Good morning, everyone. I'd like to welcome you to this beautiful venue today for our Wounds Australia Momentum one-day seminar. It's lovely to see so many faces in the room, but I'm also welcoming those that are live streaming in with us today. I've got some housekeeping just to go through, so for those on live stream, feel free to tune out. In the event of fire, we're basically following the Morphettville Racecourse staff. There's 2 exits on this floor, and they'll take us down to the main car park where we're all assembled. Our toilets are located basically either side of the bar, whether you're male or female. Our morning tea, lunch and afternoon tea will be located just behind us, and dietary requests are being catered for, and basically there'll be a small area where you'll find your special diets. We have a very tight program today and there may not be time for questions, so we encourage you to write them down if you're here in person and drop them off at the registration desk, or for those live streaming to put them through the Slido, and then we'll get an opportunity to answer them perhaps at the end of the day. If we don't quite get to that, we'll make sure that we get those questions answers out to you. In the seminar bag, if you're here face-to-face, you'll find the program and speakers' biographies. So firstly, I'd like to thank our major sponsor, Convatec, and Liz from Convatec today will be giving us a bit of a spiel on their products. I would also like to thank Braun as our minor sponsor, and thanks to the other industry present here today, because we definitely couldn't do it without the support of our sponsors. And thank you for all those speaking today. We really appreciate the time that goes into presentations. And again, thanks for everyone for signing into today. So I'm going to hand over to Convatec.
Good morning, everybody. I'm Liz from Convatec, and this is Shannon. So we've only got 5 minutes, so we just thought we'd kind of quickly just have a chat about our negative pressure and in a VEL and the differences with a VEL, and also just touch on the wound hygiene, which I know you guys have got a few speakers speaking of wound hygiene today as well. So first of all, with a VEL, it differs from the other negative pressures on the market in a few ways. A VEL is a 30-day pump life. So that means that it'll stop at 30 days, but the dressings actually come separately. So it gives you that flexibility for that 30 days. If you need to step down with the dressing size, you can. Also, it's got our hydrofiber technology, 8 layers in the interface of the dressing, and it's designed to actually work with our Aquacell, so you can pack up to 2 centimetres. A VEL also has a one-way valve here, so you can actually disconnect that to enable your patients to go off and have a shower, and if they continue to get 80 millimetres of mercury for up to an hour. So really, really great for your patients, gives them more flexibility to go and do things, and they're not always connected to, but it is very portable too, so they can go shopping, and there is a carry bag that comes with it as well. But I also just wanted to touch on the fact that we actually recently did a case study that was performed in Tasmania, and a patient with multiple risk factors had a wound for over 5 years, and multiple approaches were tried with no improvement, and we recommended that they try negative pressure. First of all, they had to use what was on contract, so they did that for 2 weeks and didn't see an improvement, and then moved over to a VEL, and they used a VEL for up to 20 weeks and saw a reduction of 40% of the wound. So they then dropped down to the Jubilee method, as the patient was actually allergic to the silicone. So they actually used Duoderm, and even with this, they used the Duoderm underneath so that the a VEL actually stuck to the Duoderm so that the silicone wasn't on the patient's skin. So, and then by March 2021, the patient's wound was actually completely healed. So after having that for 5 years, you can imagine how much that changed her life, and she was able to get out and about and, you know, sort of get back to having a bit more of a normal life. As I said before, I know you guys are talking about wound hygiene. I can't see my thing there. But so I just wanted to kind of touch today on where the concept of wound hygiene arose. It arose during an expert advisory board meeting that was convened by Convatec in early 2019. There, the international panel agreed that almost all hard-to-heal wounds contained biofilm, which delays or stalls healing, as you're all aware. This led to the publication of an expert opinion article and the development of a simple 4-step process, be sure in 4. So obviously, there's number 1 is cleanse, 2 is debride, 3 is refashioning the wound edges, and 4 is dressing the wound. Terry Swanson, a member of the advisory board, facilitated recently a 6-part webinar series on wound hygiene. The link to this series can be found on the Convatec website, or for more information on it, it's www.woundhygiene.com. So I just thought that might be something that down the track people might like to look at, and you can get CPD points from that too. Yeah. And at Convatec, we're really passionate about ensuring that people are educated about using our products and getting the best results for your patients and for you. So we've obviously put Shannon on, who is a clinical educator. So if any of your facilities, etc., are wanting any education, please contact us and we'd be happy to assist. Thanks.
Got to remember the mask. Today's seminar is focused on hard-to-heal wounds and their management. The burden of wounds continues to grow and demands are enormous on our health resources and has an impact on the quality of life of individuals. We need to do better to help our patients achieve healing. So this morning's sessions will explore why wounds are hard to heal, giving us greater understanding at a cellular level. It will also include the concept of wound hygiene and how it helps us achieve improved outcomes. The afternoon will be speed dating and present rapid sessions on specific wounds that are hard to heal and their management, and we hope you enjoy the day. So our first speaker is Sue Templeton, a nurse practitioner in wound management for RDNS. Sue is presenting on what a hard to heal wound is, and can we please welcome Sue?
Thanks very much, Sarah, and thank you very much to Wounds Australia for the invitation to speak today. I guess I get the first cab off the rank, which is good because then I get to sit down again for a little while. But I also get to set the scene, I guess, because this is hard to heal wounds, and so I guess I get to set the scene there. Okay, so I'm actually going to go through some definitions, and I'm not starting with a hard-to-heal wound. I'm starting with a chronic wound because that's the definition that most of us are familiar with and a lot of us still use in clinical practice. And that's defined as a wound that is not progressing through the expected orderly and timely healing process. If we look at how that's applied in clinical practice, that can include things such as delayed healing, no significant signs of healing in 4 weeks, which I must admit is the definition I like, because the first one really doesn't really tell you in clinical practice how to identify that something's not progressing. Or not closed in 3 months. I must admit that does come from the literature, but I would hope that in clinical practice we might identify that there's a problem with a wound before 3 months. So it is really interesting looking at the literature on this topic because there's not consensus. So there are different people who publish with different opinions. The other term that is of course used is ulcer. And if you know me, you'll know this is one of my least favourite terms, because particularly our patients seem to think that it's something absolutely terrible, when really it's just actually another definition for a chronic wound, a hard-to-heal wound. It's not very easy in the wound literature to find a definition of what an ulcer is. So ulcer is used, but not well defined. So I actually finished up going to a dictionary definition to find a term, and the Oxford definition is an open sore on an external or internal surface of the body caused by a break in the skin or mucous membrane that fails to heal. I actually thought that was quite a nice definition. Palmer went on to say that minor ulcers are shallow, affecting the epidermis, while more serious ulcers can be much deeper. So there's really, again, it's a very broad definition in the wound world. So then we get to hard to heal wound. And I think probably a take-home message is that the literature states that this term can be used to replace the term chronic wound. So really we should try and get over definitions and terminology. And different authors say, again, the same things that I've already said. Healing is prolonged, never achieved, doesn't heal in a timely and orderly manner, isn't responding to care, and again, size not reducing. So whether you call it a hard to heal wound, an ulcer or a chronic wound, the important thing is to identify and do something about it. That's the really important thing in clinical practice. So in clinical practice, what do you need to look out for? So any wound that's unhealed for 4 to 6 weeks. So this is particularly important if someone's coming into your service with a wound. So you will often not know what the progress of that wound has been, but generally if it's been there for 4 to 6 weeks, that person's probably got a problem with healing. So that's the first thing. The second thing is that no noticeable size reduction after 4 weeks. So literature talks about 25, 30%, 50%. Again, it's a bit all over the place. But generally for you as a clinician, if you're looking at that wound 4 weeks later and you can't think, yes, I can see that that is noticeably smaller, then that wound and that patient probably has a problem with healing. It can have other characteristics as well, such as wounds that are recurrent. Venous leg ulcers are a good example of that. If it's deteriorating, getting larger, people who get repeated infections, so all of those sorts of things. And of course, these are what we see in clinical practice. Wounds on different parts of the body, different causes, I'll talk more about that. But these are all wounds that have been there for some time and aren't improving. So they're a clinical challenge for us. So I know some of you probably know these stats, but I'm going to go through them anyway because I think it's important to set the scene. So globally, for every 1 million people, it's estimated that 3,500 live with a hard-to-heal wound. That's quite a lot of people. And of those 3,500, 525 of those have had their wound for more than 1 year. So that's living with an open wound or wounds for over a year. In Australia, it's estimated that over 420 people live with a hard-to-heal wound every year, and that it costs us, in direct costs, about $3.5 billion a year, and that doesn't include community. That's only hospitals and residential care. We also know, and I know I'm preaching to the converted generally, that hard-to-heal wounds certainly aren't a government research or policy priority. They're often not seen as a clinical priority. And in fact, I was having a discussion about that with a client just this week. Even where best practice is available, it's often not implemented. And to be honest, a lot of clinicians, general average clinicians out there looking after wounds, actually have relatively limited knowledge and confidence. And that's not just nurses, that's across all healthcare professionals. So we know the consequences are that lots of people are affected and all different types of people are affected. It certainly uses up a lot of healthcare resources. It occurs over all care settings, costs lots of money and lots of resources, and God, if it was only as easy as putting a Band-Aid on. And of course it has lots of human consequences as well. And most of this is all well publicised. So what factors influence healing? To start with, I guess healing is an amazing thing. It's a really complicated process. And I like this, this sort of, because a lot of if you start to look into it, it's so complex, it really does your head in. But to summarise it, orderly healing requires a complex collaboration of signalling molecules, enzymes and regulatory pathways that both activate and shut down cellular activity and the wound in its surroundings. So even if you were cutting up the capsicum tonight and you missed the capsicum and took out a bit of your finger, hopefully the bit of skin doesn't go in the cooking, but you never know, might add a bit of flavour. Even to get this relatively simple wound healed is a really complex process that we take a bit for granted. But as you know, the more complex a process is, the more that can often go wrong with it, and does go wrong with it. Although, really, it's amazing what does heal. Now, I really like and still use, as you can see, this is from the UMA document, which is relatively old now, 2008, on hard to heal wounds. But I think that their factors that they point out as an overview of the factors impairing healing are still as relevant today as when this was published. Because you've got 4 broad categories there. Factors related to the person, remembering of course that we should be looking at the person with the wound, not just at the wound. But of course there are wound factors. There are also healthcare professional related factors. And of course resource related factors. So all of these impact on whether that wound is going to heal or not. So as I've said, the mechanisms of wound healing are complex. The underlying pathophysiological cause or etiology of hard to heal wounds is very diverse. And there are multiple factors that can impair healing, as I said. And interestingly, a lot of these are actually poorly understood. So we don't know a lot about some of these things. And as I'm sure some of us have hoped, well, I'm sure we've all hoped for, and of course some of our patients hope for, is that one day there's going to be some magic pill that you're going to be able to take and do all of us woundies out of a job because they'll just magically heal. But because of this complexity, I hate to say it, but unfortunately that's unlikely, yes. I'm still waiting to be able to go to Bunnings and get a tube of biological polyfiller. That's my dream. So I can just take the polyfiller out and then put it in and it'll all be healed. I'll do myself out of a job, but I'll be very happy doing myself out of a job. Okay, so what are we trying to do in clinical practice? So basically, we're trying to identify and address and overcome those factors impairing healing to restore an environment that allows the body to heal. Because unless you have some sort of superpower, you can't heal a wound. Unless it's your own wound, of course, but you can't heal someone else's wound. All you can do is work with them to facilitate that optimal environment, but in the end, their body has to heal the wound. And that is really important in clinical practice because I think there are patients out there that think we have the healing power. We can have lots of knowledge to help them heal their wounds, absolutely, but they still have to do the work in the end. Just going back to evidence, this is really quite interesting, and certainly it's been acknowledged that there are lots of studies and guidelines and recommendations which suggest how we can manage wounds better. And in fact, that best practice wound management has been found to be cost effective and even cost saving. However, what we've found in clinical practice is that there's poor adoption of a lot of these recommendations in clinical practice, and we haven't really, in some areas, moved practice on significantly. So this is just a very, very small example of some of the documents that are readily available, and a lot of these, not all of them, but a lot of these are freely available on the internet. And some of you may not have seen some of these. I guess for some of you they might not be relevant, but these are things that can help us in clinical practice. They can also help if we're perhaps having a discussion with a colleague that might not agree with something, because these actually provide written documented evidence that's not just your opinion. So it's really handy to have some of these around the place in your clinical practice. Because in the end, insanity has been defined as doing the same thing over and over again and expecting different results. And I think sometimes we do that with hard to heal wounds. We just keep doing the same thing and hoping that the next day, the next week, the next month, sometimes the next year, that suddenly something's magically going to change. So we need to challenge that and need to do something different. So, what are the solutions for hard to heal wounds? The first thing is, as I've already alluded to, is identifying problems earlier, because we know from the literature that the longer a person has had a wound, the longer it's going to take to heal. So if you can identify problems earlier, you are more likely to have success and that person's more likely to heal. Now, we have a plethora of fantastic wound dressings on the market. And believe me, when I started in wound management, basically we had gauze, betadine, mercurochrome, peroxide, well, some of these things are still out there. And that was really about it. I can remember when the first sort of moist wound dressings came onto the market. And since then, of course, there's been an explosion. And believe me, I do not want to go back to the days of just mercurochrome and peroxide and gauze. Definitely not. But we do have to acknowledge that dressings are only one component. And quite often, not always, but quite often, in hard to heal wounds, it's going to take more than the dressing. So if you're in a setting or you're working somewhere and the solution to a hard to heal wound seems to just be swapping dressings regularly, and I've certainly seen that in clinical practice, you need to think, if you're swapping dressings and it's not working, then there's something else going on. And we need to challenge that. We also have to acknowledge that not every wound will be healable. Now, theoretically, every wound is healable if you can overcome those factors impairing healing. But for some people, there are going to be different reasons, whether they're physiological, local, environmental, that we can't address those factors impairing healing. So for some people, living with their wound is going to have to be an option. And in fact, as you know, for some people, their wound may actually be a contributing factor to taking their life, such as in a malignant wound. So there's a whole lot of things that have to happen to make that outcome for that person with a hard to heal wound. Because these aren't the wounds that you stick a dressing on and they get better in 2 weeks. These are the wounds you stick a dressing on in 2 weeks, nothing happens, or they're actually getting worse. And I'm sort of going to go through some frameworks later on, so I'm not going to go through this in any detail, just to say there's a number of things we have to do. Which leads me into frameworks. And it's really important, I think, in clinical practice to use a structured, systematic, comprehensive framework to base your wound management on. We're often not great at doing that in clinical practice, and in fact you can set up within your organisation where you work assessment tools, management pathways and tools and policies that work based on frameworks and based on a consistent framework as well. Now, then you have to choose which framework, because there are a number of them around there. A lot of them are very similar though. Remember that the framework must consider the whole person, because the wound is generally attached to a person, I find. It would be much easier sometimes, wouldn't it, if we could just take the wound off and just deal with that and then put it back on when it was healed, but it doesn't usually work that way. Usually if the wound's coming off, it's not going back on. Yes. So you've got to look at that person that the wound is on and then the wound. We tend to get very focused on the wound itself. So we need to look at that person, which is deliberately why I've ordered this in this particular order. So the person or patient, client, resident, customer, consumer, or whatever other term you use, the environment and the wound. Because certainly as a community practitioner, I have to say that that middle one, the environment, is actually often one of the biggest challenges that we face in addressing hard-to-heal wounds. So really what's very, very important is etiology and diagnosis. And those two things can be different. So in fact, if the diagnosis is venous leg ulcer, so that's the diagnosis for the wound, the etiology causing that venous leg ulcer is actually chronic venous insufficiency. So for some they'll be the same, but for some they'll be a bit different. Certainly it is well acknowledged that that failure to identify and treat the underlying cause is a main reason that wounds fail to heal and remain hard to heal. And in fact, there was a big study done in the UK a couple of years ago now called the Burden of Wounds Study. And I must admit, I do have a little bit of envy for the English health system because their system, the NHS, goes across all care settings. So they can do this sort of thing. As I don't know about you, but the increasing complexity of our health system is just amazing. So they were able to look across all care settings to do this study. And what they found was that approximately 30% of wounds had no recorded diagnosis. I actually thought that was pretty good. I actually thought that wasn't too bad. But that's the important thing. So I really like this statement, which we've just got to keep in our mind, that dressings are helpful and they're available in clinical practice, plenty of them, but even the most sophisticated of these can't be effective without addressing the underlying cause of the wound. So I'm going to just put up a few frameworks now that are from the literature. I'm not going to go through these in any detail. However, what you will find is that a lot of these have similar elements. So just talking about cause before, you'll see this framework here, treat the cause. This framework here, which is called CASE, and don't we love acronyms, and I'm about to use plenty of acronyms, treat the cause of the wound. Here again, on this framework, get the diagnosis or cause of the wound. So that's common to all the holistic frameworks as such. The framework I use in clinical practice is a variation of that previous Heidi framework. I think, in my opinion, that previous framework has a huge gap in it, which is actually evaluation. You go into interventions, but then there's actually no evaluation built into it. So, oh, I didn't think I'd hit that. That must be on a timing. I didn't think it was. So you've got your history, examination and investigations, which is essentially your assessment. Then you want to look at that etiology and D for diagnosis, and then also as part of that work out the prognosis. So is this something that's healable or not? Yeah. Put your interventions in place, remembering that interventions are more than just dressings. And of course evaluate what the outcome is. Always considering those three factors of the patient, wound and environment. And then I actually have Heidi with a couple of extra E's on the end, but I don't use them. Because really you've got to take the person with the wound on this journey. If you don't educate them and build trust and rapport with them, you're less likely to succeed and they're less likely to engage in their care. And of course the other thing is at any point get help. None of us can do all of this alone. So consider escalation or referral. Not sure why this has gone on. Consider getting some help. So wound-related factors. So now we're going to look at the local wound environment. And I'm probably going to give a disclaimer already. You're probably going to see a slide like this several times today. But that's, I guess, because it's important. Because what is happening at the local wound level is also a major reason why wounds become and remain hard to heal. So I'm sure most of us know that hard to heal wounds generally have a sustained and increased inflammatory phase. And that includes biofilm and increased bacteria, of which we'll hear more about, high MMP, so high enzymatic activity with ongoing degradation of the extracellular matrix. God, that's hard to say even early in the morning. Local hypoxia, so lack of oxygen, impaired neovascularisation and angiogenesis, so impaired repair, increased reactive oxygen species, and reduced cellular division. So all of these things contribute at the local level, and these will be discussed in more detail as we go through the day. And I know we have a presentation on biofilm, and I certainly don't want to steal anyone else's thunder, but that picture on the right there is an electron microscope view of biofilm, which I really like, because if you look at most of the diagrammatic representations of biofilm, they look like slime, and in fact I've even seen ones that look like melted cheese. There's a couple around that look like a wound with cheese melted on the top, where in fact, as you can see in this wound, biofilm's actually more like a netting. So it actually almost looks like a spider's web. So that polysaccharide matrix that joins those bacteria is not mozzarella. Okay, but you'll hear more about that today. All right, so then we look at this, what have we got to do at this local wound environment? And there are several frameworks again for managing that local wound environment. I do like to keep the whole and the whole a little bit separate. And of course we've got time, we've got wound hygiene, which will be talked about today, and there's biofilm-based wound care, there's a whole lot of different ones. When you look at them though, they're actually not that different again. So if you turn them under wound bed preparation, it's really about what I've got there. And this is a comparison between time and wound hygiene. So it's really about cleaning up the wound. And certainly if, I know some people have heard me say this, and it's true, if there was one thing that I could change in wound management to assist patient outcomes, it would actually be getting every single health professional to clean a wound properly, particularly a chronic, hard-to-heal wound ulcer. Yep, absolutely. That would be my biggest change. Using antiseptics, surfactants and topical antimicrobials, which are highlighted in green. Getting rid of anything that's not healthy. And again, looking at that edge of the wound, both in relation to the health of that wound and also in relation to whether that wound edge is reducing, because that's really reduction in size. Remembering that there are some exceptions to this. So that's why the whole person is important, because we don't want to go in sometimes doing things when it actually might make things worse. So just keep that in mind. All right. Oh, I'm actually going to finish a little bit early, I think. So gaining momentum, there's nothing wrong with that because I'm sure we'll catch that up. So gaining momentum in hard-to-heal wound management. I think the first thing is that you are here. So you're obviously interested. My goal is to try and get people that aren't interested. That's the goal. Be passionate. Access some of these documents, be familiar with them. As I said, read journals. I mean, we have a great Australian journal. There are lots of journals online, and a lot of them now are full text. Keep attending events as much as we can in this COVID world, and we're very lucky here in South Australia to be able to do this, and create relationships, and that's really important. If all else fails, one of the other things I always say is pick up the phone. You know, if you want to talk to somebody, pick up the phone. Often, most people, there are always exceptions, but most people are very happy to talk to you. And sometimes you can actually, in a 10-minute conversation, cover a whole lot of points that might have taken you an hour to write an email on. So just talking to people is really, really useful often. Share your knowledge. Impart that to other people, those people that aren't here yet and aren't passionate just yet. And give them a bit of your passion. Where you work, establish resources, a resource folder, an area where you can keep some of these guidelines and standards. You know, bring them up in team meetings, those sorts of things. Try and encourage use of systematic frameworks in your practice. even if that's just if you work somewhere where you may not necessarily have a lot of influence on organisational structures and policies, but somewhere where you think if you're going to look at someone with a hard-to-heal wound, is actually going through that framework in your mind, so that you're thinking, okay, have I sort of more or less ticked off all these boxes, and where have we got gaps there that we need to look at? As I said, escalate or refer. Don't hesitate to do that. You know, I'll certainly say in my practice, if I think a wound is unusual, say, and I think, oh, well, you know, you never know, it might be a malignancy or something like that, I would rather someone take a biopsy of that and I prove to be wrong than leave it and then it is actually something bad. And there are unfortunate incidents where that's happened. Given that I've got a little bit of time, there is actually a really good example from here in South Australia about 10 years ago, which was a coroner's case, and you can find it online, where a gentleman with diabetes and neuropathy had a previous neuropathic foot ulcer which healed, and then he developed a new wound on his foot, which was treated by his treating podiatrist, and it's just the facts, and his GP as another neuropathic foot ulcer. Unfortunately, that wound was actually a malignant melanoma, and by the time they biopsied it 16 months later, the melanoma had actually spread and he died of that. So, you know, if things aren't improving, look further into it, because that was actually on the front page of the Advertiser at the time, and none of us want to be on the front page of the Advertiser or in a coroner's court. So don't hesitate to ask. And my last three things actually, is challenge practice and policies, and things change. Unfortunately, we do have people whose wound management practices are stuck 20 or 30 years ago. We do still see them. I mentioned mercurochrome before. It was actually only in the last 12 months that a consultant plastic surgeon at the Royal Adelaide in front of me said he wanted mercurochrome on a lady's wound and that mercurochrome would fix it. And I was a little bit horrified, and I said, I can't remember my exact words, but I said, oh, she does have lots of edema. Perhaps if we actually address the edema, I tried not to be too sarcastic, but perhaps if we actually address the edema, that might help. And in fact, that's what she needed, was addressing the edema, because she had underlying untreated venous insufficiency. So we do have some of that, and we do need to challenge some of that when practice is outdated. And that's where some of those other resources can be very helpful. And certainly for the people we're looking after, I can't overestimate, I don't think, explaining and educating what's going on to people. Most people are quite smart and they really like to be involved in their care and understand what's going on. Discuss possible outcomes, and that includes being realistic. So if you do have someone with a neuropathic foot ulcer that refuses to wear their offloading and just leaves it in the wardrobe all day and probably puts it on to go to their clinic appointments so that, you know, they look really good to the high-risk foot clinic team. And then they ask you, well, how come my wound's not healing? You have to be honest with them. Their wound's probably not healing because the thing that's going to help is actually sitting in the wardrobe most of the time. So that's really, really important. Facilitate their participation in their care. As I said, they have to heal their wound, and this is really important stuff. But also advocate for them. You know, if perhaps they're not getting current best practice care, then work as an advocate for them so we can get best practice care for them, and support them and build their confidence. So, takeaway top tips. If there is no noticeable size reduction in a wound in 4 weeks, do something different and ask why, and investigate why is that. Use structured, systematic frameworks in your practice and hopefully even in your organisation where you work. Ensure there's an etiology and diagnosis for the wound, and this is treated where possible manage the wound to address local factors impairing healing, and we'll hear quite a bit more about this today, and ask for assistance from an appropriate healthcare professional. And try not to be scared of wounds, okay? Because I have to say, this is actually what a lot of clinicians look like when they're faced with a hard-to-heal wound. They don't know what to do, and they just go, oh my God, it's too hard, quick, stick your dressing on and run. And that's not really helping anyone. So try not to be a scaredy cat. Try and get in there and help that person. Because in the end, this is what we want. We want these hard-to-heal wounds wherever possible to get better. So, you know, whether it's a very hard-to-heal venous leg ulcer, whether it's a significant pressure injury, whether it's someone with neuropathy who perhaps then has had complications, whether it's something, this was actually an acute wound that should never have gotten to this stage. This was actually an acute burn on a back, so it wasn't even on a lower leg. But, well, I haven't got time for this, but this, well, maybe I've got 1 or 2 minutes. So this is a good example of outdated practice. So this gentleman was actually treated, this was probably a mid to deep dermal burn, it wasn't full thickness. He was treated by his GP with daily SSD for 3 months, and the wound was actually getting worse. So, you know, 3 months is a long time to, again, just like I said before, that insanity, doing the same thing over and over again and expecting a miracle. And that miracle didn't come, and this poor man then was left with a hard-to-heal wound that really shouldn't have ever been hard to heal. Became very hypergranulated, very recalcitrant to treatment. But in fact, and in this case I will say it actually was getting the right dressing on there. We actually managed to get that man managed to heal, I should say. Because that's what it's all about in the end, is happy people who had a wound, who were ex-woundies, ex-wounded people, rather than continuing to be wounded. And these are all my references. So thank you very much. We probably need to move on for time, but I do thank you for your attention this morning.
Thank you, Sue. I'm just also going to take this opportunity just to say, if you haven't done so already, just pop your phones on silent or off completely would be fabulous. Our next speaker is Margi Moncrieff, a wound management nurse practitioner from Flinders Medical Centre. Margi will be presenting on the concept of wound hygiene and in particular wound cleansing. Can we please welcome Margi?
If standing up here and speaking is a good time to get your mask off, let's keep doing it. So nice, isn't it? So my session is around presenting a little introduction to wound hygiene, which you've already had a little sniff of, and my focus will be on wound cleansing. So I'm going to do Sue's favourite part and be a supporter in the importance of having good wound cleansing. So I'm just going to talk a little bit about biofilm again, and you will get a fair bit of this today, but I don't think it'll hurt, because when we first learned about the concept of biofilm, we were all really creeped out by it and thought, oh my God, we all thought we were killing our bacteria with, you know, our silver dressings, and now we see that we've got something in a wound that's really stubborn, and that some of our dressings that we thought worked aren't working. And so we were really troubled by it. And then I think we've plateaued out a little bit and we've come to accept, yes, there's biofilm. And I think we've also perhaps come a little bit complacent that we're not doing enough and not honouring that it is in many of the hard to heal wounds, and it's one of the obstructions to healing. So biofilm's not new, and we've known about biofilm in the human environment for a long time. Not that a wound's not human, but just to reflect oral health, biofilm, the plaque on our teeth, that is actually biofilm, and it's a major cause of periodontal disease.
biofilm and breast implants. It's a relatively new awareness, which is pretty scary. I remember being at the plastics conference, might have been about 4 years ago, when they started to talk about this, and it was like, OMG. And it's been associated with an increase in T-cell lymphocytic infiltrate and a link to anaplastic large cell lymphoma. So, you know, for women that have had reconstruction to breast cancer and implants and then to get another cancer, it's devastating. And biofilms behind it. So we know about medical implants like prosthetic joints, shunts and catheters, that they can also have biofilm and cause no end of problems for the individual. Persistent urinary tract infections are associated with biofilm. And cystic fibrosis, we know that biofilms of Pseudomonas contribute to morbidity and mortality. And we know about aquatic biofilms, so Legionnaire's disease, Pseudomonas and Mycobacterium. So they're not new, they've been around and they've caused chaos for some time. And the consequences can include loss of implants, sickness, death, and an increase in use of antibiotics and an increase in antibiotic resistance. So when we look at biofilms and hygiene, it's really quite a fundamental practice that we all accept as being now part of our normal life and our day-to-day work. So it's a fundamental accepted concept to reduce bacteria and the spread of infection by brushing our teeth, hand hygiene and surgical asepsis, and even, you know, our wound field concept where we're reducing contamination. So we follow basic hygiene every day in our personal and healthcare life to keep clean and ward off bacteria, so we should apply the same basic hygiene to wounds. And the hard-to-heal wound is considered a battlefield associated with tenacious biofilm that is a barrier to healing. So removal of biofilm should be our primary intent. So I think one of my goals today is to bring back a little bit of that discomfort about biofilm that we all had so many years ago when we were really feeling really uncomfortable that we weren't doing enough for our patients' wounds. So I don't want everyone to be so uncomfortable they walk out and think, oh my God, we're never going to get there. I want you to be more aware of what we can do to help our patient to heal and get there. So the wound hygiene concept Liz introduced this morning, and I encourage you to download the full version of the document. It's a really great document, and it's basically our international consensus on some steps in managing hard-to-heal wounds. So the core principle is to remove or minimise unwanted materials in the wound, including biofilm, devitalised tissue, foreign debris and exudate. And the hallmark of wound hygiene is repetition. And this has significant importance when it's all right when these patients come into our clinics or our specialty areas and we perform good wound hygiene. But when we send them out into the community and to their homes and their other environments, we need to make sure we send some instructions and some educations so that everything is repeated. It's not good enough that it happens once in a clinic. It's got to be repeated again and again and again. So the steps of wound hygiene are 1, cleansing the wound and the peri-wound skin. So the rest of my talk will be about that. Debridement, initial aggressive as well as maintenance. James will be talking about that after me. And then Beck and Sarah are going to talk about refashioning the wound edges. And then Tal is going to talk about biofilm and dressings and managing the wound. And you'll notice that sometimes we are all going to overlap a little bit because the processes do, and sometimes they need to do that. So if we talk repeatedly about biofilm cleansing, wound edge, and it's in all of our talks, it's okay. So what are our reasons to clean a wound? Well, there's a number of reasons, apart from the fact that it must feel much nicer for a patient to have their wound cleaned. It actually sets the stage for biofilm disruption. It's going to remove old and excess exudate from the wound, all those crusties that dry up. Remove cellular debris, foreign bodies, dressing remnants and any non-viable tissue that might be loose at the time of cleansing. We're hoping to decrease the wound bioburden by giving it a good clean. And I put this in because I think it's important, but I need to have a clause within this when we get to solutions for cleansing, that we know that we must clean a wound before we take a wound swab, but please don't clean a wound with the solutions I'm going to talk about and then take a wound swab, because you'll grow nothing. I might talk a little bit more about that later on. It helps us to have an accurate wound assessment, so it's no good looking at a crusty wound that you've just unwrapped and going, oh my God. Go, oh my God, after you've cleaned it, because you might be surprised that it's not quite as bad as you thought it was. And I guess at the end of all of your intervention, it's going to prepare the wound for a nice dressing. So I love this statement, and Terry Swanson made it and quoted Dot Weir in saying, clean it like you mean it. And Dot Weir is one of the authors of the International Consensus of Wound Hygiene. So it's become a little bit of a mantra of mine, and I'm annoying everyone in my clinic. And when they're doing things, I'll walk around and I'll go, clean it like you mean it, girls. But it is really important. I think, Sue, you'd feel the same, that sometimes we don't clean with assertion, we anoint. As Sue often says, it's the first time I heard about anointing wounds with your saline and your wet gauze and plastic forceps. We really need to get in there and clean properly. So looking at cleansing the wound, where the international guidelines say that we should clean with as much physical force as the patient can tolerate. And I must admit, I bristled a little bit when I first read that, because it sounds aggressive. But if we could perhaps lose the concept of aggressive and make it assertive cleaning, so that it is a positive action, not an anointing action. And we need to make sure it gets repeated at each dressing change. And what we're hoping to do after our wound cleansing and with our other steps is also prevent the biofilm reforming. And we're going to select cleansing agents and techniques based on the clinical assessment of the individual. So some of the methods for cleaning. So if we're going to clean with intent, we're going to use a little gentle force as the patient can tolerate. And our goal is to loosen that superficial devitalised tissue, exudate and biofilm. We want to shake it up. So I always remind myself when I get anxious about biofilm, what do we do with our teeth and the plaque and we have biofilm? We brush them. So we clean it off by brushing. And I guess it's no different for what we're trying to achieve with our wounds. And we don't cause pain when we brush our teeth. It's assertive, and we think through it as we do it. So don't be scared of biofilm. Go in there and be assertive with it. You can use gauze and use a little bit of abrasive friction. You might use forceps to pick off anything that's loose. You might use some fibre cleaning pads, and I'll talk about those in a minute. Quite enjoying my fibre cleaning pads. And if your patient does have pain, because let's face it, not every patient can even cope with the anointing, let alone a little bit of assertive cleaning, don't forget to consider the use of oral analgesias prior to treating them, but also the use of topical analgesia. And I'll talk about that in a minute also. So there's a number of cleaning pads that have come on the market. They're either, the Prontosan pad is a microfiber structure. the Debrisoft, and I can't remember the name of the other one there, it's fairly new, monofilament cloths. And what they do is your action of cleaning, when I'm using one, I've got Enyo in my brain because I clean with Enyo, so I really understand the concept of good microfiber and how it works. But slough, necrosis and bacteria are lifted from the womb bed and trapped in the fibres of a pad. And you know, this is no different from Enyo and some of the other Zorvex cloths that are out there. When we're cleaning with them, the fibre is trapping the bacteria, the dirt, and it doesn't smear back on. It's trapped into the cloth, so it's no different. And maybe that's where the concept of the cleaning pad came from, who knows? So you can also use the debridement pads on the peri-wound skin if you've got thick scale or skin that's coated with lots and lots of lotions and creams that haven't been washed off. And it's relatively painless, so it has surprised me with some patients when I've used them that I'm using quite a degree of pressure and I'm waiting for the out and it's not happening, which is good. So I think explore some of the pads. They're out in the industry display, and you'll notice in your bag I think you have a Prontosan sample. It's not sterile, but it's to just show you what it looks like and some information on it. So just before we look at the pads, that might be down the track a bit, just looking at topical anaesthetics, I'm really lucky because, you know, I have a cupboard that I can sneak my hand into. But a lot of these are over the counter. There is sometimes a price tag to them. So LMX4 is a really, well, we used to have EMLA and then as a cost saving switched over to LMX4. So I've used both EMLA and this one. So LMX4 has lidocaine, a lignocaine, and it needs to be applied 30 minutes before the procedure. So I had a chap on the wards that was having a biopsy of his foot. And he's a jumpy Jen. He had awful ulceration between the toes and the base of his foot, and he's under dermatology. It's all right, you've seen him. And he was going to have a biopsy, and he's really hard to even clean well. So I said to him, look, I'm going to go up and get some LMX4 for you, and I'll leave some instructions for the staff to put it on at least 30 minutes before your procedure. And he was so relieved. But the staff came up, wiped it on, and then the dermatologist came in 5 minutes later and did the biopsy, which was pretty cruel because I felt like I'd led him in a direction, but really they failed to follow the instructions of the cream. Then there's EMLA, that's lidocaine and prilocaine, and that must be applied at least 1 hour before under occlusion. I've had a little bit of experience personally with these. After I had a thyroidectomy in 2007, I had a scar that was really ropey, and one of the plastic surgeons, registrars at the time, said, oh, come on, I'll just inject some steroid into it and see if we can soften it and flatten it. And that was after about 6 months. And I'm a princess with needles, and I said, oh, well, we'll need to organise that because I'd like to put some EMLA on beforehand. So under occlusion, for an hour, came along, and she did the first dose of steroid, and I didn't feel a thing. Then when it came for the second dose of steroid injected into my neck, I hadn't put the EMLA on. She said, look, don't worry, there's local in the steroid, it'll be all right. And of course I was sweating, anxious, and you know what, it really bloody hurt. It was horrible. So I made sure with my third injection that I had the EMLA on, and I truly didn't feel it. And it's not psychosomatic, I didn't feel it. So I can vouch for that. So I'm very protective of patients that have pain and that are about to undergo a procedure, that I will pull this out the cupboard and use it. Then there's Numbit and Ego have got that, I think, on one of their flyers. I don't know if they've got any samples there. That's lidocaine and prilocaine also, and that also has to be applied 30 minutes before. And I think, I can see her face, but I can't remember her name, and you might remember it, Sue, has done a literature review, one of our colleagues, interstate nurse practitioner, that found Numbit and EMLA were superior. And then I've put this in because I know a lot of clinicians will use it, xylocaine jelly. I actually don't like using it because there's not a lot of safety data on its use in open wounds, and its use is more procedural, not necessarily for wounds. But I know people do use it and apply it on wounds, but I personally don't feel comfortable. It's got a lot of other added ingredients. I've had some patients complain it stings and it hurts, so that kind of is counterproductive. So I'm not saying don't use it, but I personally can't use it just because I just have other things that are better. So I think the moral of that slide is if it's painful and you need to do a good clean, think about something that you can do topically to make it more comfortable for your patient. So now we look at solutions for cleaning the wound. So I'm focusing on 3 key solutions that have been a little bit of the focus in the international consensus paper. And they're ones that you're going to be familiar with, and they're ones that are available in Australia. So the solutions that they present are surfactant-containing solutions. They have antibiofil capabilities in vitro, and there's, oh, here we go, this will be interesting, polyhexylmethylene biguanide, that's an antimicrobial and surfactant and a broad-spectrum bug killer, and there's no evidence of resistance. Then we have octenadine, and that's a little newer on the market, dihydrochloride, and I wouldn't want to say that after having a glass of champagne. Why would I be saying it? If I'm having champagne, I'm having fun, not talking about these solutions. So it contains preservative and a surfactant to aid cleansing, and it's effective also against a wide range of bacteria and fungi. And then we're also talking about hypochlorous acid, and it's a rapid broad spectrum and can be used to loosen dressings and cleansing. And I'll go through the 3 solutions in a moment. And what the consensus paper has said finally is that water and saline are not considered effective in wound cleansing and reducing bacterial burden. And I think this is really important, and it goes back to the anointing with the saline and the gauze. It's a substance that is not going to do anything beneficial for our wounds in terms of bacteria or cleansing. It's just going to wipe things over. I think it's a really important thing. So no more do we look at this and this beautiful field when we're facing a patient's wound and all that revolting exudate. That is not going to cut it, it's not going to clean it, and it's not going to help your patient. So we need to shake up some of the traditional ways we've been doing things. That woman had the slimiest wound. We often say you can't see by a film, but you can feel it. You can feel it on your teeth, that slime. Your dog's dish that you haven't replenished the water when you finally tip it out. All the time. So let's go through the solutions that are the mainstay that are being recommended in the international document. So Prontosan is a polyhexanide, which is a broad spectrum antimicrobial, and it's also an antifungal. And it also has betaine, which is the surfactant that penetrates, cleans and loosens cellular debris. As a solution, it's that you soak it, you saturate it in gauze and you leave it on the wound for 10 to 15 minutes. And they've also just recently launched a spray, and my sense is that it's more for acute wounds, and they say you can put it on chronic wounds. And I was trying to do a quick look last night to see if there was a recommended soak time of that, but I guess you spray it and you're not going to be washing it off. The beauty of sprays is that if you've got nooks and crannies, the spray can get into all the nooks and crannies. But, you know, I'm a soaker and I saturate my gauze, and I know that my solution drizzles into nooks and crannies. But I guess it's convenient. Vascular enjoy it, and Podiatry the sprays, because their wounds are tiny and they're convoluted, so there is a benefit. But I encourage you to visit the stands and ask lots more questions about it. And then there's a gel dressing indicated for dry wounds. And I noticed on the Be Brawn website they were saying that you can use the gel as a soak. And my original learning was that the gel has a different timing of effect, and that it's a more enduring kill or reduction of bacteria, whereas the solution does it quickly but in a 10 to 15 minute time frame. So that's something perhaps we can talk to the industry about to clarify, but I always feel the gel is as a dressing, and it's for dry wounds, not necessarily wet wounds. You don't want to make a wet wound wetter. And it's like that with all gels. The general gels in wound management, we don't put them on anything moist or wet, because we make that wound incredibly unhappy and being very wet, which I'm going to talk about again this afternoon. I don't like wet. And you just need to be mindful of some of the contraindications around bones, tendons, etc. So this is a little bit of a combination. It sort of creeps a little bit into James' talk on debridement. But this is a young guy with necrobiosis lipoidica, who's a bit of a jumpy Jenny with his wounds. And I thought I want to show a couple of things here, because I use Medi-sponges sometimes too, and I quite like them because they have a little bit of a brushing action, rinse it off. So this chap had a Medi-sponge and a wash of his leg, and then a Prontosan soak. And so, ooh, that's weird. This was the gauze after a Medi-sponge, and then after a 10 to 15 minute Prontosan soak. And then I got out my Prontosan debridement pad, and I got even more off. And then the Prontosan pads that you see here and some of the loose tissue that came off were at the end of the cleaning. So it was a really interesting, he was probably one of the first chaps that I tried the Prontosan debridement pad on. So this is not a plug for one brand, this is just the one that I've been playing with at this point in time. And we use Prontosan and microdacin, which I'm going to talk about in a minute, so I'm more familiar with those two solutions. But I just thought that was a really interesting photo that visually shows you what you can achieve with the microfiber. But also, you know, look what came off just with a 10 to 15 minute soak after I'd already cleaned it. So imagine if you'd just done a saline anointing. Look what you're missing out on. So the next solution is octenolone, and it's a bit similar to Prontosan. It's a surfactant, has a surfactant action that promotes debridement and antimicrobial activity. And in vitro, phagocytosis and growth factors such as platelet-derived growth factor are stimulated by octenolone, which can be beneficial for wound healing. Has an irrigation for acute and a soak for chronic wounds. So they're recommending you can irrigate with it plus soak with it. And again, you need to just observe the contraindications. The contraindications relate to the surfactant side of it. And then microdacin is a superoxidized solution. Also comes in a spray. It's superoxidized with hypochlorous acid and sodium hypochlorite. It desloughs, has a rapid antimicrobial activity, and also has a soak time in chronic wounds of up to 15 minutes. So they also have a spray for acute wounds, and I guess it's the same concept. You know, you're going to get it into the nooks and crannies, and you're not going to rinse these solutions off. And one of their recommendations in acute wounds is you can spray up to 3 times a day. It's a lot of dressing change, isn't it? And they also have a hydrogel spray dressing that lasts up to 3 days. So again, the gels I feel are pitched as a dressing, not as a soak. So some of the other actions of surfactant cleaners They do help assist in removing adherent dressings. So the first time I used it as a removalist was in a poor child that was 3 years old that had an abscess from its buttocks, debrided and packed with gauze. They weren't thinking, were they? And the nursing staff couldn't get the gauze out of this screaming child's bottom. And so we came along and I just irrigated, soaked, made sure that the Prontosan went through the gauze into the cavity, left it, we just kept coming back, and then that just lifted out really easily. So it's a surfactant that loosens things. Certainly if you've got patients where you have foam adhesion with negative pressure and there's a little bit of pain and discomfort, irrigate it all with your surfactant antimicrobial solution, walk away for half an hour and do something else, then come out back and remove it. That's more in the acute setting, you can do that. It's great for cleaning crusted surgical incisions, and when you've got road trauma or gravel trauma, removal of foreign body. So this was a chap that I was called to see about a wound that was on his chest down here, but I couldn't stop looking at the rest of his head and thought, this is a man that was 10 days post head and neck surgery, and I thought, what part of this is okay? Who thought it was okay to leave this surgical wound that was 6 hours in the making looking like this? Why wasn't the surgeon saying, can someone clean up this wound? And why weren't the nursing staff saying, oh, that's gross, we need to clean it? And I know that I could have never cleaned that without the surfactant action of Prontosan, which is the one that we currently use, soaking and soaking and soaking to get it off. I know I couldn't have got it off without him killing me. So the recommendation from the international consensus is that we do use a surfactant antiseptic cleanser. They're dynamic, they're surface active agents containing hydrophobic and hydrophilic groups. The hydrophobic part sticks to debris and dirt, and the hydrophilic part enables it to be washed away. And the combination of surfactant and antimicrobial agents enhances the performance of the antimicrobial. It allows for more efficient debridement, cleansing and physical removal of biofilm, and you must make sure you respect the soaking times. My patients have a timer. I know, irritating. But, you know, it's no good just putting it there for a minute and then wiping it off and thinking that's okay. It's not okay. And there's evidence for disruption of biofilm. Thus far, it's in vitro, but there is definite evidence to support that it prevents the reformation of biofilm. So it's affecting the planktonic bacteria that come back and settle and start the growth of biofilm communities. So just quickly, looking at cleansing the peri-wound skin, it's recommended that we look at 10 to 20 centimetres from the wound edge. And we need to clean anywhere that bandages might have been. And if the wound is on the lower limb, clean the foot as well as the skin. You know, when these patients come in and you go, oh, that's rank, it's quite often lack of cleansing to the limb that is the smell, not the wound. So the skin contains debris of lipids, keratinized cells, sebum and sweat, and it's an ideal environment for bacteria to thrive and form a biofilm. So hyperkeratotic tissue may be present in patches or on all of the skin of the lower limb, and it needs cleaning, removal, and I believe cleaning again once you've removed it. So typically affects patients with lymphedema and chronic venous insufficiency, can be associated with neuropathic diabetes, chronic eczema and infrequent skin cleansing. It must feel awful because the pressure of those scales is tight, it's uncomfortable, it cannot feel nice for the individual to be wearing it. It can cause inflammation and itch, and bacteria and fungi reside in the layers, causes odour and can lead to cellulitis. So ideally, prevent it from occurring in the first place with good cleansing and the use of emollients. When we're cleansing the limb, use soap substitutes. Just put QV there because it's one of the examples. Using a bucket, a bowl, shower or wipes. I'm not a big advocate of wipes because the wipes have a lot of ingredients that can cause local skin reaction and preservatives doing the like. And then we need to exfoliate and debride, and we can use our monofilament and microfiber cloths to do that as well, or we might pick it off with forceps. And then once we've cleaned it, picked it, so to speak, emoliate it. Is that a word, emoliate? Put your emollients on. So this is a man that was in ICU septic from a cellulitis, and when I walked into the room it took my breath away, and I spent a considerable amount of time just on one leg and even took a photo of the things I took off. How sad's that? And it still wasn't done on that leg, and then it took me about another hour to take it off the other leg as well, and underneath were lots of little tiny wounds and the entry of his bacteria causing his sickness. So good emollients, these are just a few examples. The greasier the emollient, the more effective it is at preventing transepidermal water loss. So, pick your weapon, be consistent. So just in conclusion, step 1, cleansing. It's really important not to skip wound and skin cleansing in hard to heal wounds, or any wound for that matter. And it is an anti-biofilm strategy. We need to ensure the patient has good pain relief and has topical anaesthesia and oral analgesia if necessary. Use the right solutions as directed. Don't mix up your gel and use it as a soak, because really it should be the solution. Respect the soaking times. And if I hear I haven't got time, I'll because it's a cop-out, reorganise your time. So, if I am soaking my patients for 10 to 15 minutes, it's probably one of the first steps I do. And I go off, hunt gather, get my supplies, chat to the patient. By the time you've done all that, you're ready to do what you're going to do because your soak time's up. And remember, clean it like you mean it. I love that saying. Clean with intent and repeat, repeat, repeat. And don't forget to download the consensus document, and there's also a consensus document on the management of hyperkeratosis. Some references. No time for questions.
Thank you, Margie. Our next speaker is James Hobbs. He's a wound specialist from Wound Innovations, and James will be presenting on wound and biofilm debridement. Can we please welcome James?
Thank you. Welcome, everyone. Hope we're all learning plenty this morning. Like Sue and Margie have said, our presentations are going to overlap quite a bit, and we're going to repeat some messages throughout the day, but that's really important to get that in, because there's some really good messages already being conveyed this morning. So I'm going to look at wound and biofilm debridement methods. Okay. So again, like Sue said earlier, there's loads of fantastic consensus documents, best practice guidelines that are freely available to download electronically. One here from the World Union of Wound Healing Societies. So have a look out there. I think Margi showed a couple at the end there, and my presentation here has been based quite heavily on the Journal of Wound Care consensus document. And we've got the other things like journal articles. So there's one here, the consensus guidelines for the identification and treatment of biofilms in chronic non-healing wounds, where we had a few experts discussing best practice guidelines. I'll say, okay, so when we look at biofilm, basically this slide's showing what the difference is between, when we think about microbes, we think about planktonic activity, so microbes freely moving around a wound bed. But with biofilm, it's different. As you can see on the right-hand side there, biofilm will aggregate and stick together to form this community of microbes that then causes this film over the wound bed. And this causes many problems when we're trying to get through to the bacteria to kill them and keep them at a colonized level so the wounds can continue to heal. So the definition that is found in that Journal of Wound Care international consensus document that we've talked about is that biofilms are a complex community of different species of bacteria and fungi that causes a sustained subclinical wound infection, but can protect itself from the host's immune response, which is what we're heavily relying on in that wound healing trajectory, and it can protect itself and is also tolerant to antibiotics, which I don't think's been mentioned so far, and antiseptics. So we're coming along, we're putting our topical antimicrobials on, we're doing our cleansers with antimicrobial solutions, and that's not getting through, and it's not getting through to the planktonic bacteria that's occurring elsewhere in the wound. And interestingly as well, biofilm can reform really quickly. Within hours, it takes 24 hours to form, and then can reach maturity between 48 to 72 hours. So even when we're coming along and doing the right things in disrupting biofilm, if we're not doing it regularly, it's going to fully reform within 2 to 3 days. So we have to keep doing it. And when we're working in teams where there's lots of different nurses coming along to do that same wound in one particular week, we all have to, it's really important that we're all doing the same thing and we're working as a team. So the diagram at the bottom there just shows the life cycle of biofilm. So starting as planktonic bacteria, they start to aggregate together, and as you can see, get larger and larger, forming this community of biofilm. And then the biofilm will also release, intermittently disperse more planktonic bacteria to go and grow elsewhere. So there's a continuation, a survival mechanism that's very clever when we're talking about biofilms. So clinical indicators of biofilms. We've discussed already that it's not something we can see. Sometimes we can think there is biofilm there when we've got that slightly shiny appearance or slimy texture to the wound. But basically, this is how we've got to think about when we're thinking about chronic wounds that are failing to heal despite treatment with antibiotics, or delayed healing despite optimal standards of care. If this is happening, we've got to start to think about biofilm. Delayed healing despite optimal standards of care, like we should have a checklist with chronic wounds to go through before we start to think about other things like MMPs and biofilms. But if we've ticked off that circulation is not an issue, edema's not an issue, nutrition's not an issue, erratic BGLs, we've got all those things lined up and the wound is still not progressing, and we've debrided the wound as well from non-viable tissue on the wound bed and it's still not progressing, we've got to assume that biofilm's now something that's likely to be causing the wound's chronicity. So I like this this quotation about assuming all non-healing chronic wounds that have failed to respond to standard care have biofilm. Okay, so that then triggers us to do our debridement. We'll just go through a couple of myths versus truths. So just putting it out there, do not remove loose scales, scabs or slough as healing is occurring underneath them. Is that true? Is that a myth? Yeah, it's a myth. I think we've got most people agreeing with that one. Yeah. So slough inhibits healing. Scales and scabs harbour microbes and so must be removed to promote healing. What about wet to dry dressings provide adequate debridement for healing to occur? So that's your leaving your gauze on, letting it dry and then ripping it off to debride. Is that a thing? Okay, I think we're agreeing as well that the wet to dry method can cause substantial pain and distress, resulting in poor patient concordance or adherence to management. With wound hygiene, the wound bed can be debrided without traumatising patients and the biofilm disrupted, removed, and its reformation prevented. So what types of debridement do we have? So some of the main ones here, surgical, which will definitely disrupt biofilm at the surface and in deeper tissues. We've got sharp debridement that some of us may be able to do if we've undertaken a debridement course, and that might be using a curette, dermal curette, scalpel, scissors and forceps, and this will disrupt biofilm. Larval debridement is one of my loves. Margi's called me the maggot man in the past. Coming from the UK, where we used to use larvae quite a lot, and I've managed to do it twice in Australia. So I'm like really proud of myself for that, because it's not an easy process. Got to ship them over from New South Wales, which might be a bit of a problem at the moment. Also known as biosurgery or MDT, so maggot debridement therapy. There's good in vitro evidence at removing biofilm. Ultrasonic debridement can destroy, dislocate, or physically modify tissue and biofilm. And then mechanical debridement, which is the one I really want to focus on because we can all do this, has some evidence of disruption and biofilm removal. So mechanical debridement pads, which we've touched upon this morning, there's actually 4 different ones out in Australia now. I've only discovered the new one this week from Sean, who's here today, who was very, very savvy in contacting me this week and letting me know. So we've got L&R's debridement pads called Debrasoft, which were the first to the market. And as you can see, you've got the different shaped debridement pads there, including the lolly that is good for cavernous wounds. We've got Essity's DebraClean, and you've got the darker lines at the top there which it's basically a bit more rough, and we'll get through a more stubborn, non-viable tissue. You're also soaking these pads as well in an antimicrobial solution. Biberon's Prontazan debridement pad. And then the new boy on the block, the Alprep from Coloplast. Thanks to Sean. So 3 of these guys are here today. It's just L&R that don't have a physical representation in South Australia. But the last 3 there, we've got the reps there, so visit the trade displays and speak to them about these debridement pads. So this is mechanical debridement that we can all do. But if we've not got access to these debridement pads, because they're usually costing, through the stockists, we're talking between $15 and $25 each. So it's not going to be always readily available. And as I'll talk about earlier, we need to be doing this mechanical debridement sometimes for a long period of time, every couple of days. So the cost can add up. So we've still got our gauze debridement method, okay? So we soak the gauze in the antimicrobial solution. And then this is what I like to show people about being able to get more purchase when you're using your gauze and your forceps from your dressing pack. So you're basically, with one hand, laying the forceps down on the flat piece of gauze. With your other hand, you've got the other forceps, so then you can start to tuck in all the corners, so from the side, from the top, and then the other side. So you end up with this gauze wrapped around the forceps, and you can get more purchase. Basically, a smaller surface area is going to create more pressure. Again, as Margi said, as long as the patient's going to allow you to put that pressure on, but you can get a lot more purchase doing it this way. So we can still do some good mechanical debridement even if we've not got the access to those 4 debridement pads that I talked about earlier. And so pre and post debridement, this is what we should be doing. Before debridement, the wound should be cleansed with an antimicrobial or pH balanced surfactant solution, and knowing your soaking times, because they are different for different solutions. So knowing how long your minimal soaking time is really important. And then doing your debridement, mechanical debridement, getting into all the nooks and crannies. The pads, they sort of say you're doing circular motions, applying a bit of pressure as well, as much pressure as the patient will allow you, and doing that for 2 to 3 minutes on the wound bed to try and start to lift and break up the non-viable tissue. And then after the debridement, the wound and peri-wound skin, so not forgetting the peri-wound skin, we have to keep that clean as well, because we can get migration of microbes onto the wound bed post cleansing, if we're neglecting the peri-wound skin, this is going to reform quicker. So the wound and peri-wound skin should be rinsed, ideally with an antiseptic solution, or cleanse, even better, do another cleanse, but at the very minimum, do an irrigation and a rinse, with, again, the antiseptic solution that you've used prior. And to avoid contamination with surface, ideally with an antiseptic solution, in order to avoid contamination with surface microbes and to kill bacteria that have been exposed by that procedure. We've loosened, we've disrupted some of the biofilm, so we're going to get more microbes escaping again post-debridement. So this is the post-treatment to get some of those little nasties dealt with as well. So if we're doing this every couple of days with our chronic non-healing wounds, we should start to see some results. So this is just an example of a patient I see in the community. This lady's got a venous leg ulcer on a left lateral lower leg, 7 years old. This is actually after 2 weeks of actually doing this debridement method with a debridement pad as well. And this is how it looks every time we go back to the wound. So the wound was a lot sluffier than this at the beginning, but at this point we've de-sloughed it a lot. But I like this photo because you can still see a little bit of sheen on the wound bed. And when we're debriding with the pad, we can feel that it's still a bit slippy. And this is just after 2 days of it being dressed. So the biofilm is definitely reforming every couple of days. So this is before we even debride it. We've just taken off the dressings. And then post-debridement, it does look cleaner. I hope you can see the subtle differences. I'm using this example because it's all good showing the lots of slough pre and hardly any slough post. But this is a non-healing chronic wound that's 7 years. It's colonised God knows what inside it, and it's really made a happy home for itself. And it's going to take a while is what I'm trying to say. It's going to take weeks of doing this to really start to get things going. Up to speed, we're sort of 8 weeks in, and we are slowly starting to see some granulation, some healing occurring, and some contraction of the wound. But it's taken 8 weeks of this debridement to get through this biofilm that's, has been there 7 years. So I like to add that in. And so, just to say as well, so afterwards as well, when you finish doing the debriding, you can feel the difference in the texture of the wound bed. It's a bit more grippy, and that slippiness has gone. And it's just positive reinforcement that we're doing the right thing. So the take-home messages, basically, we've got to assume all slow healing chronic wounds have biofilm in them. We should be using antiseptic cleansers, followed by mechanical debridement, and then cleansing again, or irrigating, but cleansing would be great to do afterwards. Repeating every 1 to 2 days until normal healing rates are seen. So I just go off roughly 30% reduction in 4 weeks, and I'm happy. Whether that's 30% reduction first in wound depth, and then 30% reduction in wound surface area, which is a simple calculation to do. If we're hitting that sort of area beyond 30% reduction in 4 weeks, then we're on track again. And that we should be debriding all non-viable tissue, scales, scabs and slough. Okay, thank you. So we finished a little bit early, so I can take some questions if you like. Is that okay, Sarah? Yeah? Or if we've not got any... Yes. Are you just yawning or are you asking a question?
Thank you, by the way. Very interesting. I think it's great that it's all the repetition that we need to be doing, particularly with the cleansing of wounds. In my experience... Oh, thank you. Oh, that sounds terrible.
You've got the floor now.
Oh, gosh. Can I start again? No. Oh, thank you, by the way. I think it's great with repetition, particularly with cleansing of wounds. In my experience, I do a lot of house calls, domiciliary work, and the district nursing group that go there often are quite, I don't know if it's by intention or otherwise, but there's always seems to be a different person that does the work. And also, when you're trying to repeat something, I find that if it's not the same person doing it, there's always a chance of issues there. Is this something that should be looked at?
Well, absolutely. I'd say this is the number one issue we've got in treating chronic complex wounds, is consistency of care. I think you've nailed that. That's, I don't...
Respond to that?
Go on.
Yeah. As someone that actually works for RDNS, I do want to respond to that because it does sound a little bit like a criticism. And I do just want to say that employers these days often don't have much choice but to take people who want to work part-time, casual. So whilst it would be lovely to have a workforce where we had staff that worked full-time 5 days a week, so you could get the same person in there every time, unfortunately that's just the workforce issues that many of us are facing. So I think what we need to work at, and look, don't get me wrong, I don't doubt you about the same person making a difference and being invested. However, sometimes you can come across staff of any clinical persuasion that can be the same person going in there that's not invested. Just because it's the same person doesn't mean they're always doing the right thing. And I think we need to move away a little bit because of these workforce issues and differences, really to doing the right thing, that if everyone's doing the same care, even if it's not the same nurse,
it shouldn't actually make too much of a difference.
Yeah, it's the consistency of care is the key issue, and it doesn't matter if it's different nurses, the same nurse. It has to be consistent. And I think that's the biggest issue that comes out of it. I hear a lot from patients in the area I work in, aged care facilities, is that different nurses will have their different ways of doing things. So I understand what you're saying, but we're always going to get different nurses following on, and that shouldn't be seen as a negative, but it's the consistency of care. I feel that's the thing we need to get right.
I'm going to add something to that because I work in the acute setting, and same deal. You'll get a different nurse doing that wound care. And I think the way I get around that is really clear, explicit instructions that are step by step. And in the community, I give my patient also a copy of the instructions, and I tell them they're the boss. You oversee what your nurse is doing. And so that you're not irritating, you say, this is what Margi has asked for, so I'm the irritating person. And I find that is something that is really effective and works. But it takes a little bit of extra time, but I want that care and I want it to be consistent. And the real world is not consistent, so we've got to work the best way we can around that. And that's something that works most of the time for me.
Thanks, Margi. Got a question at the back, John? You have to use the microphone. We want to hear your voice.
I'm sorry, this is a bit of a silly question, but what are the antiseptic solutions that you use afterwards?
The same one that you used before.
So you just use that again? Oh,
yeah.
Okay. Thank you.
That was easy.
I would like to ask one question, with the normal saline and water we just mentioned, it's very ineffective. So are we guys all using that Prontosan or whatever solutions are mentioned here, or because they can be expensive in an aged care setting sometimes, and they're specifically when we do it some chronic wounds, then only we use them. So I just want to know that whether normal saline is being taken off from all settings, or just we can still use them?
We're talking about non-healing chronic wounds today, and that's where we do need the antimicrobial surfactant solutions. Normal salines, we're not saying don't use that ever, but usually that would be more in a healthier acute wound, but a chronic complex non-healing wound, we really need to be assuming there's biofilm. And are they that expensive? I didn't think that there was 20 bucks for a bottle of, compared to sachet saline, but it's that cost-effective argument, isn't it, that's going to come back.
But you can buy a bottle and multi-use it as long as you don't contaminate it, and it has an 8-week shelf life. So a bottle is actually more cost-effective than sometimes the ampules, which I find I waste half of.
Yeah.
It breaks my heart. But you buy a bottle, and as long as you do not contaminate it, you can use it in, you've got to keep to your rules though, use it in multiple situations repeatedly.
So we can also consider about human cost as well.
Yeah.
So if you use that, the anti-biofilm, surfactant, if the wound is healing earlier, the quicker, so we can save the human cost in or the material costs as well.
Yeah.
I think it can be make it up.
Yeah.
All the cost, the total cost in overall.
Exactly. Yeah, and that's the conversations we need to have with people that may be blocking these solutions because of an expense concern. I think that's the conversation we need.
Use the evidence. If you're appealing and
work environment, I'm pretty loud anyway, if you're appealing to your work manager to get these solutions on board, don't let it just be your voice. Pull out the international consensus document and the evidence to support it, because they're going to be a bit uncomfortable if they read that and turn around and say, no, I want saline. So, you know, you can be behind some of the evidence that supports the use of these things, so you get the things that you need for your patients.
Maybe last one before we have morning tea.
Just with regards to cleaning and preparation, I'm not sure if there is at the moment. Is there any tutorial type work where people can see it in action and visualise it or even try it? For example, if you've never used these products before or had people do the wound healing and preparation.
Yeah, I mean, we've got YouTube with some amazing videos out there. So the industry will all have YouTube clips of how you use the debridement pads, the cleansing, whatever's, you know, we've got a wealth of that out there. Does anyone else want to add? Cup of tea? All right, thank you.
Thank you, James. And like a good opportunity for morning tea to go ask those trade displays more about their products, you know, looking at their pads, etc. So we've got 10:45 to 11:15 for morning tea. Should all be ready straight behind us, and then we'll meet back here for 11:15. Thanks, everyone.
What's the matter here? I'm waiting, son. Waiting on Roosevelt. I'm waiting on Roosevelt. The rent was due and the lights was out. I said, tell me, mama, what's it all about? We're waiting, son, waiting on Roosevelt. Just waiting on Roosevelt. My sister got sick and the doctor wouldn't come because we could not pay him the proper sum. Awaiting. House, Ma empowers me what's hungry and cold done stop believing what they've been told by Roosevelt. Roosevelt. 'Cause the pot's still empty and the cupboard's still bare, and you can't build a bungalow out of air. I'm tired, Mr. Roosevelt. I'm tired. Oh,
Okay, welcome back. Hope you're all refreshed and ready for some more information thrown at you. Before we commence this next session, we wish to announce the 3M and KCI award winners. So to do that, we've got Odie and also Meredith and Amanda. Odie is the Senior Regional Sales Leader for 3M, looking after both the MSD and negative pressure portfolios. Odie came across to 3M as a result of the KCI acquisition and has recently returned home to South Australia to be with his family. So please welcome Odie, Meredith and Amanda.
Thank you for the introduction. So, Kate and Damien have worked tirelessly to reduce the occurrence of wounds, particularly pressure injuries, and improve wound management across 17 residential aged care homes in South Australia and the Northern Territory. The Wound Champion program was created in late 2018, and each resident home has a nominated nurse who is the go-to clinician for wound management and healthy skin promotion. They liaise and network with other champions and refer particularly complex wounds to the internal wound specialist team, Kate and Damien, who review remotely and make suggestions for possible treatment regimes. Kate leads the Wound Champion program by fostering a culture of critical reasoning amongst nurses to achieve better outcomes for the residents. She works closely with Damien to monitor wounds across the organisation via the master wound list created in consultation with Wound Champions. The winner of the 3M Skin Integrity and Wound Care Awards is both Kate Uyghur and Damien Lay from Southern Cross Care, South Australia, for their Wound Care program. Please join me in congratulating Kate and Damien.
Congratulations, Kate, on the job well done. We're very proud of the organisation. Congratulations. That's for you. Yeah. Thank you. Thank you.
Did you want to say a few words? Of course you do.
You want to have yours?
No, you.
Oh, you can.
Happy Friday. No, look, it's a very lovely honour to win this award, and I think it speaks really well to the work we've done over the last 2 years. We've built up our wound champions and really worked heavily with all our staff, whether it be our nurses, our care staff. This is really a testament to everyone across our sites. We've got 17 residential sites, and ongoing education and support and ongoing mentoring. And Damo's not one for many words, but we really are a great team. So it's been a great few years. We've been able to reduce our facility-acquired pressure injuries in 2019 when we started capturing. In end of September, we had 85 facility-acquired pressure injuries across our 17 homes. And at the end of August this year, so just under 2 years, we had 20. So we've been calculating that at the end of each month. It's been a slow burn. Last November, we were still hovering around 30, and we were really, really keen to get into the 20s by December, and then we were down to 19. So it's something that we really work heavily on. And, if there's an increase 1 month, it's not about punishment, it's not about performance management. It's about exploring the why and how can we risk mitigate and how can we use this as an education piece. So really supporting our nurses and promoting healthy skin and to be better for life, and that's what Southern Cross Care are all about. So thank you so much, and thank you to Damo and all our wound champions. So the money we've already got planned. We've got a big wound forum being held next Thursday, where we're going to do everything about skin promotion, healthy skin promotion, basic wound management, really focusing on the cleansing of wounds and some lower limb assessment and continence promotion as well. So thank you so much.
No worries, congratulations.
Okay, next up, we've got Rebecca Daebeler, lead podiatrist at Flinders Medical Centre and a good friend of mine and a lovely person. She's gonna be presenting on refashioning of the wound edge. So please give her a warm reception. Beck.
Step one, I did make it up without tripping, so that's great. I was actually meant to do this with Sarah Christie, but we'll give her a reprieve because it's actually her birthday today. So happy birthday, Sarah. I've been given the honour really to talk about the E-bit, the wound edge, and again I'd like to reiterate that there is a lot of overlap between the talks that already happened and obviously talks that are going to happen consequently as well. So I guess one of the frameworks that Sue's been talking about are the time principles. So really looking at tissue, infection, inflammation, moisture balance and edge of the wound. Now this is a concept that was put together in 2004 and again reviewed in 2019 with the timers principles. So there's a little bit of an acronym expansion there. So for those that use EMR, we're probably very familiar with acronym expansions. So after the wound edge, it's looking at repair, regeneration, and the social and patient-related factors, which is absolutely vital when we're looking at wound healing and wound remission. And then we have time, the time principles, and including clinical decision-making tools within that as well. And a really big one for us, Sarah and I both work in a high-risk foot service, time is tissue. So the longer it takes for that referral, the outcomes for the patient tend to be more detrimental and the risk of amputation then is a lot higher. Again, this is a figurative framework for time. Again, looking at that tissue or non-viable within the bed of the wound, managing and looking at those infection or inflammatory factors, looking at that moisture balance within the wound. Again, very wet wounds are some of Margi's challenges, and most of our challenges too, with our community nurses. And our challenge really sometimes is looking at the edge of the wound, which is non-advancing. So what's all the fuss about? We're talking about the wound edge. So wound healing actually occurs when those epithelial cells actually migrate across the wound bed to cover the wound surface. So in order for that to actually occur, the wound edges must be moist, so getting that moisture balance right, so not too wet and not too dry. Obviously needs to be intact and attached and flush with the wound base itself. So monitoring these epithelial margins assists with management to optimise wound advancement and ultimately wound healing. The tricky bit then is that nurturing afterwards to maintain wound healing, and a nice phrase in which we're sort of looking at in regards to managing diabetes and foot wounds is how do we maintain wound remission, because it's very much like cancer, it can recur. That recurrence is very, very common. And obviously assessing the wound edges provides how much information we're requiring and revisiting the etiology and the reasons why, how the wound's progressing and whether current management's actually effective. So sort of reviewing what we're actually doing. Are we getting anywhere? Are we getting wound advancement there? So common problems really include in maceration, so that wetness around that peri-wound area and the moisture contents imbalanced, dehydration where it gets crusty or that desiccation gets dry, undermining, and looking at those rolled edges, which is quite common when your wounds have been there for some time. So when we're looking at the ideal wound edge, what does that mean? So basically when those wound edges are contracting and pulling together and we've got that migration of those epithelial tissue cells and moving towards the centre of the wound. Again, it needs to be flush with the wound bed, it needs to be moist and open with an epithelial rim, and it's often that pale pink or translucent colour. Pretty important thing, and revisiting that, is the reasons why things are there in the first place and identifying those risk factors. So a really key point is that wound bed preparation, which all of our speakers beforehand have gone through, and that's really the key to get that epithelial advancement and that wound contraction and healing. And it's very, very important to assess that wound edge and the need for debridement. Most of you probably know that podiatrists like to debride. We like sharp things, we love sharp tools, and we often make things look a little bit bigger, and this is one of the reasons why. And wound edges that are rolled and calloused over are really some of the key pointers into why wounds aren't actually advancing. So non-advancing wound edges, it can be associated with hypergranulation tissue at the wound edge, and I think there's a talk about that a little bit later on this afternoon, and that speed dating sort of scenario that we're going to hold. That hypoxic environment, infection and desiccation, that drying out, senescent cells, that inability of the cells to actually divide and proliferate, and the undermining. And this is a really important part of our wound assessment, is looking at the undermining. So what you actually see is not always what you get, or the actual size of the wound. So those wound edges really need to be assessed and documented. And I think it's probably bringing back to the comment around, I guess, consistency. Documentation is a really, really vital part for the next person taking over. And again, having those frameworks in place. I think if we've got really good frameworks, that then helps provide the consistency of care. And if we're documenting things as well, because if you don't document, hasn't happened. So some of the considerations, obviously we need to we need to consider the wound depth and the wound size. And that includes the width, length, and how deep it actually is, that 3D approach. Looking at the nature and duration of the wound and the underlying etiology. And I think it's really vital for us to start asking questions, the why. Let's get curious about why something's not improving, because the signs are there for us to be picking up on. The wound is telling us it's unhappy. We then need to figure out all those intrinsic and external factors that can affect healing and start to address those with the patient. And they're actually essential and key to this. Obviously, looking at those psychosocial factors, accessibility, the environment, that was a really big one that Sue brought up, and that adherence to management, that can always be a little bit tricky. I say to my staff, it's sometimes about giving patients options to make safer choices. They might all make the choices that we agree with, or an evidence-based practice sort of model, but it's about providing safer choices for them. Again, when the offloading's in the cupboard, let's have a look at the reasons why it's in the cupboard, because I think sometimes people think we might be a little bit silly, and actually your wound's actually telling us you're not wearing your offloading because you've got a whole heap of callus that takes 4 years to debride. Again, the wound's telling us exactly what's going on. Addressing high levels of exudate, it's really, really important to be managing the exudate levels and get that moisture balance right. Addressing biofilm, we've had a fantastic talk by James around sort of biofilm and that introduction with Margi, very, very important. Obviously addressing infection and managing that inflammation and that bacterial balance, and managing all of that non-viable tissue around peri-wound, but also in the wound bed. So wound margin should be debrided as indicated by hyperkeratosis, so that build-up of hard skin and callus, or that devitalised tissue. We need to consider the maceration, dressing traumas as well, hypergranulation within the wound bed itself, and looking at protecting that wound edge. So those fragile epithelial cells migrate across the wound more freely and remain viable longer when the wound is free of desiccation and crust formation. So this was actually written up in 1962, so it's not a new concept. Probably taken us a while to cotton on, because that time framework sort of came across sort of early 2000s. So epithelialisation of a wound occurs more rapidly in a moist environment, so getting that moisture balance right. And obviously, dressing should prevent further trauma and minimise the risk of infection and optimise the wound environment. So taking care, taking dressings off, and taking care, putting dressings back on. It's almost getting the recipe right, really. If we get the reasons why something's there in the first place, and the wound's telling us what it actually needs in regards to addressing and putting all of that together, it makes it a little bit easier to look at moving forward and towards wound healing. The patient's absolutely critical. They do the healing, we help facilitate. So when the desired outcomes and timeframes are not met by the patient, I think it's really important to consider linking them in with a multi-D team. And I think one of the beauties of COVID, I'm not quite sure it's a beauty, but I guess one of the really positive outcomes is looking at how we can do things differently, and telehealth is one of those. So, if we're looking at rural and remote areas, even some community members or people in hospital, in aged care facilities that can't actually get to places, it doesn't mean that we can't link in. So I think there's been a growth in the use of telehealth, and I think it's something that we need to be considering and doing a little bit more and learning to get a little bit better at doing it. And obviously integrating the patient's need into the management plan. So healing might not always be the outcome for some of these patients. It may be around sort of managing things, preventing deterioration, preventing infection and managing that. So they're actually crucial. So I guess a big part of all of us is actually addressing the wound environment, and we've sort of seen already that those chronic wounds differ biochemically from acute wounds. Chronic wounds are complicated by local ischemia, necrotic tissue and heavy bacterial loads. And that continued recruitment of macrophages and neutrophils actually fosters a prolonged inflammatory response. So these wounds sort of get trapped in that chronic inflammatory phase, and they produce excessive inflammatory cytokines and matrix metalloproteinases. It's much easier to say MMPs. So the balance is a bit out of whack. Again, that noxious environment, it's not very friendly, sort of perpetuates that cellular senescence and that growth factor deficiencies and faulty receptor site function and poor cell proliferation, if I could enunciate properly. And so by addressing this abnormal wound environment, we use things like debridement, wound bed preparation, controlling infection and inflammation, moisture control, and excising wound edges and peri-wound callus when that's actually appropriate after we've done a thorough assessment. And part of that thorough assessment is actually doing a vascular assessment to make sure that their perfusion's adequate. That's a really, really important point. So the rationale behind sort of wound bed prep and debridement is actually to prepare the wound bed and to change the wound physiology. So it's to sort of knock things up a little bit, give them a little bit of a shake-up. So it's remove the non-viable tissue, the MMPs, biofilm, and excising the wound edges and peri-wound callus to stimulate the production of growth factors and also to remove that bioburden. I don't know if some of you have seen, there's like an ultraviolet light. I think it was a tool that Smith and Nephew had that was sort of light up where all the bacterial growth is. It's quite interesting around the peri-wound area, just lit up like a Christmas tree. So that's a really important factor, again, for us, is about removing that sort of hyperkeratotic tissue because it's a nice carrier for bacteria. I know James has gone through this in regards to conservative sharp wound debridement guidelines, but it's important to get your multi-D team involved. It's also very important to understand the relevant anatomy and tissue structures. Obviously, your patient assessments first and forefront, making sure they've got adequate blood supply. Are they feeling? Are they not feeling? I think that's probably a beauty, unfortunately, of some of our work is the fact a lot of people don't actually have feeling in their feet, so we can get quite assertive when we're looking at preparing a wound bed in the peri-wound area as well. And, that ability to identify what's actually healthy and what's devitalised. So these are some methods of debridement that James has already gone through. We're going to concentrate a little bit on the sharp and the sharp debridement. Obviously with podiatry, offloading is a really key part because we're dealing with foot wounds. And it's offloading modalities and devices are really important for us to look at how we can reduce foot pressure points, especially on the bottom of the foot. And sometimes it's about loading where we load the foot to take the pressure off. It's really important for prevention and maintaining wound remission as well, and it's obviously a really important factor for looking at healing and moving forward with wound advancement. So there's been a couple of studies. Young demonstrated that debridement of hyperkeratotic lesions reduces peak pressures by about 26%, so that's almost a quarter just by doing a physical debridement of that peri-wound area. And SAGE has also demonstrated that the frequency of outpatient visits and other foot care interventions were correlated with the occurrence and severity of ulcerations. So again, that's one of the beauties of us working in a high-risk foot service is that we can get people in quite frequently, so we can do that debridement, and again it's about helping with that biofilm, that bioburden, reiterating how to use their offloading devices and the fact that they should be wearing it as well, not just into their appointment, because we know that happens too. You know, it looks brand new, like there's no dog poo on the bottom. So this is a couple of studies really, looking at what sort of evidence we actually have for reducing callus. So, you know, I guess some people say just leave the callus there, it's to protect the person or protect me. But if we actually leave it there, it actually increases those peak pressure forces on the bottom of the foot. And again, it's also about that bacterial bioburden that just sort of sits there around the wound and obviously within the wound as well. And we know that both direct pressure and cumulative stress on tissues will lead to, you know, a neuropathic foot wound. I think the paradigm shifted a lot for us, and when we're looking at diabetes and foot wounds, probably 10 years ago, we used to see a lot more sort of purely neuropathic, so they don't have feeling in their feet, it's a traumatic event, or, you know, they get a build-up of callus and that focal pressure sort of breaks down underneath. It's more sort of neuroischemic now that we're seeing, so it's a combination of people not feeling, having a sort of an unknown injury, and they're not having adequate perfusion to get things healed up. So again, that's why it's important to be looking at that team structure to make sure we've addressed all of those you know, factors. So callus removal in the studies by Peter and Pataki and Davis supported that removal of callus in patients with diabetes significantly reduced plantar pressures, and it might suggest that callus causes elevated pressures. And obviously you can see there with the Woodburn study that they didn't actually find you know, a significant difference there with reducing callus and plantar pressure areas, but that probably was due to the fact that around sort of foot structure and biomechanics, for the sort of looking at bony deformities and bony prominences underneath the foot. So, again, this is some of the things that we do to sort of look at where we can get to the edge of the wound, because if we keep, I'm going to see if I can do this. Here we go. So if we sort of have a look at the wound there, and if we were sort of, you know, to go in and just sort of say, okay, well, actually, this actually looks like the wound edge here. But after the brow, we can actually see that's actually quite a large area, and it's quite unhealthy and quite wet around that area there. A lot of this is actually a transmetatarsal amputation, so basically a stump at the end of the forefoot where they've had their toes and metatarsal heads taken away. It's not uncommon for us to see this type of tissue there, sort of verruca hyperplasial tissue, and it's sort of due to that shear and stress on the stump basically. So this is actually an offloading issue as well. And again, you can see how it's shelved a little bit through here. I'm not sure my hand-eye couldn't find motor coordination's very good here, sorry about that. Yeah. But again, you can see all of this area here is really sort of non-viable, and that's, you know, that can often be quite odorous as well, because that moisture just sort of gets trapped there. And then you can actually see what you're dealing with and can do a reasonable assessment after you've cleaned all of that up. But it doesn't look like a particularly healthy wound base there. This slide has been used for a number of presentations because it's just such a cracker. So this is actually an inpatient that we had. Again, you know, just slapping a dressing over this is really not going to be very beneficial. You can have a look at the wound base here. You know, there's some slough, some granular tissue, lots of callus, a bit of dog hair, a bit of cat hair, a bit of not sure what else is in there. But obviously mechanics are a bit of an issue for this person as well. So very simple, clean it up. Then we can actually see exactly what we're dealing with. So we've got a nice sort of healthy granulating base. We've cleaned it up, given a nice sort of wound bed prep there. We can actually see the margins of the wound there, which is going to help and assist with that epithelial migration across the bed of the wound, help that wound contraction and healing. So I thought I'd just go through a little bit about the role of the high-risk foot service podiatrist. So obviously our core business is really looking at wound assessment and management, wound bed preparation and debridement, infection management. There's probably half of our team within Flinders and we partner a lot with our orthotic and prosthetic colleagues too, to try and get the best approach for our patients, and obviously getting them involved as well. We do have the luxury of referring and working with our medical, nursing and allied health colleagues, and very quick and rapid response when things are needed to be escalated. We're quite lucky at Flinders. We have a direct admission pathway with the vascular team that's been developed over many, many years. So it's really looking at an ED bypass model, so patients don't have to go to emergency. If they present to podiatry, we can then escalate their care and make sure that they're at the right place at the right time with the right people. Obviously, we work across acute and subacute, so some of it may be, yes, we get the wound to remission, but it's how do we keep it there? We want to try and prevent recurrence, so that monitoring and that surveillance is absolutely vital. A lot of our patients undergo, several angioplasties, so open the blood vessels up in their tibial vessels. They can shut down quite quickly, so part of our role is to actually make sure they might have palpable pulses after they've had a reperfusion procedure. Can feel pulses, and then all of a sudden you can't, and the wound stops advancing. That could be one reason. So that's part of our job as well, just to surveil those patients and keep a very close eye on them. And obviously footwear prescriptions are a really important part of what we do as well in regards to recurrence prevention and wound remission as well. So that's some of the things that we get presented with on a regular basis. I'm done.
Thanks, Beck. That was excellent. Thank you very much. Our next speaker is Tal Ellis, who is the Wound Clinical Practice Consultant for the Barossa Hills and Fleurieu, as well as a Board Director for Wounds Australia. He's a great speaker, really dynamic. I'm setting you up to fail now, Tal. If he's had a beer or three, even better, but I can't promise you that. You're going to get a good talk, whichever way. So please welcome Tal to the stands.
Yeah, thanks for that. Right, so a couple of things. Firstly, I'd like to acknowledge the land on which we meet today. Of course, this is the Ghana land, the Adelaide Plains, and the elders past, present, future and emerging need to be acknowledged. There is a direct and continuous lineage associated with the cultural relationship of Adelaide, of the land that we live on and work in, and it's really important that we pay respect to that and that we also acknowledge it, because for those of us who have worked a long time with Aboriginal people and have been taught the lessons, it's extremely important that we go forward acknowledging the pain and the suffering and the legacy of the things that Aboriginal people have gone through, and that they are relying on us for understanding and for support and assistance as they move things forward. They don't need us to do it for them. But I just wanted to do that because we didn't do that at the beginning of the day. So if it's cool with everyone, I'll just raise that issue now. So it's very, very important. Okay, so I took a lot of licence with my talk, realising that solutions and dressings are going to cross over pretty much with what everyone else has done. So if you forgive me, I'm going to do some repeats, some, no pun intended, but some rinsing, and also hopefully was add in some new things. I don't talk a lot about dressings. Dressings for me are fundamentally things for consideration, and it's a sort of almost like a person by person type thing, but I am going to mention a few things today. The other thing is that with other stuff that's going on in my life, I've done a lot of listening recently to a whole bunch of really weird stuff, you know. So Christopher Hitchens, who speaks a lot about atheism and just theism and deism and that sort of stuff. So they have been speaking a lot about, you know, special books to them and the things that they like to read from. So I'm going to do a couple of readings for you before we start today, which might seem a bit weird, but my readings are coming from the Book of Dad Jokes. And the reason that I like to do these is like, yeah, I love to tell cheesy jokes, but my friends are lactose intolerant. Exactly, see, this is very good. Or my osteopath gave me one the other day and she said, I took the kids to the zoo and we had quite a nice day. We went to see the lions, the monkeys, the tigers, but they only had one dog. It was a Shih Tzu. Anyway, so let's move on from that. All right, see, have I got that out the way now? See, it actually really helps to do that sort of stuff. So I'm going to talk about dressings and solutions to biofilms, and I've made it really specific, and I really want to raise some issues. So these are the sort of people who I'm typically seeing. I want to tell you a little bit about this lady at the end of the talk, so I'm not going to spend a lot of time now, but this is really typical. This is everywhere in the community. We are seeing people like this all the time. And I also acknowledge our earlier questioner, sorry, I didn't catch your name, that our inconsistency across our industries is quite remarkable, and that does, given that we have this biofilm model that we're all working towards, have a significant impact on our clients. Now, this lady stuck there for 3 years. Do you know how she was treating her wounds? Because she'd been treated for 4 or 5 years prior to that, going in and out of hospital, etc. Do you know what she was doing? She was sitting in the bottom room of her house, having lost all of her friends because she smelled, and she was literally having 7 or 8 showers a day and sitting with paper towels wrapped around her legs and towels on it, on the floor. And that's how she managed herself, you know. This is quite amazing stuff. I'm pretty sure it's 2021. Okay, I'm pretty sure it's 2021. And just while I'm at it too, is everyone here a member of Wounds Australia? Yeah, there's a lot of nodding, which is brilliant. Okay, well, we've had 30 years to garner your membership. I don't know if you know this, but in 1991, the first conversations, which include some of the people who are sitting down the front here, were held around starting up the South Australian Wound Management Association. And I find it remarkable that here we are, that a group that was started as part of a worldwide move back in the 70s and 80s that then translated into the 90s in Australia. I find it absolutely remarkable that here we are 30 years later and we've still got this sitting out in the community in the form of our clients. This is somewhere along the line we've failed. And I don't know where it is. And can I also say that somebody mentioned earlier, mercurochrome. Who was that? Was that Sue, right? I actually think we're starting to track backwards. And this is something that I really noticed. I went away for 6 years. I went off and lived in the desert and did a whole bunch of different things just to try and re-educate myself and sort of do stuff. And I came back and I started to see stuff that I hadn't seen pretty much since the early 80s. And coming back in and starting again. And I think that we really need to be very careful. So every single person who is in this room today is either a member of Wounds Australia or, can I say, potentially, at the end of the day, a member of Wounds Australia. We need you. We need this support because advocacy, consistency, education, knowledge, all of these things are really important because this should not be happening. Like, we're sitting here today talking about something that we should be really quite technical about, and we could be doing this. What are we doing all day? We're talking about fundamentals, fundamentals, fundamentals. Why? Because they're not being done. And this is the really big issue. So that's my first slide, and I've just about run out of time. Happy to take questions. This person here, you know, this is another one. This lady, and Margi had done a brilliant job on getting her better, but she goes back out into the community, re-injures, goes backwards and forwards. You would know her really well. And goes backwards and forwards, can't get back in to see Margi because her mobility, etc., is no longer there. So she loses this amazing wealth of knowledge. What happens? 17 wounds across her legs, like this. Pain, suffering, you walk in, you can smell the pseudomonas when you walk in the wound. The organisation had been caring for her for 3 years, right? Fundamentals, 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 same diff. This guy here falls over, leaking everywhere. What's wrong with him? Oh, we don't know. Let's do this, let's do that. And you have to go in and push really hard, get an ambulance admission, get him seen acutely, get it all under wraps and then start moving forward. All of these wounds are biofilm related. Every single one of them. So we've all seen manifestations. Here is an absolutely beautiful one. Now, Sue, I know that the cheesy thing is an issue, but I mean, here it is. We've got a bit of mozzarella happening there. So we need to just acknowledge the fact that biofilms come in all shapes and sizes. This lady, another 3 years before anything was actually done, and it's a really big issue. So let's just talk briefly about biofilms and what they are, because I know that everyone's alluded to this. I actually thought we'd just go back to the basics and just talk and move forward. I've done my talk a little bit differently, so my slides have the references at the bottom of each of them rather than summarised at the end. I don't know if that makes it easier or harder, but so a complex community of different species of bacteria all banding together to cause issues, and they reach maturity over 48 to 72 hours once they start happening, and then they regress, break down and reform. Okay, so that's really important. I'm going to go back and talk again about the biofilm issues in relation to teeth. I had this slide, I went back and had a look at some of my really old slides, and I had this one about Ramses II. I don't know if Ramses II was like the god king in Egypt, really the most significant king of Egypt. And he died in his 90s of tooth decay. So even he had problems with biofilms. Probably didn't have this type of toothbrush, I'm just saying. Anyway, the interesting thing is, though, that biofilm is something that we live with all the time, right? So biofilm is not new, biofilm is not different. Biofilm is something that we live with all the time. And the other little one, oh, look, I put Ramses in there. There he goes. And that's because I have a dad joke at the end of it. If you don't brush your teeth, you'll suffer a fate worse than the Hittites. No history buffs here. Okay, move on, Tal. Okay, so Ramses destroyed the Hittites. I don't know if you know that, but anyway, whatever. So one of the earliest biofilm models was this little baby here. This is P. Dirks. Now, I wonder, this is the Centre for Biofilm Engineering. You know, what a place to work. What do you do? I grow slime. It's a really good thing. I've got a young 9-year-old at the moment, and she grows slime every single day. There is more slime and slime and slime and slime. Do you have anyone who has young children will know all about this slime epidemic that's going on? I've actually yet to incorporate any of her slime efforts into my talks, but I'm going to. I walked into her bedroom last night and I could feel it on the carpet, and I'm going, oh, really lovely. What have you been up to? Oh, nothing at all. And there's wet tissues and stuff all around. So there we are. We have biofilm in the bedroom as well. So the Centre for Biofilm Engineering, we're going to actually get Adelaide to head that up. But let's just briefly talk about this. This is an older model. And this model actually came from the investigations that were taking place in relation to what? Does anyone know? Why would we have a Centre for Biofilm Engineering? It's got nothing to do with nuclear submarines, surprisingly enough. You know, that fella down under. Thank you, pal. How would you feel on an international... Oh, who am I? Oh, I don't know. Who's that fella down under? I don't know. Who knows? We'll probably be a different one next week, knowing Australian politics. It's probably why they don't even bother now. They just got the Australian Prime Minister with an asterisk next to it, just C list. But anyway, you know what it does? It actually comes from the plumbing. Yeah, it's plumbing. Right? So the interesting thing about biofilms is, you know, that kind of circumstance, again, if you've got young children, you've had young children, you'll know this, where suddenly the sink in their bathroom just non-functioning, you know, just not functioning. And you've got to do that thing where you pour a whole heap of chemicals down there and just try and dissolve the shit, and you can hear it like this. Anyway, the point being that it doesn't work, so you unscrew it and it just goes... It just all comes out in one. That's biofilm, right? And so we see biofilm in and around our lives everywhere. It's not just about the fact that it's on wounds, it's about everywhere. And some of the derivation of the chemicals that we use in order to deal with biofilms on human tissue actually come from here. Right? And this is the truth. And in fact, what's really interesting is that some of the stuff that we're doing these days is actually related to what we used to do. So, Sue, you mentioned about, you know, and I know, Margi, you were onto this as well, you know, in the 80s that there are, and we used to, in plastics, Sue used to run the plastics ward there, just in case you know S5. Well, didn't you? Yes, at one stage. When was that? 1986. 1986-7, just so you want to know. It was a little bit later, but, you know, anyway, not much later. And Margi, yeah, we won't even... anyway, so the thing is... Oh, that's right, I was there then. I was, what, about 12, 13, I think, something like that. Here's the thing, though. Here's the thing. We used to use a thing called sodium hypochlorite, which was otherwise known as what? Milton, bleach, Usol, okay? Usol if you wanted to sound fancy, you know, Edinburgh University solution of lime, and then bleach if you want to put it down a toilet. So it's really interesting, isn't it, that we've always understood fundamentally how to deal with biofilm. That is, you need to use a solution which is capable of penetrating that biofilm and killing the bacteria and the fungi and whatever else happens to be in there, breaking down that matrix and then flushing the stuff away, right? Now, if you think about James's talk and Margi's talk, where they talked a lot about doing exactly that, making sure that you've given it a really good scrub and clean. There's our toilet man, okay? So this is my biofilm model, by the way. This is as far as I go in this talk. It's like, yeah, you've seen that, the plumber. But basically, that's what we're trying to do. We're trying to scrub it, we're trying to smash it, and we're trying to flush it away. And that's the fundamentals of everything that we do. So this model here is pretty cool because this is a much more advanced model. And this explains why as much as you pour that stuff down the sink and as much as you get the plumber in to, like, you know, flush it out or scrub it, you know, not leave the skid marks, do all of those types of things, as much as you do that, the bloody stuff comes back again. And this is the problem that we have. So I'm going to just go through this quite carefully so that we understand the various components of the biofilm, what we're going to do about it, and where some of the stuff that we've talked about this morning actually fits in terms of practice. So this comes from Rumbauer. This is a really, really good article if you're a wound nerd. This is awesome, this article. 2020 biofilm dispersion. It's in Nature Reviews. You can actually access it free online. That's the reference there. It's an absolute ripper. I read it most nights before I go to bed. I really do. That and my dad jokes. I have another dad joke later on, but I'll get to that. But this is really good stuff. Okay, so the first thing is that you have a wound. Okay, down come the greeblies, the free-floating planktonic bacteria, and land on the wound. Now, the first thing that they do is go, oh, this is not very good here, and some of them get killed straight away because we activate our immune system, bingo, they're gone. Okay, that's great. But all wounds are contaminated by bacteria. There is no such thing as a wound that does not get bacteria in it. Even under the best of surgical environments, you can never guarantee that you don't get one. Okay, and one can lead to many, just depending on whatever. I took out all my historical stuff today, but anyway, we won't go into that. So, you get some bacteria. Now, they can start to proliferate, or they can just start to live there. Now, at this point in time, they're pretty easy to deal with. This is where things like, for example, saline could actually be quite useful. And some of us have been around long enough to remember when we used to talk about syringes and putting things on and you know, 15 pounds per square inch pressure and all of this sort of stuff, because those things can be removed at that point. But within 24 hours, as James mentioned, 24 to 48, maybe even 72 hours sometimes if you're lucky, and you've got a good immune system, unfortunately, you get irreversible attachment. Now, it's called irreversible attachment because it's irreversible. In other words, they're there and they can't go away. So you need to think about, okay, we've got bacteria there who have colonised and formed this irreversible attachment, but that doesn't matter. You know, evolution will take care of that. And I know that some of you looked at me really weirdly when I talked about, like, reading from the book and stuff before, and you were like, where is he going? Evolution, it's a thing, all right? So basically, yeah, okay, fine, we'll leave that one. But basically, here's the thing. The irreversible attachment means that they're not going away. So we're going to have to deal with this for as long as the wound's there. As the environment changes and that tissue that they're attached to is no longer there, then we may get rid of them. But for as long as the tissue that they're permanently attached to is still there, they're still permanently attached. So then the biofilm matures. Now, at the biofilm maturation stage, what you've got is that slimy layer. You've seen some beautiful examples from everyone that's shown slides today, and they start to grow. In a toilet, that's that white hangy stuff that can come down, or in a sink or whatever, or in Adelaide's bedroom, whichever you prefer. But on a wound, we tend to start to see actual layers of this stuff, and it discolours, etc. So this is the biofilm maturing, and you can almost see it. You can't always see it, though. You can't always see it, but this is the biofilm maturing. So that's the model that we got to in the Dirks model, right? But here's the bit that we haven't really focused a lot on today, and that is the dispersal model. This is extremely important because what happens at dispersal is that the bacteria that are released from the biofilm, and the reason, biofilms will do this naturally. It's a little bit like a commune, you know, where eventually, or a city or anything, eventually there's no room for further growth. You know, all the resources have been used up, all the oxygen if they're aerobes, etc., all the nutrient sources, etc., have been used up. So the biofilm itself starts to degenerate and it releases more bacteria, right, to go somewhere else and colonise, a little bit like Earth, you know, we're trying to go to Mars, you know, that kind of thing. So we're just taking us bacteria, viral spores, and going to transport our problems to another planet. But here's the thing. When these bacteria come out, they are more virulent than the parent cells that were there originally. So the little greeblies that came down and landed and then colonised and stayed there, they've sort of gone to sleep, like most good parents should. It's just like, oh, good, I've done my job, and produced a few children who then go off and cause some mischief. But when those children come out, right, to play, anyone who's got older children will relate to this, they start to cause mischief. You know, they can cause all sorts of mischief, and some of them want to actually procreate and proliferate, which is not a good thing. We do talk about birth control at home. But here's the thing though, those ones are more virulent than the parents that went in there in the first place. So when you are scrubbing and using your solutions and all the rest of it, please be aware of the fact that as the biofilms are breaking down, the bugs that come out are more virulent. And this explains why it is so hard, once a wound has been there for several years, for example, to actually start to impact it and to do anything about it, and why you have to do it very hard, very consistently, and you have to add in other weapons. So we'll get to that in a sec. Oh, that's pretty boring. Okay, we'll move on. So we haven't had lunch yet, but I just thought I'd bring up my pizza wound. I love my pizza wound. You know, we've got all sorts of lovely things there. I think I can use the pointer. Oh, look at that. Amazing. See, we've got a few anchovies and lots of mozzarella and stuff like that. But this is a clinical presentation of a biofilm, but so is everything else that we've seen. I want to just talk about something before I move on to talking about these solutions, and I've got about, almost all of my talk's gone on rubbish as usual. But anyway, I just want to bring this up, and I always make a point of talking about this, because one of the biggest problems I have in practice is that I say to people, well, you know, we've got this problem, it's clearly an issue, we need to do something, let's find out what bugs are there. They go, oh great, yeah, we'll take a swab in, we'll do the swab, God knows what technique they use, you know, swabs, you're supposed to do this, press it in, anyway, whatever, after cleaning it with saline and something that won't kill the bugs that you're actually looking for, just saying. But anyway, this particular study showed that there were a bunch of people admitted for scraping of their sinuses, right? So, intraoperatively, before the sinus operation was done, they'd swab, right, send the swab off for microculture, not sensitivity because it didn't matter, right, and then take a biopsy of that same tissue and do microculture on that. And what they found was that basically the species of bacteria from the intraoperative cultures didn't match the swabs. They don't match the swabs. So one of the other tricks that biofilm is doing to you is actually tricking you into not treating it with the right spectra of antibiotic therapy, if that's the path that you're going through. Okay? And that is also why these things break down and come back, and why we also see that nasty situation where despite our best efforts in scrubbing and cleansing, what happens? You go, oh yeah, they've been on antibiotics for 2 weeks, great, we've got excellent outcomes, and this happens in community all the time, particularly in general practice. And they go, good, we'll take them off the antibiotic. Bingo, what happens? The wound comes back, except that the planktonic bacteria this time have come out, and they're now resistant to that antibiotic. And this is the problem with biofilms. It's a really big issue, and why just antibiotic therapy on its own, and just scrubbing on its own, and just debridement on its own won't actually do the trick. You need to do all of it, and do it all really hard and for a period of time. So I'm just going to move over that. But this is what I want to say. This is a little bit of me being controversial for the sake of it, and also getting people to think about things. So what we know about biofilms is that if you give antibiotics to somebody with a biofilm, you may or may not get an outcome, right? Remembering that quite often the symptom of a biofilm is not only what it looks like, but the fact that in the absence of any real erythema or anything else, even without edema, etc., you can get a lot of extra exudate. Right, so the exudate can be a sign that you've actually got the biofilm there without other signs. Anyway, moving on from that. The thing that people haven't talked about and generally won't talk about is the use of antibiotics. Now, it has been said that I've got a really low threshold for the use of antibiotic therapy. I don't order them. I'm not a nurse practitioner. I'm not clever like my colleagues. But here's the thing. There is value in it. There is no question that there's value in it. And there's plenty of research that shows that. I've got, article after article, study after study to demonstrate that there is value in it. And here's the reason. What happens is that antibiotics do not work very well on sessile cells, ones that aren't reproducing much. They can do bugger all, actually, right? Because most things are really reliant on impacting rapidly dividing cells. That's how they work. So this is what that slide is saying, okay? So they're working on that. Fluoroquinolones, on the other hand, can have some impact on slower reproducing cells just because they work off the DNA factor. But anyway, moving on from that, what I'm trying to say is that don't rely on antibiotic therapy, but also don't throw that baby out with the bathwater, because antibiotic therapy can actually help and impact what happens beyond. Imagine this scenario. You're walking in there, you're scraping, you're scrubbing, you're adding your solutions, you're doing that. What are you doing? You're breaking the biofilm down. You're stressing the biofilm. The biofilm will then break open and release the planktonic cells. Those cells are going to be rapidly dividing, and they are very virulent, right? There's some really good studies on the hypervirulence of the released planktonic cells. That's when your antibiotic can become really useful. And this is why we need to start examining, I think, in amongst everything else, the use of appropriate longer-term antibiotic therapy in the management of chronic wounds, right? I'm going to leave you with that. That is going to cause a lot of discussion at lunchtime, no doubt, as you're eating your pizza, hopefully, and thinking about the mozzarella and all of those things. But nevertheless, what I really want you to do is have a think about where this might fit, okay? Because there is certainly quite a lot of evidence that we should not be throwing that baby out with the bathwater. Okay, so let's just move on. George Rodhever had a really famous article in the 1980s. It was a really famous article because what it did is it, along with David Leeper, it did away with the use of hypochlorite solutions. And that was a good thing for most of our clients, in our patients, etc., in the people we look after in hospital. Because, I don't know about you, but putting Usol onto patients every 4 hours and scraping them off the ceiling after you did that was not a good thing, right? It was really, really uncomfortable, loading them up with opioids and stuff just so you could stick Usol into their wound and watch them scream wasn't really fun, okay? I think any time that you're... Yeah, anyway, let's move on from that, Tal. But the Rodhever article said, don't put anything in your eye, don't put anything in a wound that you wouldn't put in your eye. And that, for the next 20 years, knocked out a lot of capacity and for us, because it slowed down the use and development of antimicrobials. So just be aware of that. I want to talk about some basic things, though, and I'm really apologising here, Margi. I'm so sorry. I had it already in there and I couldn't change it. But there is a really good paper by Kramer et al. I don't know if you guys have read this. It's the consensus paper on antiseptics. It's a really good one. It's in Skin and Pharmacology, and you can read this one. And what Kramer et al. Do, it's a German thing, they actually review periodically all the evidence that is assessing, or that they're assessing in relation to solutions. So I thought I'd just throw this out there. One thing that no one's talked about is povidone iodine. Now, povidone iodine is another thing that falls into the antibiotic category. You cannot throw it out altogether as a useful item, right? I use it a lot. I do use it a lot. Why? Readily available, very cheap, people understand it. There is a stack of research around it, so we understand it. We know there is sensitivity, and we know there's a whole bunch of issues around it. There's safety and efficacy papers on it. We know how to use it. It is quite useful. Why? Because when you're physically disrupting the biofilm, the iodophores can penetrate into the biofilm, and it does kill both the senescent and also the sessile and also the rapidly producing planktonic cells. So don't throw that one out. The other thing about iodine, or povidone iodine more particularly, is that it's very useful on fungi. Okay, it's extremely useful on that. There are a couple of things that I haven't added in here. I'm going to mention one now, which is Condy's crystals. I have a big problem with this at the moment because, unfortunately, no one can actually show me the papers. Firstly, I know that there is evidence that it works. I know that. But it gets put on at the wrong concentrations, differing concentrations, again, with lots of different people coming in. They'll go, oh, well, what's pink? You know, you show people the colour pink or purple and they'll use all sorts of different things. It is a problem, so I don't use it. I only use things that have the safety and efficacy papers, and I can go, this is what I've done. Because I always imagine the judge sitting over me going, you know, why did you do that? And you say, well, I referred to the Wounds Australia guidelines and here's my safety and efficacy paper. Good, you don't go to jail. You know, just think about it. Okay, polyhexanide, really, really useful. So the interesting thing is, though, that quick release povidone iodine doesn't work when you've got wound exudate. Just putting that out there. So there are uses and there are uses. You need to have the slow release varieties when you've got wound exudate. Why? Because it binds with the iodophores bind with the wound proteins in the fluid itself, and therefore it stops working. Wound solutions that get around that are things like polyhexanide, which Margi described much better than what I've got here. We need greater than 5 minute soak times, etc. Saying you don't have time, I agree with Margi, it's a bit of an issue, but I also work in community. Sue, you work in community. We know that our nurses get bunched at the end of the day, and if they have to do a 15-minute soak when they've got 10 minutes to be back here and they're supposed to be doing their reporting and everything else, it's not getting done. Right, that's the thing. So we need to look at ways around that, and so just be aware of that. Hypochlorous acid, it is, oh, sorry, can I just go back? Polyhexanide, does anyone know what it's related to? It's a chlorhexidine derivative. So be aware that polyhexanide is a chlorhexidine derivative, has similar properties. Just be aware, sensitivities to one might equal sensitivities to the other. Right, it's very, very low incidence, but it's still something to consider. So if you're using Pronosan, for example, just be aware it's a relative, and therefore just be looking at the sensitivities around that stuff, okay? Says he, desperately trying to find different things to talk about. Hypochlorous acid, Margi described it beautifully. It is related, probably more chemically related to hydrogen peroxide than anything else. It's a superoxidized solution. But what I do want to say is that it also is hypotonic. So it has another thing which we haven't talked about, which is when you bathe the cell in a hypotonic solution, it explodes the cell, so the bacteria don't like it. So when you leave it there and you're really flushing the wound with it, you're bathing those bacteria, those planktonic cells, in a hypotonic solution, and it will explode them. And then octenadine, which we don't use much in Australia yet, is coming. It has been used extensively in Germany. So most of the papers that you'll find on it are written in German, or there are translations around for you, but have a look at it. Kramer's done a beautiful job. Another thing is that I do use a lot of medi-sponges. I'm not talking about what towel does or whatever, but it's just a way that we talk about these things. There are cases and incidences, of course, of sensitivity. Yes, it's very drying and on the skin, but there are places where, in the absence of having any other form of sponge to scrub the bloody wound, this thing can actually be quite useful. So don't also just dismiss it out of hand because that, but do watch out for sensitivities and skin reactions. Now we'll just get on to the last little bit. Have I gone over already? Yes, of course I have, sorry. Anyway, there are the silver-containing and the cadexima iodine group, which are really well studied. On top of that, you've got things like, say, Zorflex, or you might have ErgoClean, which do physical jobs on it. Sorbact is another one that you can have a look at. I haven't included them in my talk today because I knew that I'd run out of time, but I just want to talk about the two that are there. One thing I want to say about silver-containing dressings and biofilms is that the ionic silver can have real problems penetrating an intact biofilm, so the disruption becomes part of the exercise, as does the iodophores in cadexima iodine. It's a bloody good, they're both, all the presentations of those things are bloody good, but the thing is you just need to be aware that you've got to disrupt that biofilm first before these things can really have the impact that you want. So that means debridement, that means scrubbing, that means using your solutions, okay? And then, you can get this sort of effect. This is 1.5 weeks. In this particular case, it was microdacin, but this is with what we're doing. I just want to talk about this lady because I always like to leave us with a story, and I won't tell my silly dad joke, which involved a whole thing around Ringo Starr, but it's too late. Anyway, 83, 6-year history of cellulitic venous ulceration, complicated by underdiagnosed lymphatic issues, cared for by multiple community people, 3 years sitting in her house, excruciating pain. And, there's some really terrible photographs, but most of the time I was lying on my back to take some of these things, so, is what it is. But the thing that had been missing is consistency. So what did we do? We did what we always do here with these things, scrubbed it, with Medisponge in a bowl, okay, painted her with betadine, then scrubbed that off again, microdose and soaks all around, and also, of course, and everyone who knows, you all know what I'm going to say, is that we've also got a ring compression, and there's a whole bunch of other things happening there. But by the end of September, you've got that, and end of September, that looks like that, and that's what she ended up looking like in 2019. By December, she was re-injured, and so on and so forth, and we go down that path again, but there's a whole bunch of reasons for that. So I want to leave you with that. I'm sorry that I've gone over time, but that's about it from me. Okay, thank you, bye.
I told you. So, from one fantastic speaker to another, it's well known that we have hard-to-heal wounds that are caught in an inflammatory process that impairs and inhibits healing. Our next presentation is by Sue Templeton, and she will present on the management of inflammation. Please welcome Sue.
Thanks, everyone. I'll keep an eye on the time, see if we can make any up. I haven't got any dad jokes, probably because I'm not a dad. So you'll have to go without dad jokes for me. We'll talk about something much more boring, which is managing inflammation. Okay. So again, I'm going to go through this really quickly. But again, just to recap, of course, we're talking about hard-to-heal wounds, and we know that they have multiple impacts, both at that cellular level, at the physical level, and then on the broader person, and certainly the health system and economics of healthcare. And I don't know, we should almost have I think we're almost going to have a competition today for the unhappiest looking wound of the day. And I'd suggest this as a candidate, because this is, as you can see, a pretty unhappy looking wound. And I have to say that most unhappy looking wounds are attached to unhappy people because of this issue. All right, so let's talk about inflammation. I come back to my little diagram I used at the beginning of all of those factors influencing healing. And certainly this is where we're going to focus the talk on for the next few minutes, is that inflammation. So like most things, inflammation is actually a normal part of healing. We need normal inflammation. And it's essential to wound healing. It's a non-specific innate immune response, and it's basically vital to clear up organisms and tissue debris so that repair can happen. I always say it's like, after, I guess, you've had a fire on Prospect Road at a restaurant last night and you're left with a whole lot of garbage there that really needs to be cleaned up before you can rebuild the new restaurant. And that's exactly what the body's got to do. Some sort of trauma's happened, there's been an injury, so it's got to send in the construction crew, the demolition crew, to clean everything up. In our body, it doesn't involve low loaders and things like that. It involves leukocytes, neutrophils, monocytes, macrophages, fibroblasts, cytokines, growth factors, enzymes, and it all goes on. So, nice complex process that's wonderful when it works well. However, as we've been talking about all day, we know that at that cellular and tissue repair process, there's failure of healing. And that predominantly that is due to an increased and sustained inflammatory phase. And we've already talked about all the things that involves. So if we sort of diagrammatise that's another made-up word, I think. If we've got normal wound healing, and there are plenty of these sorts of similar diagrams available on the internet, what we know is that inflammation sits in here, and it's a relatively short self-limiting phase. And during regular inflammation, we have all these wonderful things happening which rebuild tissue and get us back to structural and functional integrity, hopefully, or hopefully at least some structural integrity. However, what happens in chronic wounds is that that short-lived, self-limiting inflammatory phase is long-term. So in a very basic diagram, it just goes on and on and on. We don't actually move into that repair phase. So it's like those trucks just coming and keeping taking and taking rather than going off so the builders can come in. And if we look at a little bit more in-depth diagrammatic representation of that, we have this unhealthy wound bed. And certainly, whilst there was some talk about callus at that wound edge, one of the things that you'll notice in chronic wounds at the wound edge is just hyperkeratosis. You'll see that build-up of skin at that wound edge on any wound. And often then people come in and scrape it off or whatever, and it just comes back again. Within the wound itself, we don't have those nice new little blood vessels forming, those new little bits of angiogenesis there. So we have a wound that's basically stuck. So I really like this one, particularly as I've recently actually had the pleasure and privilege these days of spending a couple of weeks in the Northern Territory up in Darwin and seeing plenty of crocs. So I came across this statement and I loved it. A chronic wound can be described as having a rogue inflammatory response, but really all I wanted to do was have an excuse to put a picture of a large crocodile there. There we go. So what are we going to do to manage this chronic wound inflammation? So I'm going to go back to basics again. We absolutely need to identify and manage those underlying etiological and diagnostic considerations, because we know that for some chronic wounds that's enough. So I'm sure most of you that say look after people with lower leg wounds, if you do that, if that's predominantly due to chronic venous insufficiency, there'll be quite a lot of people with a chronic leg ulcer that if you put them in compression, sometimes without doing a lot else, they'll actually heal. So we absolutely need to address that. We need to absolutely manage those patient and environmental factors impairing healing. And that's all those things like smoking, poorly controlled diabetes, bathing their wounds in soft drink. So that's a true story. Letting the dog lick it because they read that that's good somewhere on the internet, because of course what you read on the internet is always better than what is actually true. Systemic pharmaceuticals and supplements, and this is where I'll talk a bit more in a minute. We've talked enough about good wound bed preparation. Well, not enough, but we've talked a lot about that. And topical pharmaceuticals, dressings and therapeutics. Because this is what we want. This is a lady that I looked after a few years ago with a chronic venous leg ulcer, had been in good long-term compression, had certainly had good wound bed preparation, including low-frequency ultrasonic debridement, but still you can see, and it's actually quite good that the size is there, because in the photo on the left here, this is the size of the wound, but you can actually see this wasn't infection. So this wasn't bacteria, but she had this chronic persistent inflammation around this wound. And this wound just wasn't going anywhere, certainly despite best practice treatment. So we actually had to take that next step to address some other factors locally, which I'll talk about in a minute, to progress her towards healing. And isn't it amazing that as soon as you can overcome that chronic inflammation, particularly even if you look at the middle photo there, you can actually see that erythema has subsided really quite rapidly. Now, we won't always see inflammation that obviously in our patients, and that's one of the issues we see, is that chronic inflammation isn't always associated with chronic erythema. And that can be particularly a problem for people with chronic wounds because that flare response gets dampened down. So don't think you're always going to see that redness, but in some people you will. So I'm going to talk about something a bit different now. I'm going to talk about matrix metalloproteinases, or MMPs, because they're the focus of my presentation. Again, these are essential for normal wound healing. They're a family of more than 20 zinc-dependent endopeptide enzymes secreted by M1 macrophages, and they contribute to every phase of normal wound healing. They help to break down wound proteins, including the provisional extracellular matrix. They facilitate cell migration, involved in cell signalling, they contribute to angiogenesis, and they help to remodel collagen during the maturation phase. So they're really heavily involved, and there are different classes of MMPs, and you can read lots about them. In normal wound healing, though, you come in with TIMPs, which are tissue inhibitors of matrix metalloproteinases, and they actually dampen down the MMPs so that then healing can progress. However, in hard-to-heal wounds, you've got too much of a good thing because these MMPs are elevated and the TIMPs are reduced. And there's certainly evidence that this upregulation and continued expression of high levels of MMPs correlates with a chronic inflammatory state within the wound, and healing fails to progress. So that ECM, that provisional matrix laid down, becomes weak and disordered and breaks down again. So your healing just can't get any traction. Type 1 collagen, which is the initial type of collagen, is broken down, and cell proliferation is inhibited. So that wound is just getting stuck there. There has been quite a lot of work done recently, and there's ongoing work done to see how we can actually manage excess MMPs. And there's some of the things that are around. And really today I'm not going to talk about the first three. I'm going to talk about what we can use in clinical practice or help facilitate in our clinical practice on an everyday level, which are the later two, the dressings and the pharmaceuticals and supplements. So there's quite a bit to cover, so I'm not going to go into great depth with any of this, but certainly in the vitamin and micronutrient space, there is emerging evidence that some of these are actually anti-inflammatory and might have a role in promoting wound healing. And this includes niacin or vitamin B3, zinc and selenium. So Chemist Warehouse will be happy because I think soon their whole store will just be vitamins. Now, I just want to say, just do be careful with supplementation, all right? So you can even have too much of a good supplement. So I wouldn't necessarily recommend that you just get people to go out and take a whole pile of things without some supervision. So this is where you would talk to the GP, make sure you do your own research and use these things, like everything, wisely. There's also some use of tetracycline antibiotics such as doxycycline, although this is considered off-label use. And it has been shown that these tetracycline antibiotics do have broad MMP inhibitory effects independent of their antibiotic effects. So there may be a role for some people to be on things like doxycycline as a low-dose long-term treatment. But again, if you're interested in this in your workplace, talk to somebody else about it. The next big development is dressings. So there are two main groups of dressings for MMP regulation. And the first one are classed as MMP modulating dressings, and these alter the wound environment, resulting in changes to the protease concentration. And these are really a superabsorbent dressings, and I want to talk a little bit more about that. And then there's what's called the MMP inhibiting dressings. So these are dressings that are specifically marketed as having direct MMP altering activity, rather than almost as a secondary effect of the dressing. There's also a third group that sort of doesn't really fit into either of those, which is for some of the silver dressings, and in particular the nanocrystalline silver dressings, which essentially is your Acticoats. That in fact the AG0 in that product does have some anti-inflammatory effects as well. But as everyone has said along the day, you can't just do one thing. So using your silver dressings, even if it is something with some nanocrystalline silver in it, isn't still going to be effective unless we do all those other things we've been talking about today. So the MMP modulating dressings, so these are your SAP dressings, your superabsorbent polymer dressings that incorporate polyacrylate. So they actually absorb and lock exudate into the dressing. So these are usually the dressings that use the technology that traditionally was used in continence pads and sanitary napkins and those sorts of things. And it's very nice now to have these dressings available to us, so I don't have to go to people and say, well, the only option we've got is to put a continence pad around your leg, which is what we used to have to do. That technology's been incorporated into dressings. So as that's locked into that actually binds some of those proteases into the dressing material. So dressings that we often use in clinical practice can actually have some of that effect. Then we've got the MMP inhibiting dressings, and I'm sorry this is a little bit busy. There are two main brands on the market in Australia at the moment. And from 3M we've got Promogran or Promogran Prisma matrix, which is comprised of collagen and oxygen regenerated cellulose, plus or minus silver. So the Prisma version has 1% silver in it. And certainly it's claimed that these can inactivate proteases and free radicals, remove excess metal ions, protect matrix proteins and growth factors. The opposition product, I guess, the other product available, is ErgoStart from Ergo Medical. And that's known as a TLC NOSF dressing. And God, they such big words, you can see why they use abbreviations. So the TLC is their technology lipidocolloid, which is available in a lot of the Ergo dressings. So if you look at Ergo Tool and those products, it incorporates that TLC technology. The bit that's different, that is particularly MMP inhibiting, is the nano oligosaccharide factor, which is actually a sucrase octyl sulfate potassium salt. Oh my God. And that's the bit that inhibits the MMPs. That also normalises growth factors and contributes to tissue formation. So they're available in different formations, and I'll show you those in a minute. So when might you use MMP inhibiting dressings? So recommendations from the literature say hard to heal wounds, healing by secondary intention. Consider when no improvement after 4 weeks of best practice management. So again, that thing I talked about before about not waiting too long. So again, getting onto it sooner is going to be better than later. Again though, make sure your etiology is diagnosed and you've addressed some of those other factors. Good wound bed preparation, again, is vital, and in particular no necrotic tissue, because otherwise you're just putting, to be honest, a fairly expensive advanced dressing on something that's not going to have any effect. Yeah, so it needs to be on something that's reasonably happy. Yeah. And generally you don't use these products while there's overt local wound infection, so you need to treat the infection first. So if we look at the two products, Promogran, and I'm just going to talk about Promogran Prisma because that's the one that most clinicians use, although it's only the addition of silver that's different in this one, as I said. So what this does is form a soft, conformable, biodegradable gel in contact with exudate. So it basically dissolves into the wound. So this is probably one of the few dressings where the recommendation isn't that you have to clean it all out at every dressing change. So this actually also means that if you have a deeper wound that maybe you've got some recesses in, it's actually safe to put in because it's not required to get it all out. Yeah. You can hydrate the product with saline, pre-hydrate it if the wound is dry. I've not done that myself in clinical practice. I must admit. Put a secondary dressing on that's appropriate and it's compatible with most secondary dressings, and then you reapply every 1 to 3 days depending on the exudate level. And it does look like a little wafer type dressing. It almost looks like a foamy type dressing if you haven't seen it. There is some on the stand today. This is a case study from my clinical practice, and I do apologise if you tuned into the Wounds Australia conference because I did give this here as well, there as well. This was a gentleman with pyoderma gangrenosum. In fact, you'll see what this looked like initially at the very end of this presentation. And all his other wounds, of which were many and extensive, had actually closed except this one. He had been in compression, didn't make any difference. He'd had negative pressure, didn't make any difference. He'd had good wound bed prep. I have to say by this stage his pyoderma was actually inactive. Okay, so we could actually be a little bit more aggressive with our cleaning with this wound. So it wasn't responding to a whole lot of things, even some advanced treatments. So Promogram Prisma was commenced on the 7th of June, and by the 21st of June, although there's not been a big reduction in size at this stage, you can actually see we've gone from a very flat-looking granular wound bed here to actually having some granulation tissue forming here. So that's a really good start. By the 13th of August, that wound was at least 50% smaller. 24th of September, we'd gone to that, and pretty much closed by the 26th of November. So made a significant difference to this man's outcome. Okay, the other product, ErgoStart from Ergo, indicated for exuding hard-to-heal wounds. Again, no infection, treat that first. Contraindicated for malignant wounds, fistula and deep abscesses. The same sorts of things again, good wound bed prep. With this product, if you are using an antiseptic solution, any of the products we've been talking about today, they do recommend that you rinse that off thoroughly before you apply ErgoStart. And again, replace every 2 to 7 days depending on the wound characteristics. And there is a recommendation that this is used for a longer period of time. So they recommend with this product you're not necessarily going to see instant results, okay? It may take several weeks to see results. And it's available as a foam, which is the top picture there, or as a chill wound contact layer, which is the bottom picture there, and in various sizes. So ErgoStart has some amazing clinical evidence. So there's the Explorer study, which was actually published in the Lancet. And my understanding is that this is one of the very few dressing-related trials that's ever been published in the Lancet. That's not normal for them to publish such trials, but it was a randomised double-blind controlled trial in 43 European hospitals in specialist diabetic foot clinics, and they compared ErgoStart to ErgoChill, which is, I guess, part of the brilliance why it could be double-blinded, because essentially those two products look the same in the wound contact layer form, which is the form they used during the trial. And you can see the criteria there, non-infected neuroischemic foot ulcers. And what they demonstrated was that after 20 weeks, the group that had ErgoStart had significantly better wound closure. And you can see that that was 48% wounds closed compared to 30%. And that was with all the other things around management of a high-risk foot in place as well. So since then, certainly considering a product like ErgoStart has been incorporated into recommendations such as the recent International Working Group for the Diabetic Foot Guidelines in 2019. So there is quite a lot of evidence and recommendations for it. So this is a case study. This is not a case study from my clinical practice. I do need to say that, but it does show how it can be useful in clinical practice. So a 50-year-old woman with diabetes-related neuropathy, post-amputation. Now, I guess it's important, as you can see, what they did here is they cleaned up the wound first. They didn't just stick it on a load of crappy tissue. So they actually didn't start it until the wound looked half decent, okay? So they'd cleaned up all this stuff and then they supplemented all the other care with the ErgoStart, and this lady obviously achieved closure at 10 weeks. So a great outcome. Okay, I just want to finish off quickly with a slight tack to the side, which is just a little bit about inflammatory etiologies. So there are some etiologies that we might come across in clinical practice that are inflammatory related. The main take-home message is that these are uncommon. Everyone loves talking about the weird and wonderful things, but these are uncommon. So always when you're looking at wounds, think about the most common obvious causes first, and if things then don't respond, then start to look at other things. The interesting thing about a lot of these inflammatory etiologies is because they're associated often with erythema, they are mistaken for infection. So if it looks unusual or unresponsive or chronically inflamed, I guess my take-home message is discuss this with whoever else is looking after this person or make some appropriate referrals. So I'm not today going to go into how you treat all these things. It's really a bit about what you might pick up in clinical practice and who to refer them on to. So the first one is actually lipodermatosclerosis. And this is an inflammatory condition of the lower leg, and it's a result of chronic venous insufficiency. And as the name suggests, it actually tells you what it does in the name, doesn't it? Because lipo is fat, dermato is skin, and sclerosis is hardening. And that's basically the end result of this process. But what you see, and what we often refer to as an inverted champagne bottle leg, although these days I don't know that we're allowed to call it that, probably an inverted sparkling wine bottle leg, given that we're not allowed to use the term champagne unless it's actually French champagne from the Champagne region. What you see here in these photos is the end result of that inflammatory process. So it's more likely associated with obesity and in women. Now, if you think you've got someone with an acutely inflamed lower leg with venous insufficiency, it may be cellulitis, but it may also be lipodermatosclerosis. So you can refer them off to your vascular colleagues, okay? We might be able to get some treatment for that. Often it is hard to treat, and it's, of course, once the fibrosis is set in, there's really not much that can be done about it. The next one is Charcot-neuroarthropathy. So this is often referred to as a Charcot foot, but what we see in clinical practice as a Charcot foot, again, is actually the end result of what happened after the inflammatory process has occurred. It's a complication of neuropathy of the foot, usually motor neuropathy, and it does have an acute phase. And during that acute phase, there's bone and joint destruction, fracture and laxity of ligaments. And due to the lack of sensation in the foot, it doesn't hurt the person, or it may have a bit worse pain. So someone that I looked after that had an acute Charcot, he said to me, it hurts a little bit when I get out of bed and first put my foot to the ground, but if I keep walking, the pain goes away. But of course, all the time, basically his foot is inflamed and the architecture and structure of his foot is collapsing. All right, so it presents as acute erythema, edema, and increased foot temperature. So what happens? These people go off to their GP or sometimes even an ED, and what do you think they get told? It's an infection. So they get put on antibiotics and sent home. And so the actual process is not managed appropriately. And then, of course, what happens is once the inflammation sets, that foot basically remodels where it's all fallen into. So if you are looking after someone with neuropathic complications of their foot due to diabetes or other things, because the man I spoke about actually didn't have diabetes, he had neuropathy from another cause, please contact your colleagues in a high-risk foot clinic, or if it's after hours, whoever the vascular reg is on call at a public hospital. And if you're from the country, at least make a phone call, you know, if they can't get down. Because if you can get onto this quickly, you can minimise the damage that's done by this process. Because if any of you have looked after anyone with these type of feet, this is really, really difficult management. And you can see the altered foot architecture that that person now has to live with for the rest of their life. So as you can imagine, if you're looking at the gentleman on the far right, who was the one I was talking about before, how the hell do you offload that? That's just really, really difficult management. Yeah. Okay, then we're going to talk a bit just quickly about pyoderma. I've got a couple of minutes left. pyoderma gangrenosum, an autoinflammatory disorder, and it's often associated with other inflammatory and autoimmune conditions such as Crohn's, rheumatoid arthritis, those sorts of things. Not always, but there's about a 50 to 60% history that they'll have those conditions. It usually develops rapidly, skin breaks down rapidly. Wound edges are often described as violaceous, which is purple, but they can also appear black and they may undermine. A couple of hallmarks of pyoderma gangrenosum is that it's extremely painful. So even quite small, superficial looking wounds are excruciating for the person. And the other hallmark is pathogy. So pathogy means that if you traumatise or sharp debride or even aggressively mechanically debride that wound, it will actually make it bigger and worse. And sometimes, I have to say, there are still occasions where pyoderma is diagnosed when someone is sent, and this is not a criticism of plastic surgeons, but someone is sent to a plastic surgeon for a skin graft and they excise the wound and make things a lot worse. If you think you've got someone that might have pyoderma, in the first instance, I would encourage you to either refer or discuss with a dermatologist. Yeah. And this is what it can look like. So that bottom picture there is actually what the man who I showed you before, who I used pomegranate Prisma on, that's what his initial wounds looked like. I mean, he had some wounds that were dinner plate sized. Yeah. So this one up here shows the characteristic sort of dark, almost black margins. And the other thing with pyoderma, it often heals with this, what they call cribiform scarring. So as you can see, that's not normal, just edge epithelial creep. You get this almost cruciform type scarring. Yeah. And lastly, vasculitis, which is an inflammation of the blood vessels. So this can involve all types of blood vessels, although it's most commonly seen in the skin, which is known as cutaneous vasculitis. It is occasionally systemic, has various causes, but in fact in a lot of cases they can't identify a cause. And it does have various clinical presentations. Usually treated with systemic corticosteroids, and again refer either to dermatology or a vascular specialist for diagnosis and treatment. And as you can see, it does have various clinical presentations. In fact, some of them don't look a lot different to meningococcal if you're looking at spotty black dark marks, but they usually happen often on the lower limb. So if you're seeing anything like this, get some help and assistance for that person. So in summary, chronic inflammation leads to hard to heal wounds, requires multiple strategies to manage. Go back to your principles and evaluate what you're doing, and if it's not responding, do something different. And remember that inhibiting MMPs is only one of many different mechanisms which improve healing of chronic wounds. And I have my references at the end. Thank you.
Thanks, Sue. That was fantastic. I hope you can take away some really useful background knowledge as to why wounds get stuck in that inflammatory phase of wound healing. Our next speaker, we've got talking about morbid obesity. As we know, we've got more individuals who are morbidly obese. They suffer chronic skin changes and risk for skin breakdown is increased. Our presenter is Sandra Rydins, a nurse educator at Flinders Medical Centre. Please welcome Sandy.
I believe we've got some unwelcome guests appearing over on the right-hand side over there, so I'm sure they'll sort that out after break. Okay. So, we're talking about a very large inflammatory process here. So a lot of what you've heard previously with regards to wound presentations will also apply in this presentation. So this is Luann Brown. She's a mum and she's a pole dancer. It's an extremely demanding activity that requires a high level of fitness, determination and drive. Confidence in yourself, your body, strength and training. Luann says she's never felt sexier. She challenges our view or our common perception of the obese patient as they come into our healthcare sector. Coming into an acute care hospital for treatment is a dangerous journey at the very best of times, and if you're bariatric or obese, it's even more dangerous. Diagnosis is more difficult, procedures are technically more complicated and more time-consuming, and the healthcare environment has not been designed, for the most part, with sufficient space to cater for larger-sized people and the amount of specialised equipment that they require for safe and dignified care. Bariatric equipment is sparse, there is insufficient numbers of staff available for timely care, and knowledge on how to use the equipment, safe manual handling, and generally how to care for the very obese is lacking. Physically, bariatric patients often have complex and multiple comorbidities and experience mental health issues such as depression and low self-esteem at a higher rate than the median population for their age group. 80% have reported negative experiences with the healthcare system, and many are reluctant to participate in preventative screenings or attend to medical clinics for medical problems early along, out of fear of embarrassment, fear of discrimination and ridicule by nurses and doctors. It's the new discrimination in the healthcare sector. As a cohort, they are a group of people not well managed by our healthcare system. Skin care is a major part of the wellness care with which this patient requires special considerations. As nurses, it's our role to be aware of and work with these patients to prevent and manage any skin complications they may come in with. In this presentation today, I'm going to share some of my learnings on the extent of obesity in South Australian society, a bit on the reasons why people become obese, briefly outline some of the health problems they face with a focus on skin problems and wound healing. The take-home message is to work with the very obese person, think outside the square, prevent issues from developing, because once a pressure area develops or a wound dehisces or becomes infected, it's a major and sometimes fatal event for these people. So, what are we talking about? Overweight and obesity are terms used to describe the degree of abnormal or excessive fat accumulation that presents a risk to health. A body mass index of over 25 is considered overweight, and over 30 is obese. Greater than 35 is severely obese. And BMI is calculated using a person's weight in kilos divided by their height in metres squared. For better accuracy on the risk and type of health problems, fat distribution must be considered, and a waist measurement is thought to give a reproducible measure for the risk of chronic health problems. The bariatric branch of medicine is that which deals with prevention, cause and treatment of obesity. SA Health defines a patient as bariatric if they meet two of the following criteria: if they have a weight greater than or equal to 120 kilos, a BMI greater than or equal to 40, or a seated hip width of greater than 51 centimetres. After adjusting for different population age structures over time, the prevalence of overweight and obesity among Australians aged 18 and over have increased from 57% in 1995 to 67% in 2017 and 18. So almost 2/3 of the people that we see will be either obese or overweight when they come into the hospital. So they're going to come in with comorbidities that are going to make management of your chronic and difficult wounds technically and manually difficult from these people. Obesity is more common in the older age groups, with 41% of 65 to 74-year-olds found to be obese, and it's more common in the lower socio-economic areas with 38% as opposed to 24% rate in the higher socioeconomic areas. I run a bariatric workshop, and we have a really lovely psychologist who comes in and talks about why people become obese, and it's a huge area as to why. It's the very beginning of obesity and the issues associated with obesity, which leads to the complications that we need to have a look at. And as one of the consumers says, it's easier to eat junk and be obese than what it is to live healthily in today's society. The distribution of BMI among persons 18 and over, you can see from the lower line being the light blue line, you can see that we are tending more towards obese, a population that is more obese than overweight. We've been overweight for a while, now we're becoming more obese. So briefly, how does obesity develop? Obesity development is a complex interplay between psychological factors and subsequent behaviour, the environment and genetic factors. Psychologically, there's many reasons why an individual can turn to food for comfort and go on to develop an eating disorder. These include sexual abuse, bullying, injury, and isolation. There are also personality traits that have a multifaceted impact upon body weight and propensity for obesity. And these include an emotional instability, if you're an anxious person, if you worry a lot. Equally, if you become obese, you're likely to become depressed. If you're depressed, you're likely to become obese. Environmental factors that contribute to obesity include increased availability of high energy and high fat foods. It's so easy to get now. A lot of people are eating away from home, convenience eating happening. Portion sizes are getting larger. You ever been shopping for a dinner service lately and seen how big they're getting? Almost so you can't fit them into a dishwasher, which is a disaster. People have limited access to physical activity, so COVID's going to have a big impact upon the weight of our population in general, and we have lots of labour-saving technological advances. Biological studies have revealed there's a genetic component in the tendency towards obesity, and there are some genetic disorders that actually cause overeating. And despite their larger size, many bariatric patients are malnourished, which has implications for skin health and healing. Okay. All right, so at its most basic level, obesity develops when calories in exceed calories out and the body stores excess calories as fat or white adipose tissue. Food enters the GI system and begins the digestive process in the stomach, with nutrients being absorbed by the intestinal villi. In a healthy individual, the increased blood glucose increases in insulin and other chemical messages, and glucose, amino and fatty acids are taken up into the cells. With enough energy for normal function, these happy cells send out chemical messages to say, hey, we're no longer hungry, can you please stop eating? However, at some point in healthy individuals, no one really knows why, the ability to recruit new adipocytes from this situation becomes impaired. Because as they absorb more fat and become full, they'll send out chemical messages to release more adipocytes from the bone marrow. Adipocytes or fat cells come from the bone marrow. They're released in response to increased levels of fatty acids. But in some people, for some reason, the increasing the balance between the release of adipocytes from the bone marrow and the storage of them and the ability to store the fatty acids is impaired, and so you have an imbalance occurring between production of new adipocytes and the current adipocytes that are there. So as the adipocytes begin to swell, they begin to function more and more abnormally. People used to think that adipose tissue or adipose fat was just a benign fatty nuisance, and it's not. It's a metabolically active tissue which secretes a lot of chemical cytokines, in a lot of inflammatory cytokines. So as the swollen adipocytes secrete chemicals and adipocytes, they can cause insulin resistance, resulting in type 2 diabetes, increases in circulating blood glucose levels, With insulin unable to be effective in enabling glucose uptake into the cells, they send out chemical messages that stimulate hunger responses, and these people actually believe they're starving. They feel like they're starving because that's what their cells are telling them, because their insulin, the food, is not getting into the cells. Additionally, as the adipocytes swell, the blood supply to the fatty tissue is decreased, which has implication for absorption of drugs by the subcutaneous route and the ability of the skin to tolerate stress, healing and trauma. Oops, I've gone back. Okay, so you can see that as the adipocytes swell and they produce more inflammatory cytokines around here, they bring in more inflammatory cells. You can see they're actually squashing out the blood supply and the microcirculation. So adipose tissue is very poorly perfused with the microcirculation. The cells are very abnormal. You get ectopic fat deposits in sites not normally known for fat storage, such as in the liver. Around the heart, you can see the top one is a normal heart and the second one is a bariatric or an obese person's heart. The fat is around the heart there, and it's not only around the heart, it's within the heart. So these people have arrhythmias as well as constrictive cardiac disease. So they have problems with their metabolic system and their ability to perfuse their skin. And we know how important perfusion is for wound healing, because that's how the nutrients get there, that's how the oxygen gets there, and that's how the wounds heal. So you've got all these problems already in the healthy bariatric patient before they've even got complications relating to having a wound. I'm not going to go through this because of time, but you can see that there are multiple comorbidities associated with being bariatric or obese. So when they come into the hospital, I think the major ones we need to worry about are the restrictive respiratory disease, because that's going to affect our ability to position these patients so that they can breathe and stay alive whilst we're changing their position to prevent them from getting pressure sores. So I'll leave you to read through these. I believe you get opportunity to have a look at a copy of the presentations a little bit later, and there are extensive notes, as you'll sort of realise as we go along. So what are the skin changes in obesity? There's a suggestion from animal studies that obesity weakens the collagen structure. There's insufficient collagen deposition to match the increased skin surface area. The abnormal collagen structure, reduced capillary circulation and increase in inflammatory cytokines results in slower wound healing, increased risk of pressure sores and increased risk of infection. The skin's normal function is a skin barrier. It prevents infection. It's involved in temperature regulation through water loss and secretions from the glands. Exact mechanisms are not well understood, but it's known that obesity leads to physiologic changes in the skin, and that these have an impact on the health of the skin and the general well-being of obese patients. Many of these changes increase in severity and frequency with increasing obesity. Transepidermal water loss has been reported to be decreased, resulting in areas of dry skin with areas of redness, and you've already seen emollients, that long word, that can be used on that. There is often an increased sweat gland activity in obese patients, particularly with the skin folds where there's increased heat, and the resulting moisture, warm conditions and skin-on-skin friction leads to irritation and increased risk of infection and inflammatory skin conditions. Increased sweating can make the obese individual very uncomfortable and self-conscious. There's often obesity can impede lymphatic lymph flow and can lead to collections of lymph in the subcutaneous tissue called lymphedema. And this can lead on to fibrosis and chronic inflammations, and can lead to the development of fibrotic tumours. And these sort of fibrotic tumours in the very obese can only be treated surgically. There's no other way to remove them when people get to that particular point in time. Obese patients also have an increased incidence of skin dermatoses and skin diseases, and these increase in frequency with increasing BMI. The impact of body shape is important in predicting skin problems. And this is probably the area where I'm a little bit more comfortable with than the pathophysiology of obesity. Okay, so nobody is quite sure why particular individuals lay down fat in a particular pattern, although genetics are implemented. The most high-risk pattern is the apple distribution, where fat and fluid collects around abdominal organs, and it's characterised by a high waist to hip ratio. These people have a high association with metabolic syndrome and cardiovascular disease, as well as having difficulty lying on their back to sleep. So they require pillows or elevation at the head of the bed to shift their abdominal weight down so they can actually breathe. Lying flat for any length of time can lead to rapid decompensation, collapse and death. So someone we can't actually lie flat to do wound care with. Their ability to walk and mobilise is limited due to difficulties with breathing due to the constrictive effect of the adipose tissue, so they often experience chronic hypoxia and hypercapnia. They can't see their lower body parts and may have personal hygiene issues in the perineal areas. They experience stress incontinence, which is more likely due to the weight of the abdominal tissue pushing on the bladder. Accumulation of subcutaneous fat in the lower abdomen can lead to the development of a hanging mass of subcutaneous fat called an abdominal apron or a panniculus, and there are several grades of panniculus, as you can see. Complications of a panniculus can include herniation and strangulation of the gut. Grades 3 and above lead to shortening of their seat depth and causes lordosis, and compromises their ability to sit, stand and walk easily, so they're more prone to fall. People with a pannus need to spread their legs very wide whilst they're seating, so they're going to need a very wide seat width to allow the pannus to hang between the legs. And it will often swing and move while they're walking. When we're getting people with, that are very obese with a pannus back into bed, we need to remember that as they swing themselves back up into bed, sometimes the pannus might go right over and they might end up on the other side of the floor. So we need to be really careful when we're moving and working with these people, and often we need to do things a little bit differently. The combination of the weight of the pannus, poorly perfused skin with abnormal collagen, heat, moisture and friction can lead to intertrigo or intertriginous dermatitis and pressure ulcers if not managed properly. Okay, so what is intertriginous dermatitis? You can see a couple of examples there. The principles are to minimise skin-on-skin contact and friction, and that can be really hard with managing obese patients because we don't have a lot of staff to lift up the skin folds and go through the skin folds and actually clean them and inspect them properly. We need to be aware of some of the mechanical aids that are available. There are pannus slings, there are limb slings. A lot of people that come to the workshops don't really have much awareness that you can actually purchase single patient use limb slings, which you can use, and use mechanical lifters in order to be able to inspect these patients' folds and keep them clean. Areas at risk, it's important to keep them clean and dry, to clean them gently, patting them dry, and utilise a sling and lifters to support the pannus. Another thing that's important is to use some sort of absorbent material between the folds to try and absorb some of the moisture and prevent some of the friction that's around the place. So I brought along these couple of things because I thought, as a patient at home, how would you go about doing that? In hospital we use combined dressings, but a lot of these people are managed in the home. And I came across these little designs. These are called Pambris tummy liners. And the idea is that people can buy these on the internet. They're just a cotton fabric outer with an absorbent inner, and they tuck in under the pannus, and the weight of the pannus holds them there. Because one of the things that's important with whatever you put in under the folds of skin to absorb the moisture and prevent the friction, you don't want it to be too bulky, because if it's too bulky, the pressure of the dressing itself or the secondary dressing can lead to pressure ulcers and make things very more difficult to manage. So I've got one of those people can have a look at. That came from America, and it was considered a biohazard. It was held up by quarantine and x-rayed for some time. Oops. We've also got one here. This is available locally, and it's handy to tell patients things that they can do at home for themselves, because if we can prevent them coming in such a bad condition to start with, we can focus in on the other health issues that they come in with. And this is something that they can do. These are brow liners, which are locally available from the chemist shops. They're only about $8 each. And they're washable. You tuck them under their bra, and it can prevent some of the intertrigus dermatitis that we saw in some of those pictures there. Okay. So removing any further irritants. So if your patient is being incontinent, you might need to think about urinary catheters, and you might need to use barrier creams to protect and prevent the skin from further irritants. It's important to use fabrics that wick moisture away from the site with the skin. And I notice there's a few lovely products down in the trade tables there now that actually do this sort of thing. They have them over in America, where they have a huge problem with obesity. They have hospitals specifically related to care for obese patients. They'll often have these wicking solutions or wicking dressings on rolls, so that they can roll them out like baking paper and use them for their patients to help try and prevent these conditions from happening in the first place. Okay, so the body shape of a pear. Pear distribution involves the deposition of excess adipose tissue around the thighs, either medially or laterally. Comorbidity-wise, these patients are a lot healthier than apples. They have difficulties with side lying in bed and with seating, and they require a much wider normal seated width. Areas of concern for patients who are pear-shaped, and also for obese patients in general, are the development of atypical pressure sores. Our patients, our very obese patients, you need to inspect all of their folds. Look for folds in unusual places. There's folds where you wouldn't believe there could be folds, but you need to go in and do a really thorough assessment of all of their skin folds when they come into hospital, and apply those general principles of keeping them clean, dry and separated wherever possible. In 1 to 2 hours, patients who are obese and have this poorly perfused fatty tissue can develop quite big pressure areas. Where you've got a bony person and their skin's overlying the bone, the pressure area happens quite quickly and it's quite red. With the obese patient, the pressure injury can happen from within, because the poorly perfused skin, you've got the weight of the poorly perfused skin going there. It's quite a deep pressure area, and you can end up with these unstageable pressure sores, which by the time you actually... Okay, there was a picture there of a rather large pressure sore, but they can be quite deep and unstageable by the time you actually get in to see them, and that can happen in as little as 1 to 2 hours. The other body shape that we see with our patients is the gluteal shelf, and this is where the adipose tissues locates around the person's buttocks, producing a rear protruding mass. These patients have difficulties with personal hygiene, rolling and turning in bed, and the person's centre of gravity is altered. People who come in with all these unusual body shapes, and we're taught manual handling techniques, we're taught how to get people out of chairs, we're taught how to position people with pressure sores that, to prevent pressure injuries, as will come out. These people, the key message with their body shape and looking at them, as well as looking through the folds, is that they don't move. They don't move like we do. They move differently. And it's important to talk with these people and look at how they do things in their home, and involve them and talk with them to think about how we're going to do the care that they require. Because if they're involved and they're given a reasonable amount of respect, they'll engage a lot more with what they're doing. Just briefly to finish off, because I know we've got lunch coming up, we've got some candidiasis in the fold, so treatment may be both topical and systemic with antifungal agents. These are very common, and often the patient won't know that they've got them because they just can't see They can't see, they rely on us to be able to do that. This is a condition known as erythemus. It's a common skin condition which affects the skin folds, armpits and groins. It's caused by a bacterium, Corynebacterium minuticium, and it's characterised by slowly enlarging patches of pink-brown skin with defined edges. It may be symptomatic or cause itching, and the treatments with topical antibiotic cream and antibiotics. The proportional body shapes, they experience a proportional deposition of fat all over the body. The issue with proportional people might be intertrigo under the breasts, and this can be both a concern for men and women. Women, when they're in hospital, keeping underneath the breasts clean and dry. We've got, as I sort of said, we can use something like this in the community. In the hospital system, we're looking at keeping it clean and dry. They may need a supportive bra while they're in hospital, and I find that more comfortable. And even men could probably benefit from a bra, but I think you're not likely to find much buy-in from that particular perspective. You've had the podiatrist talk about issues with difficult wounds on feet. All wounds in obese patients are difficult. Patients who are very obese always look at their feet as well as their skin fold. Their centre of gravity has changed, the way they move and they walk has changed. They get calluses, and the way their weight is distributed and carried over their feet changes. So always be aware of looking at the feet, and podiatry referrals. And a very common one are the acrocordons, which are just, we think of them as little tiny skin tags, but they can be very difficult for men and women to manage because they can get caught in ladies' bras and be tugged on and cause bleeding and pain as you go along. Skin issues, shear injuries are very common in the very obese. Always consider using the slippery SAMs and any other equipment with regard moving these patients to prevent shear injuries. And of greatest importance is partnering with the patient, consumer and the family. Teach the family and the patient how to assess the skin, how to look in the skin folds, the importance of keeping the skin clean and dry, how to moisturise the dry areas of the skin, but use fabrics and things that they can make at home to keep the skin folds clean, dry. Recognise the early warning signs of problems, help them with improving their nutrition, and that's a whole different kettle of fish, and accessing community supports if required. There's not, in summary, bariatric patients present multiple nursing challenges and are vulnerable and often stigmatised patients. They're at high risk of skin problems due to physiologic changes in their skin. They have extensive skin surfaces and often deep folds which trap moisture, heat and are prone to friction. When hospitalised, it's really important to keep these patients as mobile as possible to prevent deconditioning, improve gaseous exchange and prevent pressure injuries. Their wounds and pressure injuries tend to be larger, deeper and more difficult to heal, so prevention is the key. Okay. Thank you.
Sorry for leaving my mask. Sorry. Sandra, can you just hang around, Sandra, just 2 minutes? I haven't been doing my job properly, which wouldn't be for the first time. But can I get Sue and Tal back up here, please? With Sandra. Do you want to come around there, Sandra? So as an appreciation for your time, we know it takes time to put these presentations together, and then your time today to present them. There's a little gesture from us at Wounds Australia. So, Sue. Thank you. And that brings us to lunch, which I think is ready. So go and enjoy, and then we'll come back this afternoon.
what's the matter here? I'm waiting, son. Waiting on Roosevelt. I'm waiting on Roosevelt. The rent was due and the lights was out. I said, tell me, mama, what's it all about? We're waiting, son. Waiting on Roosevelt. Just waiting on Roosevelt. My sister got sick and the doctor wouldn't come because we could not pay him the proper sum. Awaiting. Waiting on Roosevelt. We're waiting on Roosevelt. Then one day they put us out of the house. Ma and Pa was meek as a mouse, still waiting. Waiting on Roosevelt. Still waiting on Roosevelt. When they felt those cold winds blow, didn't have no place to go. Pa said, I'm tired of waiting on Roosevelt. I can't get a job, I can't get no grub. Backbone and navel's doing the belly rub. I'm tired of waiting on Roosevelt. Tired of waiting on Roosevelt. What's hungry and cold done stop believing what they've been told by Roosevelt. Roosevelt. 'Cause the pot's still empty and the cupboard's still bare, and you can't build a bungalow out of air. I'm tired, Mr. Roosevelt. I'm tired. Oh, I'm tired waiting on Roosevelt. Mr. Roosevelt, listen, what's the matter here? Damn tired of waiting on Roosevelt.
Welcome back, everybody, for our afternoon sessions. Hope you've all enjoyed the sessions so far and the food. It's been amazing. So the next lot of talks, we're going to do a speed presentations. So I'd like to introduce our first speaker. That's Frank, whose name I always find it hard to pronounce. Guerriero. Thank you. He's a vascular nurse practitioner at Flinders Medical Centre, and Frank is presenting the management of cellulitis. So please welcome Frank. Thank you.
Like 9 minutes to present a topic was always an interesting task to be set. And originally I thought I was presenting both venous disease and cellulitis in one talk. So I've got an extra 4.5 minutes, which is great. The Infectious Diseases Society of America outlines cellulitis and erysipelas, which is a superficial skin infection, as a diffuse superficial spreading skin infection in their practice guidelines. You'll find all sorts of definitions for cellulitis if you go digging through the internet or textbooks, but this is nice and simple and straightforward. When diagnosing cellulitis, some pretty hard empirical stuff, some blood cultures to see what potential bacteria you're dealing with and whether it's gone bloodborne or not. Blood tests to give us some biomarkers about infection parameters like white cell counts and C-reactive protein, etc. And microbial swabs if there is an obvious wound. There's not always an obvious wound. Close inspection of the lower limb, any pre-existing wounds or any other vectors for pathogens to enter the tissue or blood, such as peripheral lines, eczema, cracked eczema, those sorts of things. A clinical history where we focus in on the patient's immune status, in particular looking for immunosuppressions, whether they've got cancers or they're on medications or treatments that compromise their immunity, whether they've been exposed to animals or animal bites, travel, been anywhere, recent surgery or trauma, or whether they're on antibiotics and what type of antibiotics and how long they've been on antibiotics is really important as well. It's more common in lower limbs. It's often unilateral, true cellulitis. It doesn't affect both legs. So you're seeing inflammation in two legs, probably not cellulitis, and a really rare occurrence. And it's commonly associated with some classic underlying conditions. And you'll note that all of these conditions involve the compromise to the dermis. So there generally has to be a vector for the pathogen, the bacteria, to get inside the tissue and start causing havoc. So tinea, fissured dermatitis, we see lots of that. You guys see lots of that, those of you that are in the community. Lymphedema, deep vein thrombosis, previous deep vein thrombosis, and venous disease. So these all kind of are pointing towards edema-type disorders where we see cellulitis or recurrent cellulitis quite common. All right. These are taken from those IDSA guidelines. They like to classify things in this mild, moderate, and severe. There's no real hard and fast rule. So mild cellulitis is considered to be erythema, inflammation with associated pain, swelling with no focal purulence, so no collections or pus coming, obviously coming out anywhere from any deep collection. So the picture that we have here, and let's see if Frank can actually work this thing. Oh, here we go. You can sort of see here that's probably on its way to moderate cellulitis because we've got a little bit of lymphangitis. We've got spreading of the redness going up the leg here, but nothing too serious, no obvious wound with this as well. So it's probably more towards the moderate side of things, that picture. Moderate, we start to see signs of systemic infection. So patients will typically have either a temperature, tachycardia, high breath rate, and potentially some biomarkers that are out of whack as well, like a elevated white blood cell count, neutrophils, or elevated C-reactive protein that has deviated from baseline. So it's really important that you know, if possible, what the baseline is of these patients to know whether they run normally elevated C-reactive protein counts from other inflammatory diseases, or whether it has actually begun to skyrocket and deviate. Severe infection, we see all of those systemic signs, plus a failure to respond to antibiotic treatment, particularly oral antibiotic treatment, and in particular in those patients who are immunocompromised, and those with any signs of deeper infection, such as a bullae. So you can see, I can get it there. Yep, so this kind of rupturing of the skin there, skin sloughing, which is similar to that, and or associated organ failure, which is pretty severe. It's pretty obvious that someone's in that level of distress. All right, so treatment for true cellulitis. Well, mild cellulitis, if you can catch it early enough, oral antibiotics and some outpatient management, is a good starting point. A visit to the GP for some antibiotics and see if we can keep it locked down. If within 48 hours we're not getting good traction, then it's time to start escalating these patients, and they're beginning to they're not responding. The erythema is continuing to progress up the limb spread, and the patient's getting sicker. And or the wound, if there is an associated wound, is deteriorating, then we would consider that transitioning to moderate and or severe cellulitis. And in that instance, those patients are going to need intravenous antibiotics and most likely hospitalisation to manage that, unless there's a hospital at home system that can manage these patients. Just a quick couple of tips when you're dealing with these patients is if you can mark the erythema with either a permanent marker or a surgical marker, something that's not going to come off very easily, so that we can see where the margins of the erythema are when they rock up to hospital, and then appreciate whether the erythema is extending or whether it's stagnant, that sort of thing. If there's wound present in context of a mild cellulitis, we commence topical antimicrobials or antiseptics if they're not already being used. Commence some topical antiseptic therapy, sorry, I've already said that, and consider increasing the frequency of their dressing regime, even if it's perhaps not indicated in context of moisture balance, but what you're doing is adding your clinical maintenance or your clinical monitoring of the patient. And I know from tertiary to community, I love it when community nurses step up their clinical monitoring of patients, because I just feel things are safer that way, and I know that they're going to get escalated earlier if things go south. Like you've probably heard 1,000 times today, address the underlying etiology for treating these sorts of things. All right. Some things that are not cellulitis. This picture here is a picture of some venous-related excoriation secondary to pro-inflammatory exudate. In these wounds, we know that the exudate is toxic. It has pro-inflammatory enzymes that will denude and damage the skin, and so we see this kind of glowing denudement and damage to the skin here. That's not cellulitis, and neither is this hemosiderin staining that's up the leg here. You'll note that generally won't change. All right, next slide. This is not cellulitis. We've got some erythema, yes, but it's in a very square classic pattern. So that's definitely in keeping with more of an allergic reaction to either an adhesive dressing or potentially exudate that's tracked up into those margins and stayed in contact with the skin and caused that inflammation as well. We've got some venous eczema here. So again, this is not cellulitis. Blanches easily. It's again associated with what looks like a classic sort of venous-looking ulcer. Yeah, enough said about that really. I've only got 9 minutes. Ischemic rubor. Okay, so this is actually fairly serious, but it is not cellulitis. So where we get this kind of redness, and in particular one trick if you're wanting to differentiate between cellulitis and ischemic rubor, lift the leg 20 degrees or higher, and if the foot or the limb that you're suspecting the ischemia is affecting goes pale, you've got a pretty good starting point for guessing that is potentially ischemic rubor. In particular, it being associated, it being associated with necrosis, distal necrosis, is a bit of a giveaway as well. And this patient in this picture here has got wet gangrene, which is a bit of a problem. So actually, that can potentially become cellulitic, and that's absolute disaster zone. But where it's just that funny redness that goes pale when you lift the leg, that's rubor. That's still a medical emergency, and that patient needs urgent referral to a tertiary service with a vascular service preferably. All right. So, how am I going for time? I felt like I've whipped through this. 2 minutes, 1 minute, I can slow down. Cellulitis is frequently misdiagnosed. It's rarely bilateral. It's always related to a compromise in skin integrity, but that may not be obvious. The pathogen, the bacteria, has to get in somehow. And that can be something as subtle as those very subtle, occasionally weeping, largely edematous legs with that cracked, lipodermatosclerotic skin, hard cracked skin or cracked dry skin. That can often be a bit of a giveaway that there is, that's the vector in which it's gotten in there, or, tinea, cracks in between the toes, things that aren't necessarily obvious. Antibiotics is first-line treatment for cellulitis. For that mild category, oral antibiotics, and again, underlying etiology, prevention is always better than cure. Spreading erythema, which doesn't respond to oral antibiotics within 48 hours, needs to be escalated either by a medical officer or off to a tertiary hospital to be reviewed. Thank you.
So next we have Sarah Christie and Rebecca Daebeler presenting the management of diabetic foot ulcers. Please welcome them. Thank you.
So in the interest of time, we went one person so we could keep speeding past. So full disclaimer, this is only a real brief touch on diabetic foot given it's a 10-minute window. So hopefully it's practical. So I guess looking at the, sorry, I'll get my clicker working. The big picture is Diabetes Feet Australia define diabetic foot disease as ulceration, infection, ischemia or neuroarthropathy of the foot in people with diabetes. So people are at risk of diabetes-related foot disease if they have developed peripheral neuropathy, peripheral arterial disease or have a history of previous foot disease. Diabetic foot disease is globally recognised as the leading cause of diabetes-related hospital admissions and amputations, with mortality rates comparable to many cancers, so that's pretty scary. And diabetes kills more people annually than breast cancer and AIDS combined. And just looking, I guess, a day-to-day picture in Australia, there's 50,000 people living with diabetic foot disease and 12,500 Australians living with diabetes have a related amputation, and today 12 Australians are undergoing a diabetes-related amputation. So the pathogenesis of the diabetes-related foot wounds. So people can have all or some of these factors. So if we look at sensory neuropathy, it essentially is the loss of that pain sensation. So, you know, pain is actually a gift as it's an early warning sign that something's not quite right. So generally, you know, how it happens is they lose that pain and sensation in their feet. They'd undergo an unnoticed trauma, so maybe they've stepped on a piece of glass that's broken the night before. The lesion progresses because it remains unchecked. Maybe they haven't seen the blood trail, maybe the piece of glass is still stuck in there. They then develop a callus formation, which then leads to tissue necrosis and damage of the cells beneath the callus. This leads to then development of cavities filled with serous fluid, which end up erupting and results in an ulcer formation. Motor neuropathy, so we have this weakness and wasting of the intrinsic muscles of the foot, which leads to our foot deformities, leading to an abnormal gait. Higher pressure areas leads to ulceration. Foot deformities as predisposing ulceration. So you can see in this picture, Sue touched on it earlier, but you know, some complications of a Charcot foot. But you can also get wounding from nail deformities, you know, those thick mycotic nails causing pressure, couple that with poor fitting footwear. Those people with a really, what we'd call a pes cavus foot, so high arch profile, those with a pes planus, the really pancake feet, and also developing things like bunions. So autonomic neuropathy, this is something really classic that you'd see in the diabetic population, especially coming into summer as well, when everyone's got their thongs on. So you have a decreased sweating and you develop that dry and brittle skin, leads to the fissures, leads to an infection and subsequent ulceration. Then you have the element of vasculopathy. So, you know, this cohort are developing you know, macrovascular complications, atherosclerosis, narrowing of the arteries, but they're also susceptible to those microvascular complications, which then impairs their wound healing. So we know that peripheral arterial disease is generally caused by atherosclerosis, and it's present in up to 50 patients with a diabetic foot ulcer. And basically, you know, that's going to impede their whole healing journey as well. And there is a small percentage of foot ulcers that we'll see in this population that will be purely ischemic. And there might be those typical ulcers that follow a history of trauma. So also with our diabetic population, they're immunocompromised, so they have impaired defence against infection. So they have a decrease in that polymorphonuclear leukocyte migration, decreased phagocytosis, and chemotaxis. So the neutrophils act as our first line of defence, and the reduction of their functional activity contributes to high susceptibility to and increased severity of their infections. And ultimately, the high blood sugar from diabetes can affect the body's immune system, impairing the ability of white blood cells to come to the site of infection, stay in the infected area, and kill the microorganisms. So we sort of touched on this briefly before, but if you've got bony prominences, your joint mobility is reduced, you've already got callus formation, you've had some complications, you're a frequent faller, you're walking barefoot, you're on your feet all day, you're more susceptible to these ulcerations. Then couple that with loss of feeling in your feet and reduced blood supply. So the diabetes-related foot ulcer treatment. So we know that foot ulcers will heal in the majority of patients if clinician bases the treatment on the following principles. But we understand with even optimum wound care, we can't compensate for continuing trauma to the wound bed and for inadequately treated ischemia or infection. So there's essentially 7 things that underpin our treatment of a diabetic foot ulcer. So 1, we take the pressure off and we protect the area of ulceration. We aim to restore skin perfusion, so working strongly in an interdisciplinary care team, liaising with our vascular colleagues. We treat any infection. We get their metabolic control as best we can. So again, placing in that interdisciplinary high-risk foot clinic, we have access to endocrinology and our diabetes nurse educators. Local wound care, so from a podiatry point of view, we tend to be the ones that probably see them in between all their big appointments and those big multi-D case discussions in alliance with, our community nurses, or if they reside in residential care, or, they're making that choice to care for their wound in the meantime. We really focus on education of the patient and their relatives, so understanding their goals and understanding that, what they do outside of the treatment room plays a really big impact in their wound healing. And then we aim to prevent the recurrence. And, with all of this care, like we said, you need to look at the whole patient. So what is their social situation looking like? What are the local resources actually available for them and the infrastructure? And for some of these people, it may not be something that can be managed in an outpatient setting. They may need hospitalisation. So I'm not going to plug this too much because Beck already covered this, but essentially, them coming into our clinic, we're providing that ulcer care, but we're also that, pathway forward for escalation and linking them in with other services. So steps in the right direction. So as Beck mentioned, time is tissue. And it's scarily that 75% of ED presentations for people with diabetic foot disease or infections have actually had no previous contact with a multi-D high-risk foot team. And they tend to then present with more severe infections. So, a lot of work going into primary health and early identification and making sure people are linked in with those screening programs so that we can actually do something before, they get to crisis state. So this is a bit of a flow chart that's been developed in collaboration with a few people, but our Foot Forward for Diabetes and our National Diabetes Services Scheme. So essentially this will run you through a few things with diabetic foot disease. So it looks at what Frank said around the acute limb ischemia and chronic life-threatening ischemia, and obviously those pathways are really towards vascular specialists, or acute limb ischemia is to an ED in a tertiary setting with vascular on site. But in terms of our foot ulcers, if you're seeing someone in the community or, they're presenting to their GP with serious infection, it's a direct route to the ED. If they're presenting with some mild signs of infection, that's where you need to be linking in with your interdisciplinary high-risk foot services, so ideally a same-day referral. And I know departments, across the state and across the nation are working at really rapid access type clinics so that those people can be seen same day, or at least within that 24-hour period. And if they're presenting with no infection, they really should still be referred to that interdisciplinary high-risk foot care. And as a guide, they would be seen within that 5 days. So, their contact with the high-risk foot service may not be straight away into that multi-D clinic, but at least they're linked in with a podiatry service that can escalate their care as needed. So I just thought, I know there's lots of live streamers, but I'll just plug sort of, the main areas in SA that you can look to, and all have varying referral forms, hopefully, more aligned in times to come. So at Flinders in our south, we've got, we're based at Flinders, we've got a fortnightly clinic that runs, it's a true multi-D clinic, but obviously we're running Monday to Friday for our podiatry services, and obviously have a really close partnership with vascular, infectious diseases and endocrine, and also access to a dietitian, which makes that micronutrient pathway and optimisation quite nice for us. In the central areas, there's clinics that run out of the Royal Adelaide Hospital and the Queen Elizabeth Hospital. And in our north, we've got the Lyle McEwen. And obviously, a lot of work being done to make partnerships with our more rural areas, and so that people have a escalation pathway, and certainly doing more with telehealth as well. So I have whizzed through that. I'm going to set the record for the speed round.
So Margi's just following me. She's going to talk about hypergranulation. Thanks, Margi.
Oh, try to be quick. Won't need to go to the gym, will I? Right. So, where's my clicker? So this talk is about hypergranulation tissue, which is really a nuisance problem, and I know a lot of clinicians struggle with it. So this isn't hypergranulation tissue. This is beautiful. This is normal, healthy granulation tissue. It's flat, red, moist, and it's granular in appearance. Whereas this isn't healthy tissue, and this is hypergranulation tissue. So what is it? It's raised protruding tissue above the level of the surrounding skin. It may be paler or darker, and it appears boggy and edematous. It can occur over part or whole of the wound bed, and it's highly vascular. Doesn't mean that it's highly normal being vascular, and it's also called overgranulation or proud flesh. So what do we know about it? Well, it isn't viable tissue. It's not healthy tissue in a wound. It involves a prolonged or excessive inflammatory response, and in fact I've sent hypergranulation tissue off to histo, and it's just full of inflammatory cells. It can be linked to a bacterial burden, a foreign body, for example tubes, trauma or occlusive dressing, so it's not uncommon to see it around PEG tubes. And usually what is a common thing that I see is that there's moderate to heavy exudate, and there's an exudate imbalance that's not proportional to the wound itself. And many of the patients I have seen that turn up to the clinic with a prolonged period of hypergranulation have a non-absorbent, low-adherent dressing in place. One of those shiny things. So we know it impedes healing, it completely stalls it. You haven't got a healthy wound edge at all. And there's no defined management guidelines versus a number of suggestions that are out there. So I'm going to go through some of the strategies to deal with it, talk about the pros and the cons, and then present the way I deal with it, which may not be the right way. I may not be the highway. I like to think I am, though. So silver nitrate sticks have been around for a long time, but look at the description. It's a caustic pencil used to chemically cauterise. And with all of these things, in all honesty, I would never say never. But silver nitrate sticks aren't something that I use. So you can use them for when I'm debriding. If I've got a little capillary that's being a pest and won't stop bleeding, I'll use it for that. But I don't use it for hypergranulation. But it's recommended to destroy unwanted tissue, such as a wart or a skin tag, or an overproduction of granulation tissue. So it's out there recommended to be used as that. One of the things I don't like about it, we know hypergranulation tissue is really inflammatory, and we're about to burn the tissue, and it really only burns the top of the tissue, not the full layer, and that causes a trauma that perpetuates further inflammation. And you need to know what you're doing, so that you don't drip it everywhere. And what I've found is that you burn your pick, you burn your pick, you burn your pick, you burn your pick, and it just goes on and on and on. It's not expedient. So I have used it in the past. So that scab then created is a medium for bacterial growth. Topical corticosteroids, I think some of the plastic surgeons like putting these on wounds. They're not listed by the TGA for use in a wound. Certainly in dermatology we might use them around an inflammatory wound like pyoderma, but we don't put them in a wound. They're used to dampen the inflammatory response. So it's not, I see it more commonly with plastics that they like to use this. So we know that topical corticosteroids retard wound quality and healing. And for me, you've already got a fairly moist wound. You're adding a cream that's adding more moisture. So I question, with that further moisture imbalance, are you making it more inflamed despite putting something that's allegedly anti-inflammatory? It's slow, it's boring, and it's rarely successful. So there are dressings out there that you can use. So there are hypertonic saline dressings that you have to wet them to put them on the wound. And you're relying on an oncotic pressure that draws exudate away and reduces edema. So again, you wet them and you're putting wet onto a wet wound. You could consider honey. I've got a GP that's a little bit can't think of the area, but she makes the honey and she insists on putting it on hypergranulation. It's very slow, but you never say never. There's recommendations that if you use foams or alginates or hydrofibre dressings, so what that's suggesting is that we manage the exudate. And then you could consider an absorbent antibacterial dressing as well. So you can consider excision, and this sounds dramatic, but for me it's not a scalpel, it's a pair of scissors. So it's the quickest method. I usually test the waters and I say to the patient, can you feel that? And if they say no, I say, well, I'm just going to nip it off and I'm ready with lots of gauze because it will bleed, and to put the pressure on. So it does bleed a lot, but don't be troubled by that because it does stop, providing you check that your patient's not on warfarin or something like that. And then what you need to do after that is to prevent the return of that hypergranulation. So if you don't manage that exudate imbalance as well, you're not going to dampen that inflammatory response. So this is what I suggest, and it doesn't mean that you need to follow my direction. So where possible, cut it off. And what you're doing is that you're taking it back to ground zero. You're really literally going along the plane of the skin and taking it back to ground zero, and be aware it will bleed. And you test the waters first with your patient. Do you think you can feel that? And most of the time they say no. And if needed, I will put a topical anaesthetic on. That sometimes is more around tubes. That can be a little bit more tender, and I will certainly give them some little anaesthesia. I think just by pressure or having an alginate handy, you will get that hemostasis, and I don't let the person walk out of the clinic until I know I've got it, and it honestly doesn't take long. And then I will dress them with an absorbent dressing. I might think about silver if I felt there was a bit of a bug load happening. And then always a secondary dressing over the top of something like gauze, because it breathes and allows a little bit of air permeability. So you're almost trying to take that overly wet wound back to a slightly drier state, but you're not going to dry it out. And then I secure it with gentle pressure, often using something like a Hyperfix to just be able to put some pressure over that wound. And it's quick, it's gone. So there's some other considerations. Some people are nervous about using scissors, and if you're not confident, well then really you shouldn't be using them. But some people could use dry gauze and try rubbing it that way. In fact, it'd be interesting to see if the debridement pads had a role for, because it's very flabby, funny tissue, and you might be able to wipe it off that way. You can sometimes do nothing other than just managing the exudate, and that's sometimes not a bad option. So around tubes, hypergranulation can be painful, so I said that if I was going to cut it, I'd numb it first. And if you can't cut it, just use something highly absorbent around the tube to settle down that inflammation. So this was a man that had a lesion excised off his scalp, and he'd had a blob of hypergranulation tissue for 6 weeks. So I tested, I snipped, hemostasis, dressing on top, a highly absorbent dressing on top, and that was 1 week later, and then within days it was gone. Around a peg tube, trimming it off, then afterwards highly absorbent dressing. So I might as well tell you what I have on the shelf and what I use. We use Aquacel. And if I was worried about bacteria, Aquacel was silver. So it's just what I have on the shelf. And here's doing nothing but managing the exudate, a hypergranulating donor site that hasn't completed its healing process. So I did no excision because it was way too painful. Just put a highly absorbent dressing on, gauze, bit of tension. Look at the difference in the wound tissue. Look how paler and healthier it looks. And look at the profile. I love that picture on profile. It's just tamed it down in 4 days, no cutting. So word of caution, my final slide, make sure that it truly is hypergranulation and not something atypical like a squamous cell carcinoma, which this is. They're irregular surfaces, so again, goes back to knowing the diagnosis of your wound. So malignancy can take on the appearance of that irregular tissue. And it's essential that we get that history and assessment to ensure that we are truly treating hypergranulation and not something else. There you go. 6 seconds to go.
So we've got James and Beck next to present the challenging of managing malleolar ulcers. Please welcome Beck and James. Thank you.
Hello again. This hasn't been prepared too well. We would like some interaction, right? Beck's done more preparation than me on this. But we wanted to discuss malleolar pressure injuries and the difficulty around healing them and sort of discuss why that may be. We've looked into the literature around that and there's not much literature at all about why they are so difficult to heal. Personally, I don't know about other wound clinicians, I find them the hardest pressure injuries to heal. And even if you manage to heal them, which can take so much longer than all the other pressure injuries, whether that's a heel or a plantar foot, they recur so easily. And so you're scratching your head, getting really frustrated about why this is. But Beck would like to talk about something that's really good in terms of the most important treatment of pressure injuries, which is offloading or pressure redistributing.
And I must say, we take a bit of a cop-out podiatrist because it's not something we do all the time, malleolar wound management. We might handball that to our beautiful other colleagues. I actually did a little bit of a case study and I can show you a bit more of a practical thing about what we do in regards to an offloading modality, which is quite simple to make. So Mr. O is 85-year-old male, lots of comorbidities, lots of polypharmacy. That's pretty natural and normal for our cohort. I think he doesn't have diabetes though, so that's not really that natural for us. But this chap had a chronic and recurrent left malleolar wound. He had quite an inverted and fixed foot shape as well, which probably hasn't helped in regards to sort of function and offloading that area. This chap didn't have any OM, no osteomyelitis, which is something that you need to keep in the back of your mind. Obviously, it's not a very padded or protected area, so that the bones are never too far away, and he didn't have any soft tissue infection either. He had been using sort of heel comfort protectors in bed to help with shear forces. I think that's one thing just to keep in the back of your mind, that these sheepskin devices do not remove direct pressure. They are quite good for shear and frictive forces, so especially they're a little bit agitated and moving around a lot, but they do not take pressure away. He was also using a gel malleolar sock, but not very consistently, and he had heel lift suspension boots. That's an item that we have on stock within the acute system. It's used to take pressure off the heel, but you can manipulate a little bit to take pressure off the malleolar area as well. It's quite bulky, can get quite hot, and it can move around, so it's not ideal. But it wasn't worn at home. Again, one of those things you'll go into the ward situation and they're sitting on the windowsill. So obviously it's not the best modality. And obviously there have been discussions as well for the need to look at pressure relieving mattress at home, and he had an OT assessment in train, again, using our multi-D partners. So what we thought we might try, and this was actually Sarah, is look at a soft cast. Has anyone heard about what a soft cast is or does or looks like? Some nods. Yep, great. So the indication is to look at sort of treating pressure injuries, and it can be considered for use on ankle areas, posterior heel, lateral styloid processes, and that area around sort of bunion regions, whether that's on first big toe or fifth area, because you can get bunions on the fifth. But not on weight-bearing surfaces, so not sort of underneath the midfoot or underneath the ball of the foot. And its advantage is that you can really produce it pretty much straight away. It's fairly cheap to manufacture, and it can be used to prevent sort of and help sort of manage multiple ulceration sites, whether it's heel, ankle, lateral foot. It can be worn with footwear, it can be worn with normal footwear, it can be worn with post-operative footwear, and it can be used in bed. And again, it's quite good to consider when you've got agitated patients or impulsive patients, because a lot of the offloading devices that are used are not recommended for weight-bearing activity. It can be a falls and slip risk, but this you could use and put it, and not that I'm an advocate for non-slip socks, but you could put a non-slip sock over the top to make it a little bit safer if they're a little bit unpredictable. As I said, it's a contraindicated for plantar foot wounds. Okay, this is actually the cast that I've taken some photos. I'll pass it around. So basically, yep, thanks. So we've actually, I don't know, you can probably see this, we've sort of padded out this lateral area of the foot around the styloid process. So you can either do that with Ottoform, which is like a silicone product, or felt. We're actually using felt, which is here. So basically we cut the felt out to the shape and the size of the wound. Okay, this is 10mm felt, and we just skive the edges. And it sits over, so you cover the wound with opside, or the area that you're wanting to sort of offload. Cover it with the stocking, put the felt on, you can put another stocking over the top, where then we just protect the, sorry, my phone writer skills have got worse, I think. Just sort of protecting that sort of anterior area of the foot and the leg as well, just sort of adhere that. Again, that's just like a PPT or a rubber, but we can use some fleecy web. And then we use a product called Soft Cast, which is this, okay? So we wrap it around the foot. So the foot doesn't have to be in a particular angle at all, because this stuff is really flexible. As you can see with, where did the devices somewhere? Yes, it's really, it's soft, okay? So we wrap that around we can start from the proximal down to the distal area, and then we wind our way back up from distal to proximal. But before we sort of get back over to the area that we're wanting to offload, we would then add some harder material. So you'll see on that, it sort of forms a little bit of like an airlock, which will accommodate for dressings, but also sort of, it's almost like a helmet basically. So a helmet over the area that you're wanting to offload. So once we've put the hard bit in, we just use offcuts actually, because we're pretty savvy. Oh, we don't need quarter menthorin to help us. We use the offcuts from orthopaedics instead of using a whole new roll. So we just cut off, again, it's to the size. That's why this is really good, because it's got an adhesive back. So we just keep the shape of that, and then we cut exact shape out of the harder stuff. So you can just use Delta cast, but as I said, we just sort of recycle what's given to us. And then what we do is we cut it off. So we, oh God, wrong button again. Here we go. So basically we almost just bivalve it. So we just sort of cut from, you can either go proximal to distal, distal to proximal, doesn't really matter. But you don't want this to fully dry, because it's quite difficult to take off then. So you need quite sharp scissors. The blunt sharps are probably the best, because you can obviously just put the blunt bit on facing the skin, so you're not going to traumatise the skin. Then you can just shape around basically. So this one's actually designed for sort of that lateral area here. But if we were designing one around the malleolar area, it will sort of come up here and accommodate and cup and helmet that malleolar region there. So again, it's pretty easy to put on. And again, it's important to sort of relay these instructions either to the patient's care, or the facility they're with, or their family, whoever's looking after them, and to community nursing if they're visiting as well. So it can either just be taped in place, they can put a sock on, or a tubifast, whatever's needed. You can use this is I think Tubi grip. So you can keep it a bit longer and then just double it back to hold it on. But we can put buckles and straps and things like that on there, but just a little bit of tape to hold it on. And then we just sort of protect the edges of the device just with fleecy web. But as you can see, it's really very flexible. So they can wear that in post-operative footwear. They can wear it in bed. They don't really need to take it off, which can be an advantage. It probably takes about 20 minutes to make. So it's sort of an instantaneous offloading mechanism, and it's custom made as well. And it is important to sort of reinforce those wear instructions, because we have seen them put on back to front. So that's not going to be really that helpful. So as I said, it creates some protection around those sort of bony areas that aren't in a weight-bearing surface. So it's just another consideration. So this was made, and basically the next week this chap came in, his wound had resolved. We just got rid of that extra little bit of pressure there for him. And again, the challenge then is to keep that wound sort of healed and in remission. So he'll need sort of monitoring and maintenance from there. But yeah, it's just something to put in your toolbox, put that in your arsenal. So there's no right way or wrong way. It's a tool that you can possibly use. Anything else?
I'd want to know if people can make this themselves, and how easy it is, and what training they would need.
It's not difficult to make. You probably just need someone who's had a little bit of experience making them. So most of the high-risk foot set, it's also called a martini cast. That might be another familiar term. So I would probably say the best thing to do is probably link in with your podiatry people, and then they can guide you. It's whether they've had experience with it or the high-risk foot service as well. So it's a great tool to use in hospital. And obviously in a community as well. Yep. Yeah, all good? Yep. Just grab my bits.
So we'll just invite Frank back just before afternoon tea for a quick session on management of venous ulcers. Please welcome Frank back again.
The information train keeps going. We can't stop it. All right, so talking to you now about water, the second part. We've had fire with the cellulitis, now talking about water with venous leg ulcers. All right, let's talk briefly about underlying etiology. Development of venous leg ulcers relates to a failure of the venous system of the lower leg. It's a chronic inflammatory disease related to a number of factors, but one of the most common is damaged vein valves, one-way valves. When our heart relaxes, our blood tries to run back into our feet, and gravity tries to pull it back there. Our end diastolic pressure from our heart is not high enough to keep the blood from running back down our leg. But fortunately, we don't end up with blood boots. We've got one-way valves that shut and stop that from happening. Now, if they begin to fail for reasons like being damaged by thrombus from deep vein thrombosis, thrombus organises, covers the vein valve, sticks the valve to the wall, or fibroses the valve to the wall, and therefore it can no longer shut when that heartbeat relaxes. You might just have bad genetics, and we see this disease with those that have predisposition to venous disease, sort of manifest this in their sort of late 20s, early 30s. And or heart failure or anything that compromises the pump can lead to a problem. And when that happens, we get retrograde flow of blood in the venous system, and that can act like a water hammer, stretching the walls of the vein out. And of course, that can eventually compromise the integrity of the walls of the veins, and we get extravasation of blood and blood products out into the interstitial spaces, which the body doesn't want there. It goes, oi, you're not meant to be hemoglobin, get out. And so it kicks off an inflammatory response, and we have problems there. All right, so the other things that can contribute to poor venous return is inactivity of the calf muscle pump. So an ally to fighting that gravitational pressure is our muscular system and our fascia. And when we contract our muscles and move our muscles, we are contracting the veins and the lymphatic system within our body, and that shunts that blood in that one-way direction. So if we've evolved a sedentary lifestyle because of ageing, injury, or occupation, you're standing around in one place for an extended period of time. We all know there are plenty of occupations that do that to us. We're going to have a compromised calf muscle pump, and we will see varicose veins and venous disease more common in this population. All right. Pregnancy can contribute to it as well, and we're also learning more about other hereditary conditions such as May-Turner syndrome, which is where you can see here that the right iliac artery is crossing over the left iliac vein. And I'll see if I can get my pointer working. I wasn't very good at using it earlier, but there you go. Way! All right, so right iliac artery crossing over the left iliac vein, and it causes that imposition or that almost like near occlusion, right? An obstruction. And you can understand then that if there's blood trying to get back into the inferior vena cava, and that's the sort of amount of hose aperture that it can get through, then it's going to be compromised, and we'll see hypertension form within the body as well. So we often see this in deep venous disease, and we're looking a little bit more about this in patients where we can't quite figure out where this is coming from. All right, but any condition that involves additional weight across the abdomen that will can compromise the venous system and also the lymphatic system, which can contribute to this condition. All right. So some symptoms of venous ulceration or venous disease. We have hair loss and dry skin, and that manifests or comes about as a result of that chronic inflammatory state. Okay, the organelles and the organisms are compromised, they're damaged by that chronic inflammatory state, so your hair follicles and the sebaceous glands that are associated with them disappear, and therefore you don't get any oil or sebum being excreted onto the skin and keeping the skin nice and soft and supple. The fluctuation in edema pressures in the interstitial spaces can cause this rending and tearing, and over time your body will react to that like an injury and begin to scar up the interstitial space. And this is where you get that lipodermatosclerosis, which is that hard, woody, textured tissue here. So we can see we've got this lovely, nice, soft, springy tissue, and as we go down the ankle, we get into this really hard, woody kind of tissue texture. I'm sure we've all seen that in patients at some point. And that's sort of also what can contribute to that classic champagne leg-like appearance, where you get this ring of lipodermatosclerosis in the patient, causing that hard fibrotic circumference. Varicose, hemosiderin staining, so that lovely port wine discoloration that we see there is a result of that hemoglobin breaking down in the interstitial spaces by that inflammatory response. There's a direct correlation to the depth, colour and extent of the hemosiderin with the chronicity of the disease. Lots of circumferential hemosiderin staining, very chronic, long-standing venous insufficiency, venous hypertension. Okay, we've got varicose veins. That's a pretty easy giveaway, big, large, bulging veins under lots of pressure. And of course, the final sort of sequelae is wounding and ulceration. Most commonly in the medial side of the leg, but not always there. I've seen, errant venous pathways that wend their way around the leg and end up on the lateral side, and you get this really focal spot of hemosiderin deposition in a wound in that area. So it's not always on the inside, but we have the big, great saphenous vein that runs along the inside of our leg, and so naturally these ulcers are most common on that medial ankle area. And also, funny enough, I think because of that May-Turner's relationship, I tend to see them more often in the left leg than the right. You can observe your own, but that's what I'm finding. This is going to go a little bit over time, and I apologise for that. So the easiest way to diagnose, or the most common entry point for diagnosis of this beyond identifying those physical symptoms, is a duplex ultrasound. It's non-invasive. We do need the patient to be either tilted or standing up for the sonographer to see that the blood's flowing in the wrong direction every time the heart relaxes. And that tells us that one-way valves are not working properly in there. So it's not a DVT screen. That's looking for thrombus within the venous system, and that can be done lying flat. But this needs to be done with the patient standing up. So the GP needs to very specifically order a venous incompetence study. for these patients, and hopefully the sonographer will know what that means. Then there's CT venograms and MRI venograms, which you tend to do for where we've got occlusions, as you can sort of see here. This is a venogram where we've obviously got a chronic occlusion in the pelvis there. Venography, which is where you pop a wire and a probe up the inside of the vein in the legs and have a look at what's going on there. And we've got endovascular, it's not going to work, ultrasound as well. So we can actually do an ultrasound inside the vein and see where it tunnels down and closes off. Oh, one final point is make sure you've excluded peripheral arterial disease, because as the following slides are going to tell you, that's going to limit how much you can attack this with compression bandaging, which is our compression therapy still remains our #1 treatment for this disease. All right. Just very briefly, in context of dressing advice for these wounds, they tend to be highly exudative and they're often quite prone to bacterial colonisation. So stages or intermittent use of antimicrobial dressings and antiseptics may well and truly be warranted in these patients, and in fact prolonged use may actually be indicated, but again, follow your standards, follow the protocols and policies of your institution for that. Secondary dressings need to manage that exudate. I probably haven't harped on about that chronic pro-inflammatory exudate, but it stands to reason that if I've got a chronic inflammatory response in the interstitial spaces, that kind of toxic exudate is going to be coming out of that wound, and if that sits in contact with the skin, it will damage and denude the skin and also potentially extend the ulcer, and it will certainly extend the life of the ulcer, which we don't want. So exudate management is pivotal in these patients, in particular looking for dressings that will wick it away and keep it locked in the dressing and not in contact with the skin, because we often use these compression bandages for extended periods of time. We don't tend to do them daily unless things are really, really severe and dire. All right, compression therapy, bandaging, I tend to advise do that early in the acute phase when there's lots of exudate, so that you're not ruining someone's garments. Also, compression garments don't tend to deal with the bulk of the dressings that you're dealing with, and that's telling me to shut up. So bandaging, you can dispose of it. It's something to keep in place. The other thing I really like about bandaging, you're technically doing a custom cast, a custom compression cast or a custom compression garment every time you do the dressing. So it's a great way in that early acute phase to get the circumference of the leg down to that kind of stable point and also deal with the exudate that you've got coming out of these wounds. Once you've got the exudate under control and you can get a very low profile dressing, or the wound's healed, even better, then we can progress to use of compression garments. Again, you're going to want no lag time between that transition between them having the compression garment on, the compression bandaging on, and measuring and fitting them for the compression garment. Right? We want their leg at that stable baseline circumference, so it's not sort of the edema is not encroaching and causing problems there. There are some surgical interventions available for this disease. We can ablate superficial veins, that is, destroy superficial veins that are not working properly. The concept there is that you reroute the broken or damaged pipework to pipework that is working. I have seen over time endovenous ablation become undone or new pathways emerge, which end up, unfortunately, also being incompetent. So they don't tend to grow new pathways with new working one-way valves, unfortunately. For those patients with those proximal problems, we are doing stenting and venography with these patients, but that's not fraught without problems as well. At that point, the patient's then condemned to having blood thinners for the rest of their life. So there's pros and cons with those sorts of things as well. We are toying around with surgical debridement and grafting of chronic wound tissue and using tissue matrices and those sorts of things as well. And look, in summary, venous leg ulcers are caused by underlying venous disease, which is a chronic inflammatory disease state. You need to treat that underlying venous disease to facilitate wound healing. Compression therapy remains a key element for that to get better. You need to exclude peripheral arterial disease because you obviously, understandably, you apply compression to tissue that doesn't have sufficient oxygen and nutrients, you're going to create more problems, new ulcers, etc. Pain and comfort is a major consideration and a key point to getting a patient to be compliant with compression therapy that you initially apply and also going forward once you've healed the wound. And application requires that training and familiarity with bandaging systems, and also then if you're going to prescribe compression garments, there's a degree of familiarity with those as well. There is this fantastic guideline called the STRIDE guideline. If you look that up, it's got a lot of really meaty content in it about prescription of compression garments and functionality of compression garments, so STRIDE guidelines. And of course, referral to a vascular surgeon if you think that you are dealing with venous disease. Thank you very much.
Thank you. Can we just have you back, Frank and Sarah, before you run away? Thank you, everybody who presented in our speedy presentations, because they were very speedy, and good on you for talking so fast. We know talks and presentations take time, so we'd West Australia would like to thank you.
Oh my gosh, thank you.
Appreciation.
Thank you very much. Wow.
Thank you. We'll now break for afternoon tea. If we could all be back, please, and seated promptly for the final session, the last sort of hurrah as we come to the finish. 3:20, please. So please enjoy our afternoon tea.
ding, ding. I can introduce myself, it's all right. I'm up here. Okay, let's do the final lap. Won't that be fun? I think it's been a really good day. So my talk is on heavily exuding wounds, which is fitted with Frank's talk, Sue's talk, a few of the talks. And we know that we want moist wound healing, but we don't want wet wounds. So moist wound healing, when we have an injury, we have a natural function of, in an acute wound, that we have a flow of fluid to it. And during that inflammatory response, the blood vessel walls dilate, allow leakage of protein and cell-rich fluid into the wounded area. And we have our moist wound. And as healing occurs, exudate usually decreases. But if exudate levels tip the balance and the wound becomes too moist, the wound can deteriorate and become a chronic wound. For example, donocytes, pilonidal sinus and skin tears. There's another donocyte that has got a little bit of hypergranulation. The one below is a skin tear and a pilonidal sinus that should have all healed long ago, but one thing in common, they had too much exudate, and that was probably the thing that converted them into a hard-to-heal wound. So exudate in chronic wounds, I think Sue might have talked about this. There's high levels of cytokines and MMPs. There's a heightened inflammation that contributes to excess exudate production. That equals more inflammation, and that equals more exudate. So we have a really vicious cycle of being fueled by exudate creates inflammation, creates exudate. And we discover then that the exudate becomes a wounder, not a healer. So that cycle needs to be stopped. So we've looked at also some of the effects of too much exudate, where it damages the peri-wound, causes maceration, excoriation, denudement, enlargement of wounds. Bacteria love wetness, especially Pseudomonas. It gets off on a wet wound. So if you've got patients that are frequently colonised or reinfecting with Pseudomonas, I bet you anything they're wet wounds. And your weapon against that is to manage the wet. So we have an increased risk of infection, which gives us more exudate, again, another cycle. And we have biofilm residing. And it promotes hypergranulation, as I talked about earlier, and stalls the healing process. So look at the damage that has been caused by too much exudate that has not been managed well. We've got a chronic erythema and a reddened area, the middle wound, where we've obviously got an itch as well, and someone's tried to tame it down with a bit of zinc. And look at the wetness in this other wound here on the end that looks just hideous. And you know what? That would be so painful. So some of the causes of increased exudate could be local factors like infection, the presence of biofilm, foreign body, deeper infection of osteomyelitis, and edema. Characteristics of the wound itself. It might be a large surface area, it might be a deep cavity. The deeper the wound, the wetter the wound. Could be systemic factors like CCF, some medications and malnutrition. And some practical factors, the position of the wound. So obviously if it's at the end of the body on the foot, you're going to have an edema and perhaps more wetness. And it could be non-compliance, or it could be simply poor dressing choices. So there's that wound again. Look how wet it is, and that's that slimy wound that had a good biofilm. Now I've got the other half of Frank's photo. So this was a lady that was in my clinic that was saying, I think I'm allergic to my dressing. And this was the dressing that was on her. And she had a little low-level silver mesh with a paper, shiny paper, melolite dressing to the square. I said, you're not allergic to the dressing, you're allergic to your exudate. So look at this wound, obviously is a very wet wound, and look at the dressing that's on it. Again, that shiny paper. And hydrocolloids are fantastic, but not on a wet wound. So wounds that exude a lot include deep wounds, as I said before, stage 4 pressure ulcers, larger abdominal wounds that may have dehisce, these are just examples, large surface areas, burns, heavily colonised or infected wounds, that's our natural response to have more fluid leaking out, osteomyelitis, venous leg ulcers, lymphedema plus a wound, and dependent edema plus a wound. and James is going to talk about that. Any wound that's chronic is going to have a little bit more exudate than normal. So the management of these wounds is recognising that exudate is a symptom of something that's happening beneath the surface. So we need to diagnose and treat what is going on beneath the surface to cause that excess exudate. So if we have a wound over a bony prominence and there's an enormous amount of exudate that doesn't quite match the size of the wound, and you're near a bony prominence, suspect osteomyelitis. So when it's just disproportionate to the wound size, something deeper lies beneath. We might need to use compression to reduce edema. Lower limb vascular assessment has to happen first, as Frank said. And we need to then dress with good exudate management products and ensure that we do it frequently enough. Sometimes in those early phases of an imbalance, Monday, Wednesday, Friday does not cut it. If they need daily, they need daily. And then, of course, good skin care that's going to protect them while you're trying to stabilise the wound. And if appropriate, it might be a wound that's suitable for negative pressure wound therapy. So when we look at dressing function and moisture balance, any of you that know me, you've seen this little slide where we've got a continuum of exudate within a wound. We have dry wounds, we have moist wounds, which is our optimal level of healing. And we've got moderately exuding and we've got heavily exuding wounds, and our dressing products fit above them. So for dry wounds, we have our hydrogels. For moist wounds, we have products like thick hydrocolloids. For our moderately exuding wounds, we have foams like a Wet-X that sucks it all up. And for our really wet wounds, we have alginates and gelling fibre dressings, so they're highly absorbent dressings. So when we're looking at managing wounds with a high level of exudate, we're looking up this end of the field. We are not looking up the other end. And more importantly, we're probably looking up this end for the highly absorbent dressings. And the same applies with our antibacterial dressings and moisture balance. So for our dry wounds, we have a number of products that will keep the hydration level up that are antibacterial. Same for our moist. These products will be better served on a moist wound, not a wet wound. We've got foams and other absorbent silver or iodine-released dressings, and then a number of highly absorbent dressings that also are antimicrobial. So again, we're looking up here, and more importantly, probably up here. So think about the secondary dressing you're going to put on. So if you're looking at alginates, hydrofibre, gelling fibre dressings, you need to put something over the top of them because they're not a one-stop shop. And I always suggest that you put lots of gauze, and lots and lots and lots of it. It's cheap, it's readily available, highly absorbent, breathes, and then you think about your next dressing over the top, which will probably be an absorbent pad. And the message here is no low adherent shiny dressings on wet wounds. So don't forget to protect the skin. It's a repeat slide of what we had earlier on. And if there's itch, treat it, because itch will interfere with healing. So in conclusion, respect that exudate can be both healing and harmful. So we want moist wound healing, but we don't want wet, wet, wet. We need to manage that harmful exudate. Treat the underlying cause that's driving it. Do not skimp on your absorbent dressings. And if it needs daily, do it. Once stable, then the frequency can be adjusted. And if this pathway is followed, healing will be enhanced. Oh. 1 minute to go. James, you're up next.
Here we go. Okay, I'm going to talk on lower limb edema. So it's a condition characterised by an excess of watery fluid collecting in the cavities or tissues of the body. So chronic edema, what is it? It's a bit of an umbrella term, but basically we've got persistent edema for more than 3 months and causing swelling in the legs. So the fluid accumulates in the extravascular space due to an imbalance between the hydrostatic pressure gradients, which is the pressure being forced through the venous wall, and pressure gradients of the blood vessels and the tissues. So with gravitational edema, we've got gravity acting downwards. So when we've got dependency, dependent legs, we've got extra pressure, extra hydrostatic pressure, and venous hypertension is going to ensue. So any disease of the heart, lungs, kidneys, liver, vascular or lymphatic circulation can cause edema. So what happens to the skin? It becomes dry and itchy, and it's bound to become itchy because, as we've heard before today, there's lots of waste products sat in that interstitial tissue. So waste products are going to cause pro-inflammatory responses, irritation, inflammation. We get itchiness. We get that increased risk of bacterial and fungal infections. The skin will stretch and become thinner and may blister and break. And fluid is therefore going to leak out, and we get those weeping wet legs. And this brings an increased risk of cellulitis. So if we're getting any breaks in the skin, of course, that's a route for pathogens to move through and cause that infection of the cells, cellulitis and underlying tissues. So what happens to the skin and wounds? So prolonged edema triggers chronic inflammation. Elevated cytokines stimulate the production of tissue-degrading proteinases and elevated MMPs, which we've talked about today. We get thickening of the skin. Skin folds and fissures, again, can harbour microbes and cause skin infections. Hyperkeratosis, so that build-up of epithelial cells and epidermal layers. Papillomatosis, which we've got a good picture of there, where you get these nodules that are full of proteins that you get with chronic edema. You'll see this a lot with lymphedema in particular, and results in unhealthy skin, difficult to keep hydrated and healthy. So toxic waste lies beneath the surface, which is what we've said before. Reduced blood flow to the wound will also occur. So if you think about what's happening with edema, you've got your arterial blood flow source on one level, you've got your outer skin with a wound, and you add in edema, what are you doing to the proximity of that source of oxygen and nutrients? You're moving it further away. So again, you're getting reduced blood flow, reduced oxygen, reduced nutrients, and ensuing wound chronicity will occur. Obviously, you're going to get increased exudate, increased hydrostatic pressures, increased venous hypertension. Is going to push all those extra proteins, blood, and other cells into the surrounding tissues. And that inflammatory cycle that delays healing that we've talked about quite a bit today, that pro-inflammatory response that we get purely because of the presence of things that shouldn't be there. The immune system recognises we've got things there that shouldn't be there. So off we go. Inflammation, try and clean it up, try and get rid of it. And because the conditions don't change, we're just in a pro-inflammatory cycle. And this will also alter pH. And often the edema is missed as a factor affecting healing. So we can get a bit caught up sometimes in what dressings to put on, But if we've got lower leg edema, it doesn't matter what dressing you put on until you manage that edema first. It's the key treatment. Frank mentioned before, it's still the gold standard treatment for peripheral vascular disease and venous ulcers. So managing, it's important to identify and treat the underlying cause of edema first, because as we know, there's many different causes. Good skincare, twice daily moisturising, has been proved in terms of reducing things like skin tears. It can reduce skin tears by up to 50% by just doing that twice daily moisturising of elderly skin, particularly lower legs and feet. And compression, as we've said, to reduce that edema is essential. And doing a vascular assessment and a neurovascular assessment that we can do at the bedside before we refer on to the experts. So obesity and edema. There is an obesity epidemic, like we've heard earlier. So the weight of the abdominal fold compresses the thighs and groin, causing a back pressure on the venous and lymphatic vessels, leading to edema. So Frank's presentation earlier that showed the proximal veins that cross over in the lower abdomen, if you've got that extra weight and pressure around the abdomen, that's pushing on those proximal veins, causing the lumen to be smaller, which then needs more pressure, i.e. hypertension, to get that blood flowing through. So increased hypertension, increased venous hypertension, increased hydrostatic pressures are going to lead to the venous system leaking proteins, blood, cytokines, all these cells into the interstitial tissues, causing chronic edema if it's left unmanaged, if we're not getting in there early enough. So the first evidence of a problem is often cellulitis, and this can become a cycle, as you've probably seen with people who've had cellulitis. They don't normally just get it once, it recurs. So to conclude, chronic edema impacts on healing, skin integrity and quality of life. Important to diagnose and treat the underlying cause. And a vascular assessment and/or referral is really important to ensure we safely compress these lower legs, but remembering that compression is always what we're aiming for. Skin hygiene as well, emollients and preventative care need to be ongoing, because these legs are often high risk for getting these conditions, dry skin, repeat infections. So we can't forget skin hygiene and skin care, and trying to promote healthy lifestyle and weight loss. And that's me. Thank you very much.
Oh, we're galloping. I've talked so much today, I'll need a drink at the end of the day. Right, what am I talking about? Pressure injury. So, what's the first thing you do when you've got a patient with a pressure injury? Take the pressure off! Yay! So, pressure injury, what is it? So it's a localised injury to the skin or the underlying tissue, usually over a bony prominence as a result of sustained pressure, including shear and/or friction. The blood supply to the tissues is restricted, cells are deprived of oxygen and nutrients, and we have localised area of tissue necrosis. So the skin dies basically because of pressure, no blood flow, tissue death. Oh, I forgot to say no to saving my timings. It's automatic. So shear results from two opposing forces. So when the patient slides down the bed, which provides resistance, and the capillary blood vessels are kinked and damaged, resulting in tissue ischemia and possible undermining. I'm going to have to keep up with this, aren't I? So friction is the rubbing of two surfaces together in opposite directions. Come back, you little devil. Like when the patient slides on the bed sheets, and it provides a bit of resistance also. And that damages the epidermal and the dermal junction. And especially with ageing, that epidermal junction flattens. So we've got these little reti pegs that attach the epidermis to the dermis with the pegs in between. With ageing in particular, they flatten, and so you have that movement of skin, and that's why people are prone to skin tears. So we need to just be reminded of some of the pressure points. And I like this picture because it shows all sorts of positions on your side, on your back, 30 degrees in the bed, maybe a bit higher, and sitting in a chair. So I like putting these pictures up too because many, many years ago, we had a device like Captain Snooze must have now that measures your pressure points. And we went around and mapped the pressure of my body on lots of surfaces. And it was a really interesting exercise. So this was our old standard mattress before we replaced our mattresses, which mattresses have a life of 5 years in a hospital. And as you can see, my shoulder blades, my butt, and my heels. This is a challenge, this little thing, isn't it? That's me sitting in a standard high back vinyl chair, padded vinyl chair. And cop this one, young Harry. That's me on the commode. Look at my heels. Look at my heels. So that one makes me feel a little guilty to my times back at the bedside, getting the patient in the shower. I'll be back in a minute, and you run next door and you shower someone else. And, you know, in a minute ends up being, 45 minutes. And I felt guilty looking at this, thinking, oh my God, these pictures don't show us duration. So add time and prolonged time, it shows you the pressure points. So in a nutshell, the treatment of pressure injuries are as such. The primary cause of injury is pressure, so in order to heal, we have to get rid of the pressure. If the wound is on the sacrum or the ischial tuberosity, you all know where that is, those bones, the sitting bones. If you see someone with a wound there, it's from sitting. So we need to make sure we eliminate sitting in a chair or have them on a really strict seating schedule where we will have it maybe for meals only and they're back to bed. We need to optimise their nutrition, so some sort of nutrition assessment using a MUST tool, review of the support surfaces, their bedding or their chair, wound assessment and staging, wound management, and you'll note that's right down the end. Whoops, and I thought there was one more. Sorry, we'll go through that. Do you want to take a photo? I can go back. There you go, take a photo, quick. So, looking at nutrition, we're just going to go quickly through all of those. Risk of pressure injury increases with poor nutrition. So our international standards state that one of the biggest risk factors for the development of a pressure injury is poor nutrition, which I find interesting because I think the pressure comes first. But it's up there. I'll honour and respect that. So we need to do that screening for their nutrition, offer high calorie, high protein nutritional supplements, and make sure it's palatable. Nothing bores me more than patients in hospital that we get the dietitian in and they've got all these drinks and they're all lined up on the overweight, and at the end of the day they're all going to go in the bin because they're sickly, sweet and not palatable. So it's got to be something that they're going to drink. And if they're not drinking, we need to report it. So studies have shown that arginine, vitamin C, vitamin B and zinc significantly improve healing in long-term nursing home residents. So we need to think about supplementing them because we know, we like to think that in residential aged care facilities our patients are getting plenty of food, but they're probably under par. They don't have the same appetite that they used to have either. So looking at some of our support surfaces, we should be using a dynamic support surface, not a static one. Static one's like a blow-up lilo, doesn't do much, just lifts them up a little bit higher, but it doesn't relieve the pressure, whereas these are more dynamic. Look at your seating surfaces. Don't sit them in a standard vinyl chair, like my butt was, because it will break down. Look at heel pressure relief. This is a bit of a bane of our existence in the hospital. As we said before, we find the heel lift boots up on the cupboard, looking really nice, gathering dust. And be reminded that sheepskin boots do not relieve pressure, they reduce friction and shear, and a number of residential aged care facilities use them, but they're not going to take the pressure off, they're just reducing shearing forces. I always say it's inexcusable to get a heel pressure injury, even if you've not got pillows or cushions, because you can roll something up and pop it under the heel while you're waiting for the cushion in the black hole to come back to your ward. So just the staging is useful to understand the degree of injury, and it also helps us to understand what dressing to put on the patient's wound. So stage 1 is non-blanchable erythema. You press it and nothing happens. When it's just blanchable erythema, a reddened area, you press it, it goes white, and the colour comes back. That is not a stage 1 injury. So you press it, nothing happens, stage 1. Stage 2, you've got a superficial ulcer, crater, or a blood-filled or ruptured blister. Stage 3, we're getting into the deeper tissues, we're going into the subcutaneous tissues. No visible tendon or bone though, that's exclusive to stage 4. Then we have unstageable, which means you can't see the bottom of it. So you can't tell how deep it is, therefore it's unstageable. And suspected deep tissue injury is blood-filled blisters. We know there's more injury depth with that as opposed to serum-filled. Or intact skin where we've got this purpley, bluey, unhappy colour. And then a new staging is mucosal pressure injury that's to do with medical-related devices. And because of the location of the injury, you can't actually give it a staging. So again, this is my little chart that I put up. We're going to choose our dressing according to the moisture balance in the wound. If it's dry, we're going to rehydrate it. If it's moist, we're going to keep it moist. If it's moderately exuding, we're going to use products that manage exudate. And then if it's heavily exuding, we're going to use the big guns to mop it all up. And once again, the same applies to our antibacterial dressings. Make sure we use them as they're intended. So what do you do with those black hills? Nothing. Come back. So do absolutely nothing with them until you know that there's blood circulation to support healing. So no getting out that gel and trying to rehydrate it and take that necrosis off, because what if you convert it to wet gangrene because they've got no blood flow? So you do nothing until you can phone a friend and get someone to assess the circulation. And if there's circulation to support healing, then you might proceed to do something. But you do nothing until you know there's good circulation to the limb. So referrals, phone a friend, get your dietitians involved. Occupational therapists are my best friends in the hospital to come in and assess the patient for seating, the surface that's going to give them the best pressure relief and keep them. We know we don't want to keep them in bed, but we don't want to sit them out for a long time, and we don't want them on a hard surface. Podiatry for heel pressure injuries in patients with diabetes or PBD. Vascular surgeon, vascular nurse practitioner. Plastic surgery for grade 3 or 4 pressure injuries that might need some reconstruction. And infectious diseases who might deal with deeper infection like osteomyelitis. And you might even think about some wound management clinics if you should need. Don't forget, we've got some guidelines that are very useful and available on the intranet as well. And that's it. Timer. Way to go.
So, hello, my name's Sue. I'm just going to give you, I've got the last session of the day, the hardest session of the day. I'm going to make this the shortest 10 minutes of your life, not the longest. So anyway, I'm just here to talk about negative pressure and hints and tips, and really I think we can get this done pretty quickly. But there's a few things that we really need to look at that are real basics when it comes to negative pressure. One of the first things is know your device. So actually know what you've got to use. There's different devices on the market, some with dressing, some are designed as incision line management, so they're not designed for wet, soggy wounds. There's disposable devices, so which one can you tell your patient to throw out at the end of the period, and which one do you want them to not throw out? And believe you me, I have had to, in a previous life, go dumpster diving for some $10,000 devices that someone put in a bin because they thought it was disposable. So know your device, know what the wound is that you're actually putting it on. And there's a lot of different devices out there. Get in touch with the companies because they're there to support you. So the other thing is, what do you want to use it for? And it's something that you often say, yes, we're putting negative pressure on. what do you want to achieve? And people look at you and go, well, I want to heal the wound. But there's a lot of considerations, you know, if it's an incision line, is it supporting that incision line, reducing edema, maintaining that lateral tension, holding that together? Are we looking at an open wound, a cavity wound that we want to stimulate granulating tissue? We want to reduce the overall size of the wound. Is it a highly exudating wound and we want to manage the exudate as well? Because something to think about when you're looking at negative pressure wound therapy is that it can do all of those things for you. It's not just about exudate. It's not just about granulation. It can help you with all of those things, but you need to know what you're wanting to use it for. And I think that's really important, is what is the goal that you want to achieve? And something else that you need to look at is your patient. You know, it's not just the hole in the person, it's the whole person and what's going to be the best therapy for them. So I think that's something that we really need to look at. The other thing is, just in the hints and tips, is where is the wound? You know, is it on a foot? Is it on a mobile area? How mobile is the patient? Are they getting up and walking around? Is it someone at home that's going to work? You know, what? So look at our device, look at our dressing. So, you know, have a look at where it is, do some planning, and I think that's one of the really important things as well when you're going to actually do your dressing, is have a plan in your mind about what you're going to do. Where you're going to put the track pad? Are you going to use foam? Are you going to use gauze? How much peri-wound protection do you need to do? And look at the devices that you've got. You know, again, disposable device or the non-disposable, how much that canister is going to carry. So look at all of those things. But when you're going to do your dressing, and as I say, when you're going to do your hunt and gather to get all the bits and pieces, that's when you can formulate a bit more of your plan as well. So make sure you've got the dressing pack. If you need some hydrocolloid for that peri-wound protection, make sure you grab that. Get your sterile scissors, your sterile gloves, you know, grab an extra pair. If you can have an extra pair of hands around while you're doing the dressing, that's a really good thing as well. So get everything together. Hopefully you would have given your patients some pain relief pre this, or had a chat to them if they're in the community. Give them a call, I'm coming to do your dressing. If you need some pain relief, take it before I'm coming, so that they're organised. Get it all out, cut your drape. So whichever brand of product that you're using, the plasticky layer that you're putting on top, make sure you cut it into smaller pieces. It's much easier to handle. Cut the corners off because round edges don't roll back as much, so you're going to get better longevity out of your dressing, particularly if your patient's moving around or it's on a movable area. And cut some strips. So the strips that you can see that we've cut there, they're your second pair of hands when you don't have another pair of hands. Cut your foam as well, and the foam needs to fit like a peg in a hole. It needs to sit up a little bit higher so that when you actually put your drape, cut your hole and pop your negative pressure on, it sits flat. If you're using gauze, you need to really layer the gauze, and the gauze needs to come up as well, because again, when you turn that negative pressure on, it will sink down, and you want to try to keep it as level as possible. So do all of those sort of things. Have a good think about where you're going to put your port. You know, if it's on a lower limb, you probably want it tracking up so that they're not going to trip over it. So is it a falls or trip hazard? You know, ask the person as well, which side do you want to carry the bag on? Are you right-handed? Are you left-handed? Different things like that can also help. If you're doing an abdominal dressing, have a look at where they bend, because, you know, you don't want to put the port right where they're going to bend over. So you can always bridge it to the side, you can bridge it above. Again, know the device you're using, know what you want to achieve, and know your patient. So your patient is really important as well. And we need to make sure that we are educating the patient about the device so they know why they've actually got this dressing. Why do I have to carry this machine around? Do I have to plug it in and charge it? Do I have to do anything else? You know, if it alarms, what do I do? So just make sure that they have all of that basic information. You know, can they shower with their dressing on? Well, they can't take the device in the shower, but we don't want people soaking in a bath. You know, if it's in an area that is likely to leak because it's on a mobile spot, it's probably best that they leave their shower to the day of their dressing. you know, so you can negotiate all of those things with your patient and have that good patient teaching as well. And if the patient understands that they need this for a short period of time, rather than having regular dressings over a really long period of time, and they understand the therapy, you'll get a lot more compliance from them as well. So, you know, it's not just about the whole, it's about the whole person. Keep them engaged in the situation, know the device that you're using, know the products that you've got available. The other thing is know the companies that support you, because a lot of those companies have 24-hour services that you can call, so you can phone a friend. As Sue mentioned this morning, it's really important to sometimes just pick up the phone. You know, ring somebody that you know is really familiar with the devices or the dressings if you're having any issues. And again, as I said, the company reps, that's what they're there to also support and help you out. Look at that, I've done that in 6 minutes. So it's time for Margi to say.
I won't give up my day talk. Well, we've come to the end of a long day, and I think it's been a great day. I'd like to thank you all for being here. Nothing better than face-to-face. Tell your friends, stop doing it online, come face-to-face. Live streamers, that's not you. I know some of you are far away, so we're glad that you could join us. And thank you to all our speakers. Thank you for the racecourse for giving us the most amazing venue. We're quite fond of it here. And just an announcement, November the 17th is our next education night, and that's around wound assessment and using digital platforms, because there's a lot more of it. We've just gone we've just gone electronic, sorry. But it's bringing in some of the newer ways of doing things and helping us to hopefully integrate it into everyday practice, because I'm personally finding it very difficult with what we're having to deal with at Flinders with Sunrise. It doesn't make me smile because the wound assessment side of it is not pretty. So, you know, we might get some tips and tricks out of that too. So come along. It's a great venue. We're going to be this time at the Highway Inn. We're just doing something a little smaller this time because our numbers have been down. But the minute the numbers come back up, we can go back to the bigger venue. So come along, go on the website, you'll be able to find out all the details, and I'm sure you get an e-blast about it. But thank you once again for all of you coming. You want to say something? Oh, what date was that? Do you want to come on? Come on, use that. Quick.
Sorry, I didn't want to do that.
Yes, you did.
But I do want to give a plug. If you haven't joined, join. Margi knows who you are, where you are, and we have your addresses.
Don't leave town.
That's that. And I just
You
want to
can't.
make sure that everyone is aware that Wounds Australia, I've just got to make sure I get this.
No, you might want to speak up.
Yeah. Oh.
It's pretty loud.
Yeah, so Wounds Australia has the AGM on October the 27th, so you can stream in, or you can actually join in, or you have to join in online anyway from down here. But it's worthwhile just so that you're across the reporting and what's been going on with the national organisation. Again, have I said about joining? Have I said? Did I say about joining?
Yeah, you said about joining.
Okay,
You said again.
all right, so join if you haven't joined. Lovely. You get your little e-blast, you get your newsletter, you get your journal, and you get access to all those fantastic resources that Margi's been flashing up on the screen today. Do it. Do it. Okay? Or we'll send the boys round. Okay, thanks. See you.
We'll send the dad jokes around.
Yeah.
Geez, that'd be torture. That'll make anyone join.
Oh, look, that reminds me. No! So, the Beatles, huge hysteria, arrive in Australia, right? The press arrived to interview them. You know, that huge rally in Adelaide, blah, blah, blah. The press arrived there. John's there, in tears. They said, John, what's wrong? And he goes, a Ringo took my baby. Oh, yes.
On that note, thank you, everyone. Where's Sue gone?